हेलो 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 आ रही है? वहां नहीं बैठ रहा कोई, ऊपर नहीं बैठा। I'll start. Good morning, everyone. We've all gathered here today on this very auspicious day, that is the 37th Foundation Day of Guru Nanak Eye Center. Exactly on this very day in 1986, the identity of Guru Nanak Eye Center came into being as a dedicated tertiary eye care center in association with Maulana Azad Medical College. In view of that, we've planned a very elaborate program for all of you today, starting with the live surgery session, which is being relayed from Guru Nanak Eye Center OT. We have with us two very esteemed and renowned surgeons who have portrayed their surgical skills not only to the Indian community, but also worldwide. We have with us Dr. Sushmita Kaushik today and Dr. Santosh Honawar. Dr. Sushmita Kaushik is an authority in childhood glaucoma. She was invited as a faculty for the preparation of consensus of childhood glaucoma by World Glaucoma Association in 2013, and was also invited to be a member of the Worldwide Childhood Glaucoma Research Network. She's been the Secretary of Glaucoma Society of India and heads the Childhood Glaucoma Department in PGI Chandigarh. She has to her credit more than 100 publications and more than 25 book chapters dedicated to glaucoma. We welcome you, ma'am, to GNEC OT. Madam will be performing a live surgery of bent angle needle goniotomy in a glaucoma patient today. We'll be taking you to the OT shortly. We also have with us today Dr. Santosh Honawar, a man who needs no introduction. From being the best resident in RPC AIMS to further taking heights to training in ocular oncology under Professor Jerry Shields and Professor Carol Shields at Wills Eye Hospital, USA. He currently heads the Department of Ophthalmic Plastic Surgery and Ocular Oncology and National Retinoblastoma Foundation at Center for Sight, Hyderabad, and leads their medical services team. He's organized numerous international conferences to his credit and runs an active fellowship program. He has extensively published in peer-reviewed journals with more than 300 publications and has numerous awards and orations to his name, starting from 1992, which never end. Sir is also currently the editor of Indian Journal of Ophthalmology and has taken IGO to new heights under his tenureship. We welcome you, sir, to GNEC today. Sir will be performing a case of ptosis surgery in OT. So we're going to relay to the OT, and we'll be starting with the glaucoma surgery by Dr. Sushmita Kaushik on bent angle needle goniotomy. I would request the AV team to relay to the OT. We have our residents there who are going to give us a brief detail about the patients. Dr. Shweta, can you hear us?
Good morning, all. Am I audible? Good morning, all. It's a very momentous occasion for Guru Nanak Eye Center. Team Guru Nanak Eye Center is ready to start the Foundation Day, which is being celebrated for the first time. It's the 37th Foundation Day. And our team has worked around the clock, night and day, to make this a success. We have two, as Dr. Anujoon already has said, two specialist experts in their field from outside GNEC. As our residents told me, ma'am, we see all of you all the time. We need now exposure from outside. So keeping in mind our teaching for the residents, we have two experts, followed by inauguration session and followed by a scientific CME. So this is live from Guru Nanak Eye Center. The first case is going to be done by Professor Sushmita Kaushik. And Dr. Shweta, please share the details of the case. Over to you. We'll take the questions. You can just type your questions and we will read them out.
Hello. Good morning, ma'am.
Good morning, Dr. Subhash. Come in.
Yeah.
Dr. Subhash Taria is in the OT. Dr. Subhash, come in.
Yeah. So basically, ma'am, I am reading brief biodata of Dr. Susmita.
It's already been read, Dr.
Oh,
Subhash.
okay.
Now you talk about the patient, Dr. Sushmita, and Dr. Santosh Vanavar's biodata has been read.
Okay. Patient की details कैसे पता?
Shweta, patient details, please.
Am I audible, ma'am?
Yes, you're audible.
Okay, so today we have a 70-year-old female with both a advanced POAG with a 0.9 cupping of DDLS 8 with pallor in the right eye and 0.9 cupping with DDLS 5 and pallor in the left eye. Her vision is 660 in the right eye and 612 in the left eye. PR accurate in all the quadrants. Currently, she is on 4 anti-glaucoma medications in both the eye, including PG analog. And she has an advanced damage in the right eye with slight sparing of the temporal vision in the right eye. She is requiring, we have planned the patient for a left eye bend angle needle goniectomy. Subsequently, after that, she'll be requiring a right trabeculectomy in the right eye, but today she's planned for a left bang, ma'am.
Okay, thank you.
Yes.
And this is Dr. Shweta, our senior resident from the glaucoma services, who's going to be assisting Dr. Sushmita.
Thank you, ma'am.
So can you also show Shweta how Dr. Sushmita would angle the microscope for doing a bang
Yes,
procedure?
ma'am. Just ma'am will be here, ma'am. She'll be demonstrating it.
Right.
Just 2 minutes.
Right.
So, Dr. Shweta, is the patient phakic or pseudophakic?
Yes, ma'am. She's both eye pseudophakic, ma'am.
So for the advanced type of glaucoma, we are planning a trap with a man. Does she have a macular split?
Yes, ma'am. She has a macular split in the right eye.
Okay.
In the left eye, she has an inferior arcuate scotoma. So we are planning for bang in the left eye, ma'am.
We're going to try bang in the left.
Yes.
Okay. Thank you.
In the meantime, I would request the discussants for the glaucoma surgery, Dr. Kirti Singh and Dr. Priya Saraf, to please come on the dais.
I think it's better here. Okay. Okay. So as was shared with you, the patient has been clean draped, the consent has been taken.
Yeah.
She has bilateral POAG and we are doing the better eye, which is controlled with a poor control on 4 anti-glaucoma medications.
Susmita, take mic. Just starting the surgery in next 1 to 2 minutes.
Yeah, Dr. Subhash, if you could ask Dr. Sushmita to tell us exactly what she will be doing with the microscope setting, because that's very important in bang.
Hello, morning.
Yeah, good morning, Sushmita.
Good morning, ma'am.
Yeah,
Right.
we can hear you. Welcome to Guru Nanak Eye Center, your alma mater.
Yes, thank you. At the outset, I can't tell you what fun it's been and how.
Your voice, the audiovisual guys, please, Dr. Sushmita's voice is little muted. No, she's put the mic. Mic is there in the back. Dr. Subhash, Dr. Sushmita's voice is not coming clear. Yours is
Hello, is it audible, ma'am?
better, but little bit more. Yeah, say hello.
Hello?
Yeah, much better. Much better. We
Okay.
can hear you.
Okay.
Yeah,
But
go ahead. Over to you.
I don't think I'm visible, am I?
Yeah, you are very much visible.
Now, okay, all right.
Very much visible.
So good morning, everybody. And at the outset, thank you so much, Dr. Kirti. And I started my journey in ophthalmology in this institution, learned to wield a scalpel. And I can't believe that today I have the privilege of actually coming back and being part of this wonderful foundation day. Thank you very, very much. So this patient has primary open angle glaucoma, advanced in one eye and pretty much advanced in the other as well. So as we know, the main thing that we need to do is get the pressures down. So what we've decided is, since the pressures are about 16 in the right with the macular split and about 12 in the left. So the plan is that we would be requiring a trabeculectomy in the right eye. I don't think we'll be able to get away without it. But we've known that there's a sequential rise of pressure in the other eye. So we thought a good strategy would be to do a minimally invasive surgery, in this case, a bent angle needle goniectomy. You could do a Cahook dual blade as well. The principles would be the same. But a bang is something which is low cost and which is able to be done everywhere, anywhere in the world. Can I have the table down, please? Because the microscope is really high. Can somebody put the table down or the stool up? So I thought we would start with end on. This is the end on view that we have with phaco. इसको ये chair ऊपर कर. Sorry, so this is the kind of setting that you would require. So I need this chair change करना है. ऊपर करो. No, not yet. अभी भी ऊंचा. अभी भी ऊंचा. All right, yeah.
So this setting of the microscope is very important.
Yeah, so, yeah. Right, sorry, all right. So I told that, can you put some visco on the corner? Yeah, so I told the microscope, the camera guys to zoom in on this. So these are things to note. Can you see this?
Yes, ma'am, you're visible.
Yeah. ये थोड़ा इधर करना पड़ेगा कैमरा जैसे बताया था. The camera has to come a little more. So this is the setting when you give me a bud or something. Yeah. When your microscope is in the neutral position, if you can see this before you start with any, so this is the setting which is there right in the center. So you need to look at this, and when you initially start, this is the knob. So you need a tiltable microscope. So this is the knob with which you tilt the microscope away from you and the patient's head as well. So when you tilt, the idea is that you have to look into the angle. And to look into the angle, you need the light to be coming out from the angle into the surgeon's eye. And for this, you have to tell them to be quiet a bit. A lot of noise. So, so this is the eyepiece of the microscope which have to go up so that you can go straight into the eye as one. So the light is going to come from the angle into the eye. So once you've sort of organized your microscope tilt, the next thing we are going to do is tilt the head of the patient. So it has to be end on. So Mataji, thoda sa upar, hanji. So it has to be end on the microscope. One tip is that you don't focus it. Can you see the view through the microscope?
Yes, we can. Yes,
right.
It's very clear.
So when we are doing a phaco, we probably start over here. So one thing about doing minimally invasive surgeries, because the head is going to tilt there and the angle is going to go down. So if you're going to keep at this focus, when you tilt the head, you will have to go right down and there is no play of the microscope. So it's important to start with a focus which is in the iris plane, almost at the lens, so that the limbus is defocused, and then you tilt the head. Mataji, thoda sa aisa. Bas. Now you bring it in. Now I will ask for a blob of cohesive viscoelastic on the cornea. So Sanchita will give me a bit of Helon GV or Helon Pro or something on the cornea. So we make a little mountain up there. So that's why a cohesive viscoelastic is important. You make a little mound. And then with the Swan-Jacob lens, take your first look at the angle.
Can we have the microscope view, please?
Yeah, hata do. Right. Can you see the microscope view now?
Yes, we can
Okay.
see the microscope and the Swan Jacob lens is in.
Yeah.
Yeah.
So this is almost en face, but a good idea
You have to
is,
center it, Dr. Sushmita.
okay.
Yeah.
Is this better?
Better, but if you could still bring it towards the entry point. Yeah, much better now. Yes.
Right. So this is an almost, so like I said, I still have to move it down in spite of a down focus. This would be the en face view.
Yeah.
Can you see the angles now?
Yes, it's
All right.
visible. But for the residents who are watching, if you could just point out the
All right.
markers.
So this is an open angle. The first line that you see is the Schwab's. And then it's a non-pigmented and pigmented meshwork, but this has a lot of iris processes as well. So this would probably explain why she has so much of damage in the presence of even pressures that seem to be controlled. So possibly there might be a dysgenetic element to this as well, because normally we wouldn't see so many iris processes in the angle, right?
At this age, yes.
Right. So this is a little unusual. The other thing to keep in mind is a lot of chronic PACGs after phaco surgery might look like this when it's fallen back, but some parts of the iris is up there, but then we can see the trabecular meshwork well. So the other thing now is, again, I will tilt it. Mataji, aise rakhna. They have a tendency to move down and then your visibility goes a little. So you'd like it completely en face like that. And again, your focus goes. So here we are. Right. So I think we have a reasonable en face view. So now we go on to the entry point. Now, the idea of doing a bent angle goniectomy here is to do as much of the angle as possible. Give me a bud. The other trick is to not enter at the limbus. Look at the limbus vessels and enter in front of it, because if you're going to include the limbus or any bit of the limbus vessels, what happens is the bleed goes underneath the lens. And once you have a little tiny trickle of blood under the Swan-Jacob lens, your view is really compromised. So I'll go anterior, so I can see these vessels still here. I will avoid that and go right in front. So once we go in, and that's about all that's required, I'll visco carboxymethyl to coat the cornea initially. So we'll just fill that. Can you get a patla cannula?
And what is the incision size that you prefer in such cases to maintain a seal tight chamber?
Yeah, so it doesn't have to be seal tight because you need a bit of play for minimally invasive surgery to work. So I use a regular 23 gauge MVR, but just move it a little bit to the side to get a bit of play. This hawa is what we don't want at all. So that's something which is not going to help you. Now I'll need a khali syringe to take all these bubbles out. So that's something which Sister G has to keep in mind. No hawa. So give me a patla cannula with that. So we'll have to remove it because the air goes into the angle and there's no way that we'll be able to see the angle structures. So we'll just take this out. And we'll have to put in some visco again. फिर से दे देना मेरे को visco please. Without the hawa.
So you prefer Elon or you can do with the high whisk, which is the generic Elon?
Yeah, so for the ऐसे रखना माता जी बार बार नीचे नहीं ले जाना ऐसे रखना है very good बस बहुत अच्छे. So ma'am, for the corneal surface I would prefer Helon GV or a Cohivisc. So Helon GV is 1.4, high visc is I think 1.1, Cohivisc is 1.2. So the more viscous the better. So I would prefer a Cohivisc for the surface. अब मेरे को Helon GV दो. But since I have the luxury of Helon GV here, so 1.4 is always nice. But for within the chamber, it's okay to have a little bit of high visc or something just at the angle. So you can see Mataji is bar moving down. And
Can the second assistant please stabilize the head of the
yeah,
patient?
because she is moving. Mataji,
Yeah.
ऐसे ही रखना है.
Sanchita, why don't you hold the chin and the
Yeah.
forehead of the patient to
Yeah,
one
that's right.
side? And
That's right.
somebody hold the hand
Yeah,
of the
that's all right.
patient. Yeah.
Just let me. माताजी ऐसे ही रखना है,
So
ठीक
that she
हो?
is comforted.
ठीक
Yeah.
हो? बस, very good. अब ऐसे ही रखना है आपने. So this is a bit of a challenge, especially when you're doing it under topical, because not just the head, then the eye also moves. So lens, MVR. नहीं, MVR नहीं, मेरे को वो needle ही दे दो. So the next thing I'm going to do is bend the needle. If we are doing a GAT, the next thing that I would do is make the proline bubble at the end. But I decided against a GAT. So for a gonioscopy assisted transluminal trabeculotomy, what you need is a 27 gauge max grip forceps or a vitrectomy forceps, because you need that play. So this is how we bend it, just like a cystotome, except that it's bent towards the bevel, so that the smooth surface is on the outer side and you don't injure the Schlemm's, right? So you bend it towards you about half the bevel and just about 90 degrees, so that you get a nice curve to do your bang. So this is what it will be like. In fact, I would like it a little bit more. Give me another one. So this sometimes is a little smaller than what I would like to go into the trabecular meshwork. So we'll just make another one. This is a 25 gauge, 2.5 millimeters needle, but a 24 gauge pink needle works as well. This is orange. So this is thinner. 26 gauge doesn't work so well because it's not sturdy enough. So I'll make a slightly bigger one here. This is just right. So if you can see the size of this, can you just wash this, Sanjay? Just wash this, so this visco will go. Isko wash kar do. Ready, rakh lo. Isko. Yeah. So now is it visible? The size of
It's
the
very
needle?
well visible. This
Yeah.
is 25 gauge.
This is 25 gauge, 2.5 millimeters, half bevel.
Yeah.
And I will also remove this hawa from here, because I will ask the assistant to, the idea of doing it on a visco syringe is to be able to, ये high visc है कि HPMC है?
It should
Right.
be high vis.
It looks very viscous. पक्का? पक्का HPMC है? नहीं, high visc है ये. ऐसे खींच रहा है? Sure, because I don't want high visc inside the canal. HPMC पक्का?
Can we get another HPMC open,
Get a
please?
fresh methyl cellulose, please.
You know, because what we do with bang is once we make the incision into the Schlemm's, the other thing that we do is also irrigate it a little bit with methyl cellulose to wash it out. But if you put in high visc or sodium hyaluronate, then it sticks inside. Then it's very difficult to take out. So I just want to be sure that it's.
So you inflate the chamber with hydroxypropyl methyl cellulose, right? HPMC?
Yeah, we just coat the endothelium up. We don't really need to inflate it that
Okay.
much. So we coat it and a little bit of maybe HPMC. Okay. Right. So I think we're all set now.
Dr.
That's it.
Subhash, if meantime the plastic people team is ready.
Yeah,
Hill क्यों नहीं रहा?
they are ready, ma'am.
Centering क्यों नहीं
Okay,
हो?
great. So then after this bank
Look,
procedure, we
give
could
me a
maybe switch on and then the
lens.
questions can come in.
Yeah.
डालो. Hill on pro. Just make a. नहीं, ये microscope इधर नहीं हिल रहा बच्चे. Something wrong.
Patient
Now
is
it's okay.
moving a lot.
Yeah. एक minute, ma'am. I'll just set stabilizer. छोड़ दो. It's okay. माता जी, आपने ऐसे ही रखना है सिर को ना, बार बार इधर नहीं ले जाना, ऐसे ही रखना है. बहुत अच्छे. इस साइड में. Very nice. Very nice. बहुत बढ़िया. बहुत अच्छा.
डॉक्टर संतोष सर, हमारे
क्या हो रहा है?
असिस्टेंट चाहिए आपको?
क्या हो रहा है? क्या टच कर रहे हैं? ये कपड़ा आंख पे टच कर रहे हैं? अब ठीक है?
Sanchita, ask
अब
the
ठीक है?
staff nurse to hold the patient's hand and talk to her. She'll be little
अब ठीक है?
comforted.
नहीं, आपने माता जी सीधा नहीं रखना है, आपने ऐसे रखना है, सिर ऐसे ही रखना है, ठीक है? हाँ, बस, वेरी गुड, बहुत बढ़िया. हाँ, बस, कोई नहीं. Give me a bud or something. The lashes are come in the center. Wet कर दो. हाँ, ये wet कर दो. I'm sorry, a bit of lashes in the center. I want out. Okay, all right, better. Now, finally, we are set, I think. Might as well. There's no air. There is air. There's still air. Right. Now, Siruja.
I think an important aspect in these surgeries is the patient positioning and not
Positioning,
just the
yes.
microscope,
Exactly what
but
we're
the
saying.
patient
So,
cooperation.
right.
So I'm sorry, it's usually not so.
No problem. No
thing,
problem.
but
You have
anyway.
15 minutes more, Dr.
Yeah,
Sushmita.
yeah, I'll
So it
take
should be
about
okay.
5-10 minutes
Yeah.
more.
Yeah, yeah,
ये क्या
sure.
कर रहे हो?
So this is exactly live surgery means you're just seeing actually
Yeah,
what
all
are
right.
the issues.
Chalo,
Right.
डालो अब.
So
Ab
as
dalo,
Dr.
iske
Sushmita
ऊपर.
said, the
Yeah,
incision
bas,
is
that's it.
little anterior to the limbal vessel so that there is no
Okay.
bleed or trickle. And the 25 gauge needle, for those who joined in late, has been bent, bevel, half bevel. Reverse of what we do for a capsulotomy. And the span Jacob lens is in, and this entry of the
This is again focus up to see the, yeah. So go right in across, especially if it's faking,
yeah, very nicely visible. Yeah, sure.
and focus down now.
Hmm.
And that little bit of trickle is where the Schlemms is. So we go in from one side. Now this is a visual surgery. This is not tactile. If you feel tissue, you're too deep because trabecular meshwork has hardly any. So this is the trabecular meshwork. If you feel the tissue going, then you're already too deep.
So say it again. It was not clear the first time. This is a what
So
surgery?
this is a visual surgery.
Visual surgery.
It is what you see, but you don't feel.
Okay.
You should be seeing this trabecular meshwork stripping off. But
Okay.
if you start feeling tissue, then you're already too deep.
Right. So,
So
if you're
this is-
feeling tissue, you're too deep.
You're too deep. That is
Okay.
clearer.
So you're just skimming,
So-
skimming and
yes,
visualizing.
you're just visualizing. Can you now inject?
Yes.
Now you need an assistant to inject. So now I'm going to inject into the angle. Inject, please. Yeah, and there is hawa again. Inject. Karo. Nikal jayega. Karo. Inject. You have to be careful with this one thing, which is your sister's prerogative. That hawa nahi honi chahiye, especially in the hub. Karo. Nikal jayega. Karo. Good. Very nice. Very good. ठीक है, छोड़ दो. Now I'll try to go. So that's about 100 degrees done. But what I like to do is go as far as possible. So remember the inferonasal collector channels are the maximum.
Okay.
So the idea of bang is to treat as much inferonasal as is possible, which is what I'm doing. So this is inferonasal.
Incidentally, intranasal goblet cells also are the maximum in the conjunctiva and so are the channels. Yeah.
So you can see now this has opened up.
Yes,
There
it
are
is
no
opened
iris
up. Yeah,
processes.
the
This
iris
is-
process have fallen back.
This
Yes.
is the back of the Schlemms, and if you feel it and you don't go deep enough, there is usually no bleeding, which is good. Now I'll just turn it
So
the
are
other
you
way.
defloring the Schlemms?
Yes, de-roofing maybe or de-flooring, okay.
Okay.
थोड़ा सा और inject करो ताकि ये हवा भी निकल जाए. So I'll do the other side.
Ma'am, for the benefit of the residents, can you explain the difference between goniotomy and goniectomy?
Okay, so in goniotomy, just a sec, let me get this hawa out. All right, let's try and do some Top Gun without it. Right, very nice.
Got it.
So now you can see the cut and the non-cut end well, right? So this is the cut end. This is the non-treated end.
Yes,
So
yes.
now I'm going to go, be sure that you move your hand so that the back of the needle is parallel to your globe. See that? Now this has opened up even more.
So you have
supranasal
entered
duct.
the Schlemms canal, right?
Yes, we
Okay.
enter it, remove the
So
trabecular meshwork,
basically you remove the floor of the Schlemms canal, but
Yes,
the roof
and
is still intact.
remove the trabecular meshwork.
The
Basically,
trabecular
the
meshwork
trabecular
and
meshwork.
so the juxtacanaliclar trabecular meshwork, Schlemms canal, the uveal
Yes.
meshwork is all gone.
Is all
But the
gone.
roof
Now
is
there's-
still there, and the
Yes, of
bleed
course.
tells you also that
There is a
is
bit
there.
of outflow. So we've done about almost 180 degrees, maybe a little short of that, and a bit of bleed there. Sanchita, if you're smart, let us try some more.
So can you
Hold.
just explain the question of goniectomy and
Okay,
band?
ma'am,
Yeah.
let me just finish with
No
this.
props,
Wait, so
no
just
props.
inject it,
Yeah.
inject more. I'm just trying to treat a little more. Sanchita, can you hold the eye at 9 o'clock and move it down towards 6 o'clock? Rotate it down. Can you do that? If you can do that, then we'll do a little more if possible. Otherwise, we'll leave it here. I'll just try to go a little more than 180 whilst it's being done. हाँ कर दो, ठीक है. Nice, nice, sister. Sanchita, can you hold it? Hello? Hold, rotate down towards 6 o'clock. Hold the eye at 9 o'clock with the forceps. No, no. Hold the eye at 9 o'clock with the forceps and rotate it down to 6 o'clock. Do you understand? So that, yeah, that's right. Perfect. Very nice. So I've gone beyond. Yeah, good, Nani. Hold it. Chod, Nani. Good. Yeah. Okay, anyway, that's all right. Sometimes you can go beyond 12 o'clock as well, and you can do more than 180. Right, so give me some visco. I'll just tamponade it a little bit and also open up a little bit of the schlims. Okay, here we are. So a little bit of tamponade here. So just move the bleed out of the angle. Just that.
Okay.
And we could do a bit of IA to take the bleed out, but maybe I'll be able to visco express it. Anyway, as long as it's out of the angle, we're all right. Sidhe ho jao, Mataji. Good. Bas, badhiya. Very good. So now I can tilt the, okay, ma'am. Now goniotomy is slicing the trabecular meshwork, and it works in a growing eye because it's elastic, and the growing eye will keep the leaves of the trabecular meshwork apart. Whereas in an adult eye, which is not growing and not elastic, if you just cut a hole or cut a slice in the trabecular meshwork, it will obviously fibrose. So the idea of a goniectomy is to cut a little bit of the trabecular meshwork, a strip of trabecular meshwork. This I haven't done. This is GNEC.
That's okay. See, these are all learning curves. It's all right. We're all residents. We have residents who are doing good.
I know.
This
A
is the old
surgeon
age
who
of the
doesn't make
patient.
mistakes is a surgeon who doesn't operate. So that's all right.
Yeah.
This is a very minor mistake.
True.
Also,
Nice.
it's a 70-year-old female, so I'm sure the
And
conjunctiva
our
must be tried.
conjunctiva,
Yeah. You
Sushmita,
mean
you'll be
iris
finding
repositor?
it's very different. We have a very sick
Repositor?
conjunctiva patients.
Repositor. So this is the other reason why a bent angle or an angle surgery is a good thing to do if your patients are already on 3 or 4 drugs.
Yes.
Because even if you reduce the amount of drugs that you're in, your subsequent trabs are going to be much better.
Right.
Repositor? Okay.
Right.
So we'll just reposit the iris and take out a little bit of, I won't chase that blood.
Would you put pilocarpine right now or you don't?
No, because ma'am, I've noticed that we used to do that. But what happens is the lens iris diaphragm moves anteriorly.
Right.
Give me a hydration. So putting pilocarpine actually ended up with a lot of peripheral anterior synechia in the later post-op period.
I see.
Because it's a raw trabecular meshwork. And if the lens iris diaphragm moves
It
up,
moves up, right?
then that iris tends to stick to the raw meshwork. So because of the PAS, I've stopped using the pilocarpine.
So post-op, you use pilocarpine?
No, I've stopped. Oh dear.
Oh, okay. So you just use post-op. Can you just tell the residents what all do you use post-op?
So lots of steroids, of course, and antibiotics for 2 weeks, moxiflox. And the other thing the residents must know is antibiotics is 2 weeks and stop. So there is no tapering. So for glaucoma surgery, we don't use combinations for that reason. Because you want to give steroids for 6 weeks, but you want to give your antibiotics for 2 weeks and stop.
Okay.
So this is one surgery where a combination is not a good idea. So I think we are done.
Let me just recapitulate. You give moxifloxacin or a 4th generation fluoroquinolones for QID for 2 weeks.
Yeah.
And stop. And for the steroids, you give
Steroids,
Tuarli for a week.
Tuarli for 2 weeks.
Okay.
And then 4 times for 2 weeks, and then taper. So 4 weeks of good steroid
So
cover.
approximately a month of steroids, 4
Yes.
hourly and then 2 hourly for 2 weeks and then 4 hourly.
Yes.
And you do not use pilocarpine
I
and no
don't use
intracameral pilocarpine because of movement of the lens iris diaphragm and
Yeah.
no post-op pilocarpine
No
required.
post-op required.
And
Yeah, true.
we need to have just the visual surgery. It is skimming of the trabecular meshwork and just gently
Yeah.
defloring the Schlemm's canal.
Yes, and removing a strip of trabecular meshwork so that they don't stick back together.
So,
So
that removal strip was not very clearly visible here actually.
Okay.
Ma'am, how important is to remove that trabecular meshwork strip?
The basis of bent angle needle goniectomy would be to remove the trabecular meshwork.
After stripping it out from the angle,
Oh,
to remove it from the anterior chamber.
Oh, I see. It usually comes out. I mean, I don't chase it. We don't see it usually. When you're combining it with the phaco, of course, you don't see it. But, oh, this is this cannula though.
So do you
Yeah.
go with the micro forceps inside and chase it and bring it out, or you just
No, I haven't done that, ma'am.
Okay. No, you didn't do that, but I'm just saying routinely do you do that?
We can do that, but that means opening up another maxillary forceps. So that's what we don't do usually.
With the
And-
KDB, it's much easier because the strip comes out on its own. With
Yeah,
the bang,
and usually when we irrigate it at the end, I haven't irrigated this one, but if you irrigate it, it comes out. With the phaco, it comes out.
Yeah. You
But-
follow this with phaco and then you do it in a dilated pupil. That's not a problem.
We always do, at least I always do a bang or an angle procedure before doing the phaco. I think we are done with this.
Right.
So we do it before the phaco because it's so much easier to do an angle surgery in an unopened eye. If you do the phaco first, there are 3 ports that you've already made.
Mhm.
And then when you go in to do your angle surgery, it gets really floppy. Sometimes it leaks. So doing an angle surgery in a closed chamber is the usual preference that what we would like to do.
So
But-
Dr. Subash, when
Sorry.
we're taking the question with Dr. Sushmita, can the second patient, the plasty patient can be draped and it's ready to go? Yeah. So Sushmita, one question again would be that when you are, I believe we discussed with you, you are doing this procedure sometimes in angle closure glaucoma too.
Yes,
In those situations, you do it post phaco?
no, even in angle closure glaucoma, all mixed surgeries, when we put in viscoelastic, the anterior chamber does deepen and we can see the trabecular meshwork quite a bit. And that's when we do that despite that. So we
Any
don't need
problems
to.
in doing it after
No.
phaco?
Yeah, that's what. So once you do it after phaco, you have 3 ports already.
Hmm.
And the eye is a little unstable
Mhm.
because when you're entering it and you want to, maneuver it, sometimes a little bit of pressure with the Swan Jacob lens and it will leak out. And then there's a lens in place. So I am personally more comfortable doing it prior to phaco, number 1. Number 2, I think it has started, we tried all sorts of things. The other thing is when we do a phaco surgery after a MIGS, it is wonderful because there's so much of fluidics going in. All that muck, all that bleed, everything is out. And the end of surgery, I'm not left with bleed and pigment like this usually if it is if we do the phaco after that. So that's the second advantage that I have.
So thank you so much. I
Yeah.
think that she deserves a big round of applause,
Yeah.
Dr. Sushmita.
Thank
Great.
you. Thanks for having me,
Great.
ma'am. Thank you
So
very
it
much.
was great to have you
Yeah,
here and
thank you.
demonstrate this beautiful technique to our residents. Great. And now we have the other surgery lined up. If Dr. Santosh is there, Dr. Subhash,
Yeah.
all ready? So if the plasty resident, Dr. Ruchi and Dr. Sushil, to please come on the dais and take over the chair and to introduce the patient and your case. Thank you.
Great. My.
So we're now proceeding with the oculoplasty case, ptosis surgery by Dr. Santosh Shunawar. And for the discussants, we have Dr. Sushil Kumar on the dais, sir, and Dr. Ruchi Goyal.
डॉक्टर संतोष एक मिनट
Uh,
स्क्रब कर लो या पहले
Good morning, everybody.
एक बार हेलो कर दो ना
I'm
एक
Dr. Ruchi Goyal and Dr. Santosh. Are you connected to the mic? So I think he'll be demonstrating an epineurotic ptosis. And for epineurotic ptosis, usually the diagnostic criteria would be a good LPS action, and an absent lid
Chai
crease
वगैरह
or
लो।
a lid crease which is shifted upwards.
Huh?
And this
Chai वगैरह
patient, I think, has about
संतोष
8
बात कर
millimeter
लो।
LPS action. And Dr. Santosh, are you connected to the mic?
Dr. Ruchi, Dr. Santosh is coming in 2 to 3 minutes.
In the meantime, I would like to also request Dr. Anju Rastogi ma'am to be on the dais, please.
Patient, silent patient की details किसके पास है? You can speak. So, Dr. Ruchi,
Yeah, please.
Dr. Salim will be telling the details of the patient.
Okay.
तो दूसरा mic ले आओ ना। This is.
So, good morning, everyone. So today we are presenting a case of a 23-year-old patient with drooping of the left upper lid since last 2 years. She has had gradual drooping of the lid, developing gradual and progressive drooping of the lid. Her best corrected visual acuity in both eyes would be 6/6 parts. On examination, she has a margin reflex distance MRD1 in the right eye of 4 mm and in the left eye of -2 mm. The margin reflex distance to MRD2 of 5 mm in both eyes. The levator palpebral superioris LPS action in the right eye is 14 mm and in the left eye is 6 to 7 mm. She has good Wells phenomenon in both eyes. Her extraocular movements are full and free. Her vertical palpebral aperture in the right eye is in the primary gaze is 9 mm and 2 mm in the left eye. She has no Marcus gun jaw winking phenomenon. And the lid crease, it's placed higher on the left side as compared to the right side, giving us a diagnosis of left acquired aponeurotic severe ptosis with good Wells with fair LPS action. And the patient is planned for left eye LPS resection surgery under local anesthesia.
Yeah, so for the benefit of the residents, how do you decide, suppose a patient presents with severe ptosis in adult age group? So it is not always that you get to know, and their history sometimes is not too clear. So what we do is usually we tell the patient to look down, and if the patient, the vertical palpebral fissure width is more on the affected side in a congenital ptosis vis-a-vis an acquired ptosis, it will be lower. So that is how we make it out. And in a severe ptosis, whenever you have a good LPS action, that is again an indicative of aponeurotic ptosis. The other thing that one needs to know is what would be the causes of aponeurotic ptosis. So any patient where you must ask a leading history of any allergic conjunctivitis or any recurrent swellings over the lids, and constant rubbing of the eyelid and eyes can sometimes lead to aponeurotic ptosis, or sometimes even following trauma, there may be some levator disinsertion, but that is not a classical case. So these are the indicators, and Dr. Santosh has joined. Or
Dr. Ruchi, Dr. Santosh is joining in 1 or 2 minutes.
Okay,
So,
sir, you want to comment?
Basically,
Sir.
Dr. Sushil sir.
Good morning.
Dr. Sushil sir.
I think, hello.
Yeah.
Am I audible?
You are audible, sir, audible clearly.
Okay. So we are starting the ptosis surgery, and I believe it is a aponeurotic ptosis, and the details have been provided. Yes, it's a cosmetic surgery, and in any type of cosmetic surgery, the expectations are very high. So pre-op assessment is very, very important, and patient is to be told what exactly are you going to do with the patient and how are going to be the results of this procedure, and the shortcomings are also to be told. Now, in this present case, the ptosis is there, and you are going to explore the LPS muscle and look for the dehiscence, and the repair is to be done. And in case the lot of dehiscence, bigger dehiscence is there. The augmentation of the
Powder free.
LPS muscle means reinsertion onto the dorsal plate is to be done. And I hope Dr. Santosh is there, ready, and will discuss when he proceeds to the surgery.
So Dr. Santosh is ready. Before that, we have team of anesthesia led by Dr. Amit Kohli, Dr. Shruti, and Dr. Srikara.
Yeah, Dr. Subhash, Dr. Anju will also like to comment.
Okay, okay.
The residents are quite familiar with the LPS resection, and as Dr. Sushil has highlighted, a very good pre-op evaluation is mandatory for a good success. But as opposed to a normal LPS resection in a congenital ptosis, in an acquired ptosis, the per-op evaluation is also very important to avoid overcorrections. So I am sure Dr. Santosh is now going to show us all the details of the surgery. Over to you, Dr. Santosh.
Okay, Dr. Santosh, are you ready?
Yeah, I'm ready.
So just.
Yeah, hi, Dr. Santosh. This is Dr. Ruchi this side.
Dr. Ruchi.
Yeah.
Our anesthesia.
So we are really grateful to the anesthesia people. Dr. Amit Kohli is there.
Hi.
Hi.
Yeah, I would like want to take a couple of seconds of all the ophthalmologists sitting out there. It's on the behalf of entire department of anesthesia. Lot of congratulations to all the ophthalmologists sitting out there, Dr. Kirti and entire team GNEC on the Founders Day. Lot of good wishes. You guys are doing excellent work and we are in the support. Thank you very much.
Thank you, Dr. Amit.
So, Dr. Santosh, would you like to comment on what is your plan?
Am I audible?
Yeah, you're audible.
Yeah. Good morning. I thank GNEC for this opportunity. This is a patient who has slightly unusual type of acquired ptosis. Looks like aponeurotic, but the levator action is 8 millimeter and ptosis is like 5 to 6 millimeter. So I believe that there would be some amount of degeneration component or fat infiltration in addition to aponeurotic, purely aponeurotic component. So the plan is to explore, look at the levator, and then decide whether we want to simply reinsert it or do a small resection as well. So she does have a hyoid crease and deep supratarsal sulcus. I have given a block, which is supraorbital nerve block or frontal block already. That's a sensory block. Every other parameter is normal. Her ocular motility is fine. She has slight amount of enhancement. Her herrings is slightly exaggerated. When we lift the ptotic right eye, the left eye droops just by a couple of millimeters. Are we ready? Bipolar, monopolar, all set?
So, thank you, Dr. Santosh. And
Yeah.
I thank Professor Sushil, Professor Anju, and Professor Ruchi, who are there for the expert comments, the oculoplasty team. And Madam was the pediatric ophthalmology expert, Dr. Anju. But ophthalmology, oculoplasty, I think, ma'am, remains your passion for a long, has been your passion. So thank you for being there. And thank you, Dr. Amit and Dr. Kirti Saxena, the HOD of anesthesia, for providing us the anesthesia support. It's always so comforting to have the anesthesia team stand by. Thank you. Over to you, Dr. Santosh.
Yeah, is the field seen well?
Yeah. So you're given the markings after measuring the upper lid crease on the other side, I suppose.
Right. So I've given it at 8 millimeter. Other eye has a faint lid crease, but at 8 millimeter. So I've taken exactly that. And I would demonstrate it the way the residents are supposed to do, not the, evolved version, so that all the steps are clear to everybody. And I'll try to go slow. I think I have time. Just let me know if there is any shortage of time. I can hurry up with the.
No, plasty takes time. I told Dr.
We have 10 minutes to 10 right now by my watch.
So, ma'am, plasty, I think Dr. Santosh, you continue at your pace.
So we have around 40 minutes.
आपको दर्द तो नहीं है ना? ठीक. नहीं कुछ. So for a beginner surgeon or serial surgeon, I would advise these traction sutures. This will help a lot during further dissection. First suture is always at the pupillary axis. That will be your reference suture. The medial and lateral sutures can be anywhere at the junction of 2/3, 1/3. You can ask question at any time. Spatula.
So I can also appreciate a little fullness, probably some kind of fat prolapse. Do you think it has occurred?
No, it doesn't look like. There is some amount of fullness.
There is some fullness, yeah.
Yeah.
Maybe after the skin
Block,
is.
it's blocked probably.
सर्जरी दिखा रहा है ना अभी अभी सर्जरी दिखा
Okay, Tolika, ready? आराम से.
थोड़ा सा उधर फोकस
No
करो
hurry. Okay, all set. So I'm ready to make the incision. I'm using Elman.
So you have to describe the instruments which you are using for the residents who are
So,
not from
so he is using the radio frequency knife, and the advantage is that it causes minimal bleeding and it gives a very precise cut. The only careful precaution you need to take is that you need to be very sure that you don't increase the power too much, otherwise it starts causing burns also, and it goes cuts very fast. So it gives a very nice and clean dissection, a bloodless feel, which is what we require in plastic surgery. And as you have seen, he has placed the central suture bang in the center before he has started the surgery, so that he knows where exactly to keep the lid crease at the end of the surgery.
Absolutely, Ruchi is very smart. She's guessing exactly what I'm doing. Of course, you do the same
Santosh,
answer.
GNEC team is very smart. Our faculty are the
I
smartest.
understand. I know that.
The faculty are the
That is why I'm
smartest,
under too much of pressure. You're all very smart.
We have learned watching your videos online, so don't worry.
Oh my God. Okay, now suborbicularis dissection is what I'm going to make now. So basically, you hold the skin flap up and incise the orbicularis.
So basically what happens is the septum is inserts on the belly of the levator palpebris superioris. So once the septum will be incised, immediately the orbital fat will be seen. So that is another, sometimes in patients of trauma, you may not have the actual landmarks. So that serves as a landmark for identifying the LPS. So you can see a bit of fat prolapse over there. So possibly, if I'm not wrong, Dr. Santosh, have you cut the septum?
Not at all. I have not come. Just on the under the orbicularis, but there seems to be some fat.
Some fatty tissue over there, yeah.
I'm going under the orbicularis. You can see change in color, skin,
yeah,
orbicularis, and septum.
So if you're not able to identify the muscles, sometimes post-traumatic cases, then you need to see the direction of the fibers. So orbicularis is going to be a circular muscle, whereas the LPS is going to have vertical fibers. So that helps in identification.
Pull nicely.
So the slit plate has to be placed, all these sutures have to be pulled uniformly so that the incisions are correctly placed.
Yeah.
And the lid plate has to be pushed up to create a good support as well as hemostasis.
So I'm doing suborbicularis dissection on the tarsal side now to expose the middle of the tarsus. You can see, I'm a hilna nahi.
Yeah, so the LPS comes and inserts on the anterior surface of tarsus, 3 to 4 millimeter on just below the superior lid margin. So that is where he is trying to expose.
Yeah, so what I'm exposing is the tarsal plate. I have exposed the tarsal plate. I need to expose only about half of the tarsal plate. There is no point going beyond that. You can see this white structure where the bud is rubbing is nothing but the tarsal plate. So I've exposed the tarsal plate. That is exactly where you're going to pass your suture. हिलना नहीं प्रिया. दर्द है तो बता दीजिए. दर्द नहीं है ना आपको? Totika, pull your spatula. Nicely pull it. Okay. Keep it nicely pulled.
So again, you can see some bit of blood vessels at the superior border of the tarsus. So we have the vascular arcade, the superior vascular arcade, which is sitting right beneath the bellies of Muller's and the LPS.
Yeah, that looks like, see, now we see the conjunctival vessels already there. See that?
Yeah.
Those are conjunctival vessels, which means that this patient has definitely disinsertion. There is no doubt at all. See that?
Yeah,
those are conjunctival vessels. So let me get a forceps. I'll just demonstrate the anatomy. So this is the tarsal plate. This is the tarsal plate. This is where the tarsal plate is ending. And on top of that, you see blood vessels, which are actually conjunctival blood vessels. This is the skin, this is the orbicularis, and this is the bulging septum. Under the orbicularis, there is some amount of fat, but septum is not open. You can see septum nice and bulging.
Yeah.
Can you see all the anatomy?
Yeah.
Sister, एक बार mop कर दीजिए press करके. Okay. Now, once the field is dry and there is no blood, you can see the entire anatomy. Now, looking at this, now this is very important. You can see color, pink, yellow, white again. So this white again indicates that this is the levator aponeurosis, right? See the color? See this? All right. So this looks like the disinserted levator aponeurosis. Now, when the levator aponeurosis disinserts, it everts back like that and goes back to the septum. So I'll have to explore that edge next. Okay. Bipolar, sorry, monopolar. तो लिखा spatula पकड़ना बहुत जरूरी. It should be nicely pulled. No, angled up. Yeah. Pull करो अच्छे से. Thank you. जितना अच्छा pull करोगे उतना अच्छा.
So now you're dissecting the levator muscle.
Levator of the septum.
And the septum.
Of the septum. Yeah, this is, you can see that this is the septum. Sister, hold the levator with a forceps.
So we can see the fat just superior to it, and that is exactly where probably the orbital septum is inserted. It is holding the fat back.
Absolutely. So this is the septum. Now I'm opening the septum. You can see pad of fat coming out. See that? See that?
And then the orbital
Yes,
this
it's
pad of
visible.
fat
It's
will
visible.
collapse out. It is over the LPS muscle.
Yeah.
We're going to retract it backward and look for the LPS muscle. And also,
and as I was guessing, this patient has degeneration. Degeneration in the sense levator aponeurosis is fat infiltrated. That explains her 8 millimeter levator action. She is supposed to have about 10-12 millimeter.
no, he is retracting the fat backwards.
You can see that levator aponeurosis is actually yellowish here.
So Dr. Santosh, at this stage, would you like to put some retracting sutures on the LPS for enabling a better exposure?
No, I don't think I need that, but let me just see. See, basically, what I'm holding is the levator aponeurosis with the forceps. And you can see that there is this medial and lateral horns that are there, which I'm exposing now. And you can see levator aponeurosis, instead of being pink, is yellowish here. Part of it is yellowish. You can see levator aponeurosis pink in this area. Can you see that? This is absolutely pink. This is the aponeurotic component of the levator. This is the aponeurotic component of the levator. This is the junction of the aponeurotic and muscular component. And that is the muscular component. And muscular component is fat infiltrated.
So there is something like an unhealthy levator, which is being spoken of late quite often.
Yeah. This is degeneration plus disinsertion. That's what I was initially, when I described this patient also, I said the same, that this patient has slight amount of atypical aponeurotic ptosis because her levator.
So what would be your maximum levator resection in these patients? Because overcorrection may sometimes occur in acquired ptosis if we.
Yeah. So I would actually go about 8 to 10 millimeter. Beyond that, going beyond that would be unsafe because that may result in overcorrect bipolar system.
We like to leave a little stump when you are inserting so as
to.
You do. And
Yes.
anytime you give, releasable, not releasable,
Adjustable
like
suture.
adjustable sutures, releasable.
Yes.
We just finished the glaucoma. So, so adjustable sutures
Yeah,
in these patients?
Yeah, adjustable sutures are in patients who are probably having a resurgery. There is some amount of fat infiltration. I'm going to release it using a bipolar. So when you do this, you should make sure that the levator muscle does not get disturbed. So when I release it, you can see healthy levator underneath.
So the another precaution while teasing this fat is that one should not pull. We can see how
It is so
gently
thin-
he is
it's
dissecting.
so thin here. You can see
Yeah.
levator aponeurosis is so damn thin. So I don't want to do any further dissection with that. Let's take the suture.
Do you ever plicate these?
Yeah, but fat infiltrated levator is very unpredictable when you do plication. They simply need to be reinserted. That is the best option. अच्छे से picture लिखा. Vertical putto. ठीक. थोड़ा angulate कर लो.
And is a conjunctival approach an alternative for epineuritic ptosis? Would you like to do it?
Yes, yes, conjunctival approach is definitely good, but when reinsertion is difficult in conjunctival approach. Plication is fine, resection is fine, but reinsertion becomes very difficult. So I don't prefer in a patient where there is disinsertion, I don't prefer. So I passed my suture right. See, this is a guide suture for me. About 3 to 4 millimeter is the bite size. I have passed it right in the area of the central suture. And now I actually have to check because in thin tarsus, you may actually go full thickness. Make sure that you don't go full thickness. This is very important for a beginner surgeon to check because otherwise the suture will rub through the cornea.
So this is 6-O-proline.
6-O-proline. You can use 6-O-vicryl as well. Suture chuskondi sister. Okay, you can hear some Telugu words. That's because my nurse is. All right, so we are retracting the fat and I'm going as high as possible to the, see, you can see fat infiltrated levator. Yeah, needed.
So you're going as far as high as possible, or would you like to measure it actually with the caliper?
Measuring is likely, yeah, you can measure it, but measurement actually does not really help. So I would go as high as possible. I would say about 10 to 12 millimeter is what I have taken. Beyond that, it's because when the levator disinserts, the aponeurotic component becomes very short. I'll just show you that in a while. Aponeurotic component, which is supposed to be 16, 18 millimeter, becomes hardly 8 to 10 millimeter. And all that we are left with is the muscular component. And that muscular component is fat infiltrated.
And unlike larger dissections, we don't need to really fiddle with the horns.
Yes, we don't fiddle with the horns at all. So I'll just show you before I suture. See, look at this. This is the white portion here. White, no, the white, you can see the white portion here. This is the white portion, that is the aponeurosis. This is the area of the Whitnell's already, right? So this is the muscular component. This is all the muscular component. Now muscular component is fat infiltrated. Aponeurotic component is all fine. You see that?
Yeah, yeah, it's visible.
Yeah. Okay. Incline, flat mark. Yeah.
Do you like to do on-table titration or something like
yes,
that?
you can. You don't have to make the patient sit up, but you can always check the correction on table. But levator action is 8 millimeter here, so I expect reasonable correction in this situation. थोड़ा सा medial suture को अच्छे से pull कर लो, evenly pull करो. That's very helpful. Thank you.
So as we were discussing, the evenly, the assistant's role has a major this thing, because if they don't pull it evenly, then
Yeah.
your insertion may be not at the same level and you may not have a very, very nice lid contour post-op.
Right. So Ruchi is saying all the right things. Check. Every suture you are supposed to check for full thickness. Ideally, in a given situation, if you're very experienced, you may not want to check, but for residents, senior residents, ideally you're supposed to check. So because I've used Elman for most of my dissection, there is hardly any ooze. And you're able to see all the tissues very clearly in their natural color. They're not pinkish or yellowish.
So what is another important point here is that Dr. Santosh has not dissected too much on the posterior surface.
Right.
So it's just the anterior dissection. Yeah.
Yeah, this is when you reinsert, this is what you do. You go under the levator pocket. Otherwise, you would pass 3 sutures through this levator aponeurosis, dissect it off the conjunctiva, and then resect. So here there is no point doing resection, but reattachment at a higher level is what I'm doing. Is the field centered for you all?
Yeah. We
Okay.
can see very well.
Okay, good. The second arm of the suture is on a free needle. You can always reverse this. You can start from the levator side, go to tarsus and come back if you want to use a single needle. I tend to use a double arm free needle. Fine. Struggle mat karo. Incline karo. Incline. You don't have to rest your hand on the cheek. Yes. Any other questions anybody has at this point?
It's very well demonstrated, and I think we are just waiting for the final lid to lift up now.
Good.
So it's just that another point that the tarsus becomes a little smaller in width as you go towards the end. So it becomes.
Yeah. Exactly. That's what I was thinking. I wanted to say that, but before that you said it. As I said, you're actually saying everything right.
It's like a cricket commentary I'm giving now.
Gavaskar. Yeah. Isn't it, Rolika? She's saying absolutely everything right. I would say the same. इसमें थोड़ा सा ये है, thinness है, careful. नहीं है. It's very thin here.
Yeah.
1 second. I'll just take this levator. Right. Correct. Needle.
Do you ever make smaller incisions? I've seen surgeons making smaller incisions.
Yeah, small incision ptosis surgery with single suture is possible when you know that there is only disinsertion, there is no degeneration or dehiscence. Then that is a very useful procedure. One single suture in the center and about 8 millimeter incision in the center. So small incision ptosis surgery is in vogue, but not for a patient of this sort where preoperatively only we have decided that she has atypical features and most likely degeneration. So this cannot be tackled by a small incision. So I won't do small incision for this, but otherwise it's a good approach for elderly patients where you simply want to expose the pupillary axis. One single suture is all that is required. But if you want to reform the lid crease, set the lid crease at a higher level, or that is not possible with small incision surgery. Yeah, remove the spatula. छोड़ दीजिए आँख खोलिए अच्छे से.
So Dr. Santosh, how do you avoid lid notching apart from the evenness in the pull and giving the sutures at a particular place?
Right. So
do you find that the nasal part tends to notch more?
Yes, I agree with that. So my suture bites on the tarsus actually help me. I take about 3 to 4 millimeter wide bites on the tarsus. And when you tie it again, you watch for notching. And notching is best detected when the patient looks down, when not in the primary position. So you kind of titrate the tightness of the suture. You, आँख खोलिए, अच्छे से खोलिए. The light is on, but you can see that she is able to open well. You can see that. आँख अच्छे से खोलिए, cornea wet कर दीजिए एक बार. I'll put off the light for a second. I don't know whether if I put off the light, you'll be able to see or not. आँख खोलिए अच्छे से. You're not able to see, no? That's the whole problem is that. Is there any external camera that you can show? नहीं ठीक है, नहीं नहीं ठीक है. अभी दिख रहा ना correction?
Please focus on the eye. Yeah.
Yeah, you can see the correction, right?
Yeah.
हाथ हटा दीजिए. Send, I'll send. So we have a nice purchase over the levator. Now I can tie the suture wherever I want, however tight I want. So that will give me the best of correction. आँख खोलिए अच्छे से खोलिए, cornea wet करो. So generally when I check the position of the lid, I put off the light so that the patient doesn't have photophobia. But here, if I put off the light, you'll not be able to see anything. छोड़ दीजिए, remove everything from the field. अच्छे से खोलिए. Okay, I'm not tying the sutures at all now. At this point in time, just holding the suture, and you can see that she's able to lift well. So which means that I have total control over the situation. Now I can tie with enough tightness to get the correction of my choice. Since the levator action is about 8 millimeter, you have to leave it nearly about where you want it to be postoperatively. Burkitt's rule can be applied to any situation, just not congenital ptosis. So I'm going to tie it reasonably tight now. Any comments? Would you do the
Yeah,
same?
suppose the LPS action was let's say 14 millimeter, then
Oh yeah, that is then you have to undercorrect on the table. The higher is the levator action, you have to slightly undercorrect on the table, because such slits actually lift, drop post-op, lift post-op. You can see the correction,
yeah.
right?
Yeah.
So central suture has been tied now, but I'm going to kind of finalize it here because I'm happy with the correction. I don't want to do any more manipulation for the center. At this point in time, if you're not correcting well, you still have scope. You can see how much, pull it, you can see how much higher I can go. See that?
Yeah.
But it is all fat infiltrated. I could pass my suture here also. I could pass my suture here. I could pass my suture here. So I have passed it at about 10 to 12 millimeter and I'm tying it with enough tightness to get the correction of my choice. I'm not going higher, but you still have the scope to withdraw your primary suture and go higher before you finalize your suture. So this is what you play with. Cut it. No. Well, I finish. You can ask me any question if you want.
In general anesthesia, sometimes it becomes very difficult to.
General anesthesia makes it difficult. खोल दीजिए.
चार्जर है आपके पास?
छोड़. Hold it.
And in the meantime, we have a few questions from the audience.
Yeah, anybody can ask
So,
this audience
They want
question.
to know what modifications you prefer depending on the grade of ptosis and how much overcorrection you advise, sir.
So
Yes.
this is for which acquired or congenital? What?
We haven't really mentioned. For the current surgery that is going on.
Oh, the current surgery is aponeurotic. In aponeurotic ptosis, there is only one thumb rule that is actually a kind of not a very mature thumb rule, I would say, where depending on the levator action, you hang back the suture. If the levator action is say 8 millimeter, then you place the suture right in the middle of the tarsus. If the levator action is 8 to 10 millimeter, your suture should be either tied loose or placed about 2 millimeter higher than the middle of the tarsus, like that. So basically you hang back the suture depending on the levator action. So, but that rule does not work so well. That's called Neerath's rule, only because the amount of contraction the aponeurosis undergoes depends on the etiology of ptosis. That means if a patient has inflammation, such as dermatochalasis related ptosis, then the levator aponeurosis contracts little more as opposed to a senile ptosis, as opposed to a patient who uses rigid gas permeable contact lens, etc. So aponeurotic ptosis is a basket. It has lot of variables. So as I showed you earlier, in aponeurotic ptosis, the most important aspect is that the aponeurosis contracts after disinsertion and it rolls back. So you are supposed to identify how much has the aponeurosis contracted and based on that take an intraoperative decision.
So would you like to do a little blepharoplasty also for this patient?
No. Her other eye lid quality is also the same. So we don't want to give her asymmetry.
Okay.
Yeah. So my lid crease formation sutures, I'm taking orbicularis, stump of levator, and orbicularis again. So this is going to be a dynamic lid crease. Dynamic lid crease is one which disappears when the patient looks down and starts appearing as the patient looks up. Don't touch. So for that, you need to close, reattach the orbicularis to levator stump, not to take skin suture in this. If you take skin in the suture, then it will become a fixed lid crease. I'm using Vicryl for this.
How do you prevent lash ptosis?
Yeah, if a patient has lash ptosis, then your tarsal suture can go little lower, that will act like a lash averting suture. Or you can pass lash averting sutures at the base of the lashes, about 2 millimeter from the lid margin, and take it right across the orbicularis. So lash aversion sutures you can place if a patient has lash ptosis, or you can go slightly lower on the tarsal plate, that will give you an aversion effect. And patients who have lash ptosis are not good candidates for posterior approach levator surgery.
Yeah, that will further increase.
Further worsen the lash ptosis. This was a frontal block or a supraorbital nerve block that I've given. So you can judge the correction during the surgery or at the end of surgery. There is no much mechanical component except for the effusion that the surgery itself creates. So this is a very good block for any patient who has reasonable amount of cooperation. Even in young adults, 16, 17, 15, you can still do under frontal block.
So how much amount of lignocaine?
Ideally, you should go about half a cc or 3/4 of a cc. But this being an unfamiliar surgical situation, I gave a little more. That's why it's more swollen. I'm not, it's a new surgical situation for me, so I wanted the patient to be comfortable.
I hope you were comfortable.
Absolutely, felt like home.
Beautiful surgery, Santosh, but that was to be expected. But from the other eye, would you try to, again for the residents, I'm speaking from that side, would you want to see the other eye and then show on the table before you do the final suturing?
Not really, symmetry? Not really. We are already seeing the other eye and the plastic drape is covering it, so it's okay. I really don't have to.
I remember in our residency, we used to be asked to see the other eye because that time we didn't have the plastic.
Yeah, you can
drapes.
symmetrize. You can symmetrize if you want to. But what happens is post-operatively, all your symmetry that you get intraoperatively can change. So you have to just stick to a particular thumb rule and then,
So post-op care also, if you could speak simultaneously, how long would you?
I would just give topical lubricants and that's it for about 2 weeks intensively, and after that just gel, gentle gel for about 6 weeks.
And systemic antibiotics?
Systemic antibiotics is your institutional antibiotic policy. I would give it in my situation.
What do you give in your situation? What do you normally give?
Dr. Santosh, ma'am is asking which antibiotic do you prefer for systemic post-op?
We give augmentin to everybody. Don't laugh at me.
3 days, 5 days. Is it 3 days or 5 days?
5 days. And also Combiflam or any other painkiller, anti-inflammatory. Systemic steroids we generally don't give unless the patient has lot of edema post-operatively, then for a short period of time, 15 days or so.
Would we require so much of lubricants like your gentile gel, especially in eponeurotic ptosis where?
No, no, no. On day one, you can assess, and HS is all that is required. 3 times a day and HS maybe, that's it. See, they do have some amount of nocturnal agophthalmos initially, which settles down over 4 to 6 weeks. But during that period, depending on how much dry eye the patient has, adults do have flash, but ghata na, cornea touch kare na.
I think a nylon suture gives less reaction in this case.
Absolutely, this gives a no fibrosis. This can be simply pulled off. I'm doing a continuous horizontal mattress suture, which leaves the skin edge everted and well opposed. You can see the everted skin edges and well opposed. So when you remove this suture, there will be a flat scar. There will not be a depressed scar or an elevated scar. So which is more friendly to the tissues in terms of visibility.
So is there any lag of?
How many days? Is it 10 days post surgery that you removed Proline?
7th day.
7 days.
7.
Have you ever noticed there's a lot of, like, in at least Indian scenario, classically we used to read that the suture, the wound heals by 5 days. But many a times, if you remove it at even 7 days, we do have, wound gape. I'm not talking about this lid surgery, but otherwise.
7th day is when generally most of this, except for dermis fat graft and where the wound is going to be very tight or tension on the wound, then you can remove later. Otherwise, 7th or 8th day is what we would. एक बार आंख बंद करके बताइए. ठीक है, she's closing well, but despite that, I think you can Rolika can put a frost suture. I think that is the end of surgery. If you have any questions, I can answer.
It was a wonderfully done surgery, Dr. Santosh. We
Thank you
really
so much.
enjoyed watching it, and each and every step was crystal clear.
Thank you so much. Thank you for all the help.
Does this require a frost also?
No, we are putting it just for the safety sake. Medially, she has some amount of lag of thalmus, so Rolika will just put a frost suture.
Thank you very much. That was really well done.
Do you would
Dr.
you
Santosh, if I
prefer?
could, as a non-oculoplasty person, if I could ask again from the resident point of view,
Yeah.
if you could just give them some tips and pearls of
Pardon?
what not to do, like how not to perforate the conjunctiva, how not to damage the SR, or whatever things you can talk about during the ptosis surgery of this kind,
Right.
with an old patient.
Right. So for a levator resection, if you're a resident or a senior resident, the best way not to perforate the conjunctiva or do a buttonhole in the conjunctiva is to give subconjunctival xylocaine or any fluid injection to create a plane of cleavage between conjunctiva mullus and the levator aponeurosis. Then there is a good separation between conjunctiva mullus and the levator aponeurosis, and when you dissect it posteriorly, there is very minimal chance of buttonholing. That is what we would do. Apart from that, there is no really any precaution. And using 3 traction sutures, as Ruchi was pointing out earlier, if you're doing levator resection, using 3 sutures over the levator aponeurosis and holding that superiorly, pulling it up superiorly would tent up the levator aponeurosis so nicely that the potential space that is created between conjunctiva mullus and the levator aponeurosis would prevent any kind of buttonholing. So this is
And I think one more thing to add, that the assistance role again comes in very handy, where when you are dissecting from the conjunctival side, and they keep the the inferior layer taut, then you are less likely to injure the conjunctiva vis-a-vis when it's all crumpled and things keep slipping.
Yeah. So assistance role is extremely important. In fact, I cannot do my surgery without my usual nurse assisting me. Only ptosis surgery, but rest of the surgeries you can still manage. Ptosis surgery, I think, is so assistant dependent that you are.
That is why you got your assistants with you. So thank you for your team. There's a question from Dr. Ritwija Thomas on the live channel.
Yeah.
Do you feel any difference between using vicryl sutures vis-a-vis Proline to correct the levator?
No, I don't find any difference, but I have had some amount of unpredictability with vicryl suture. Vicryl suture can give way or dissolve unpredictably even before 6 weeks. In ptosis surgery, we should remember that the healing, that the aponeurosis, when it gets reattached to the tarsal plate, healing is not by primary intention. Healing is by secondary intention. So you want your sutures in there till the secondary intention healing is stabilized. That is at least 6 to 8 weeks. So Proline gives you that kind of surety because it is a non-absorbable suture. Vicryl can absorb little faster, or it's not can become unstabilized. So the issue is always with vicryl being unstable and not giving you the kind of strength that you want until 6 to 8 weeks. So that is the reason why I have shifted over to Proline. But Vicryl is I think used by equal number of surgeons. There's a
So-
50-50 split between Vicryl and Proline.
Great. So the remarks are coming in fast and furious right now. So Dr. Kanshuk Marwa is saying, great, Dr. Sushmita, and great, Dr. Sushmita from our side too. And Dr. Arvind Maurya has asked you questions. Santosh, what
Yeah.
modifications do you prefer depending on grade of doses?
Ma'am, we've already
How much
covered.
overcorrections? You've already
We've
asked
already
that
covered.
question. I'm
that,
sorry.
yes. Thank you.
Okay, yeah, so another one by Dr. Kanshuk. It's a great treat to watch Dr. Santosh. Feel like taking the oculoplasty training. Great. Voice is not clear. Okay, but Dr. Goel, I'm sorry now the surgeries are over. The voice is not clear. That's not your vision. Any other messages? Please do send in your messages. And residents, anybody wants to ask any questions? Any questions who have to be
We've also
asked?
had congratulatory messages for Dr. Sushmita previously. We couldn't share them because of the
No, we're going to call
plastic
them,
surgery.
Dr. Subhash.
Yeah,
Wonderful
yeah, ma'am.
event. Wonderful event, and I would personally like to thank the anesthesia
Really thanks
team.
Subhash for all the help.
Anesthesia team,
ma'am,
Dr. Kirti Saxena,
I am
and,
ask-
and the OT team under
I am
Sister Joyce.
Ma'am,
Yes.
I am asking the OT team and
Yeah,
all
I
to
would.
come-
I was going to ask the same thing, Dr. Sister Joyce, the Sister Renu and her team,
Sir, आप भी आ
DV
जाओ।
Dharambir, our OT technician who takes care of
Sister,
everything, our
Volika, come.
glaucoma team, our plastic
They
team,
want.
and everybody. If you could just, Dr. Subhash, click a picture and
Yeah,
share
yeah.
it, that will be wonderful. It's
Come
one of the initiatives of GNEC. We hope to carry it on next year also.
This
With
is
the
very well
blessings of
done.
Government
Sister-
of NCT
Sister
Delhi.
Joy, Vinod ji.
Kirti, this was very well done. I think this is superb. I mean, the way everything was organized so meticulously without any hitch, it was really wonderful.
Touch wood,
It was a
touch
pleasure
wood,
doing surgery.
Touch
here.
wood. You came in at 1 a.m., 1:30 a.m. My people were waiting for you in the guest house. So thank you, a
Thank you
team,
so
to
much.
Guru Nanak Center team has done our faculty on the dais, off the dais, holding the OPD, and everybody in the OT. Wonderful, great doing. If I'm missing somebody, my apologies. But Sister Joyce, DV, can I see you? Sister Joyce, can I see you?
Sister Joy.
Renu is
sister.
there. Renu is
Come now.
there. Thanks, Joyce.
यहाँ पे पैन कर दीजिए.
Thanks,
So,
Joyce.
ma'am, I
TV,
think we
and
have
Sush-
completed the surgical session well before the time.
I think so. And all the team
And-
has to come downstairs and take up
Yeah.
yeah.
So thank you very much to Dr. Santosh,
Thank
Dr. Susmita, Dr. Rolika, Sister Bunty, and Sister Joy, Sister Renu, all the OT staff, Dr. Amit, and team anesthesia, everybody. And most
And
importantly,
Dr. Sushil, Dr. Ruchi, Dr.
Sister
Anju.
Susan, and then our AV team of Grover Audiovisual. Thank you, everybody. And
Thank you. It was indeed very good presentation and beautiful surgeries. Come down, we are waiting for you. So that was the end of the live surgeries. We finished well in time. Thank you, Professor Sushil sir, Professor Anju Rastogi, Professor Ruchi for being there. Thank you, glaucoma team, Dr. Anu, Dr. Ketki, and our residents, Dr. Priya, Shweta, and Shalin was there. Who was assisting Dr. Ruchi there? I couldn't identify.
Shalin and
and Dr. Priyanka for organizing. The work started much before getting the patients in, seeing the patients, and then organizing. Thank you, team GNEC. Thank you so much for this beautiful presentation. And it's my privilege now to welcome the stalwarts of GNEC. Some of you who've written the history with me would know them. Professor A.K. Gupta, sir, one of the founder directors. Professor Das, my mentor and teacher from glaucoma. Professor Gurbaksh Singh, who had started the cornea services way back. Dr. S.C. Gupta, our innovator past excellence. There is no other word for Madhu instrument innovator. They're all GNEC alumni. And I believe, so. Oh, Dr. Bansal, great. Wow, welcome.
Well,
sir.
I wasn't.
Welcome,
Thank you
sir.
very much for your.
Our
Thank you.
pleasure, our pleasure.
Well, I'm pre-GNEC. The thoughts were at that time just coming. We're talking about 1971, 72. My mentor, Dr. Gupta, Dr. Gurbaksh Singh, they were all here. And
nice seeing you.
visiting my alma mater is really a great pleasure and honor to see it's doing well and the name is going all over the world. I moved to United States practicing at Columbia Presbyterian Medical Center. And I was impressed seeing the surgeries is as better than that what we do. Thank you very much.
Sir, our faculty do great surgeries. This time our residents said that we want somebody outside to come in. So we brought it. You will be extremely privileged next time for you to come in for our surgeries too. So we can have a cup of coffee, Dr. Saksham. And sir, would you like to speak something for our residents? Dr. Das, for the glaucoma team would like to speak something.
I think this is because of all of you. Things are improving very fast under the leadership of Dr. Kirti. And we're so delighted sitting outside and that things are improving as per our expectation. And these all goes to you people, your contribution and your participation. And I'm so happy that Kirti is leading the team and it is doing so well. Thank you.
Our OPD is still running. The people are there. Our OT is running. So the clinics are running. We're expecting our residents to come in. We call Dr. Meenakshi and Dr. Ritu also, ma'am. So because our chief guest has to arrive at 12 o'clock sharp. So we'll have a quick cup of coffee. We'll just break for 10 minutes. We are ahead of time. So thanks for the meticulous all the management. And special thanks to Dr. Anu, who has been my right hand, and our glaucoma team, which has been there totally with us. Of course, everybody else has participated, but they have been with me. They left at night again, 12 midnight or 1 a.m. I can't thank you enough for that. So we have more. Taru, great. Come in. Vandana, wonderful. Coffee arrange कर दो सबके लिए. We just finished the surgeries.
Today's start of the Chaitra month, and we have a new year starting. So I say Happy New Year to every one of you. And this is according to the Dr. Guru Nanak Dev Ji's calendar, Nanak Shahi calendar. And this is really an auspicious day that the GNEC Foundation Day and this is coinciding. So my best wishes to every one of you on this occasion.
All right. Brigadier sir, can you just come here? He's the person who has been really, I would say 3 cheers for Brigadier Sanjay Mishra.
Thank you.
Thank you so much. And Army is Army. They are class. You're just class. Thank you so much for being there. Would I just say something? We just finished the live surgeries. It just finished well in time. So okay, yeah, sure. So you have welcome for a cup of coffee or something, and then we're just organizing, just having a break. Thank you so much. अंकुर बेटा एक बारी ओपीडी में राउंड लगा लो एंड डॉक्टर मीनाक्षी मैम को बुला लो. ओह देयर शी इज. ग्रेट. डॉक्टर रितु मैम को. ओके. She is here, the retina lead. We just finished the surgery, Dr. Meenakshi, and Dr. Gupta is here. Dr. Das is there.
We're going to be starting shortly. Our chief guests are going to arrive in another 5 minutes. ये लाइट कर दीजिए। Nanak?
That's not the right place. Oh, you want to see that? Okay, okay, fine.
A very good afternoon to each one of you. We're going to begin shortly. Our guest of honor has arrived, so we'll just be starting in another 2 minutes. A very good afternoon to one and all, to our chief guest, our guest of honor, and all the audience gathered here today. I am honored and humbled that you're here with us on the 37th Foundation Day of Guru Nanak Eye Center. And it is my very privilege to be a part of this institute for the last 7 years of these 37 years. Without much ado, I would like to mention that GNEC is a tertiary eye care center in association with Maulana Azad Medical College. GNEC has not only been a witness to the evolution that medicine has seen in the last 4 decades, she has also embraced it with open arms and even set precedents with its pioneering work in the field of ophthalmology. On this occasion, we're also going to celebrate a landmark event, that is the GNEC book release. I'd like to welcome our chief guest, Lieutenant General Daljit Singh, AVSM, VSM, and PHS. Our guest of honor, Professor Poonam Narang, who is the Dean of Maulana Azad Medical College. And before I introduce our chief guests and guest of honor, I'd like to start the program with the Saraswati Vandana and lamp lighting. As rightly Tagore said, I've come to thee to take thy touch before I begin my day. I invite chief dignitaries and Professor Kirti Singh for the lamp lighting, along with all our faculty members, Professor Kirti Singh, Professor Poonam Narang, Lieutenant General Daljit Singh, and our GNEC faculty. Can you please come for the lamp lighting? We have our nursing staff, a very talented team of Sister Vandana, Varsha, and Ruchi for the Saraswati Vandana.
जयति जय हे मां सरस्वती जयति वीणा वादिनी जयति जय हे मां सरस्वती जयति वीणा वादिनी पद्म आसन छोड़ दो हृदय आसन लो माँ पद्म आसन छोड़ दो माँ हृदय आसन आज लो माँ जगत का कल्याण कर माँ जगत का कल्याण कर माँ तुम ही विघ्न विनाशिनी जयति जय हे मां सरस्वती जयति वीणा वादिनी माँ मुझे दो ज्ञान सुर का कर दो पूर्ण परी मुझे माँ मुझे दो ज्ञान जयति जय हे मां सरस्वती जयति वीणा वादिनी।
I would now like to request Professor Kirti Singh and Dr. Ritu Arora to accompany our chief guest, Lieutenant General Daljit Singh, onto the dais. Our chief guest this afternoon holds his name Ati Vishisht Seva Medal for his distinguished service and has been conferred honorary surgeon to the President, Draupadi Murmu. He currently serves as the Director General of Medical Services, Army, and is the senior-most pediatrician and neonatologist in Armed Forces Medical Services. I request Dr. Saksham to honor the guest. I now request Professor Ritu Arora to give a shawl to sir. And Professor Kirti Singh for the gift. We welcome you, sir. I now request Dr. Sushil Kumar and Dr. Anju to escort our guest of honor, Professor Poonam Narang. A radiologist by profession and dean of one of the oldest and prestigious medical college of India, that is Maulana Azad Medical College, Madam has been instrumental in all activities of MAMC and GNAC. We thank her for her support in all our endeavors. Thank you, Dr. Saksham. And thank you, Dr. Sanath. Thank you, ma'am. We welcome you here. I now request Professor Kirti Singh on the dais and would request Dr. Meenakshi, ma'am, to present a bouquet of flowers to her. Professor Kirti Singh, Director of GNEC, her enthusiasm and zeal towards any activity she makes herself a part of is infectious, and her dedication and efforts to planning every detail is unparalleled. Today would not be possible without sleepless nights she'd put in. Thank you so much, ma'am. I request Professor Kirti Singh, Director GNEC, to give the welcome address.
Sanath, please come here. Good afternoon, everybody. It's a really proud privilege. And as I've said this multiple times, not my quote, it's Isaac Newton's. We stand on the shoulder of giants, and the giants are right in front of us. Guru Nanak Eye Center is what it is because so many of them literally poured their sweat in to this soil. And we have the privilege of welcoming Lieutenant General Daljit Singh, our revered Dean, Professor Poonam, and our entire faculty here. This is the picture which we got from the album of Professor A.K. Gupta and Dr. R.B. Jain of the initial foundation day of GNEC, which was laid 14th March 1986. And this is the vibrant GNEC which we have now. So you can see the things in front. You don't have to crane your necks. It's the largest dedicated eye hospital of Government of Delhi. All super specialties, cornea, glaucoma, retina, strabismus, oculoplasty, pediatric ophthalmology, neuro-ophthalmology, contact lenses are there. You just saw in the morning a super specialty surgery of glaucoma and oculoplasty. We have additional biochemistry and pathology labs fully functional and fully operational, and a microbiologist lab. Annual patient footfall, sir and ma'am, is 3 to 3.5 lakhs. In the OPD, you saw yourself how much is the rush, people wait in queues, and our team was already seeing the patients. Around 14,000 inpatients, and this is some of the pictures of the rush which we have, which we cater to, and the patients very patiently wait in line. This is spacious OPD rooms. That's Professor Ritu seeing the patient. She's heading the cornea services. That's the investigation lab. These are special clinics. As I said, all the special clinics are there. And this is the data of around 30,000 special clinics cases are seen per year. This is despite the fall during COVID. This is the retina lab and the glaucoma lab and the cornea lab and the strabismus lab and plasty labs. This is the investigative lab of state-of-art machines pertaining to all specialties, a LASIK OT. So recently, as I speak, the femto LASIK is being installed thanks to the efforts of the cornea team. iBank has 6,600 eyes retrieved in the last year, 60% by the hospital retrieval corneal program and a utilization rate of 80%. We have a fully functional 5 spacious OT. You all witnessed the extremely good quality of OT services provided by our team of sisters, of doctors. And this has 5 spacious OT, 12 phaco machines, and a recording system. And we just saw the live surgeries from there. We do around 10,000 to 10,500 to 11,000 cataract surgeries. It had dipped down during COVID. It is increasing, and now we are going to increase because of the mission Prime Minister Yojana. We have to increase the surgery, which we are going to do. And we have again a very dedicated residents who contribute to our OT services as well as being the backbone of Guru Nanak Eye Center. As I mentioned, we have a fully automated biochemistry analyzer, and all these services are available since December 2021. Our teaching is one of the best in the country, sir. We have 17 postgraduates per year, so they each have a thesis. We cater to the ophthalmology department of MAMC. We have 250 plus students per year, sir, and from tomorrow we'll be conducting the undergraduate exam. We have over 500 research papers in the last decade with the H index achieved by faculty members up to 12. Landmark studies were done on COVID and mucormycosis during the tenure of Dr. Ritu. Various awards at state and national levels have been given to the conferred to the faculty of GNEC. We had a live surgery way back in 21, and now it's the second one. We've had live surgeries before. This was done under Delhi Ophthalmic Society Conference, and this time it is under GNEC. Our postgraduate teaching, as I said, sir, is very much revered, because the fact is that 100 ranks of all India level are filled by people choosing GNEC. If you want ophthalmology in GNEC, you have to score a rank 100 in the NEET exam to get it. Uske baad nahi milti hai. And these are our teachings of the ophthalmic technicians and as well as the ward teaching. We have developed a phaco-demulsification development program, or PDP program, to improve the surgical skills in PG residents in a safe, monitored environment. It was started by Dr. Ritu in 2021 and was regularized under my tenure. Now we have, as I speak again, we have a simulator which has been going to be started. So we'll be doing the simulator training, and our residents are very much being benefited by the PDP services because it prevents any mishaps. We've also had structured logbooks, and our team with Dr. Anu and Dr. Siddharth have structured the senior resident and postgraduate logbooks, sir, where the students can record their surgeries, and this has been granted a patent to us. Based on the competency-based medical education for UGs, we have started in Guru Nanak Eye Center a competency-based medical education curriculum assessment logbook with the help of Dr. Parul and Dr. Neha, and this was the medical education team's help. During COVID care, sir, in the first wave, second wave, we had continual OPD services. We admitted around 386 and 221 patients respectively. We did around 50,000 COVID testing cases with the RAT and RT-PCR vaccination of more than 17,000. And these are our students who have worked, literally sweated under the PPE kits to take care of the COVID patients. We had another very interesting initiative to mitigate the academic loss during COVID-19 pandemic. An educational initiative for residents on the online platform was started by, again, Dr. Ritu in 2020. It was structured by me as a 3-tiered structured case presentation by residents, senior residents, and faculty. We had conducted 46 classes It was open to 100 participants of Delhi and other states. It was called Superiore because that is what we dared to do, because our resident teaching is very important to us and we didn't want them to miss out. In addition, sir, in 2021, Delhi State Health Mission State Office was taken up by us. I'm the State Program Officer. We do student and patient awareness activity. We take care of 11 districts, sir, and our students are very active in doing this activity. Dr. Pooja Bansal is my link officer, and our team of faculty is on the World Sight Day, where we had a lot of activity in low vision services. Our students, our entire staff is totally dedicated to the country, sir. Vande Mataram. For our country and society. During World Sight Day 2021, the cornea team had a marathon, 12 corneal surgeries. During the glaucoma week, we did 39 trabeculectomies and combined. This was just to give a message that surgeries are available, not that we are not doing it every day. So, and in addition, we have these workshops on rational glaucoma therapy. This is the nursing staff who have been really the big support team for us. With the community medicine department and the pediatric department of MAMC, we had pledged for rational steroid therapy. Sir, being a pediatrician, you would realize that steroid-induced glaucoma is a very much preventable glaucoma in children. We have very often children who come with steroid-induced glaucoma because of irrational use of drugs. So over-the-counter medications have to be stopped, and pediatricians were put in the loop with this. In addition to reducing the carbon footprint, sir, we have the STP plant from 2015. It's fully operational, 500 kiloliters per day. So the gray water from our OT is recycled for the green verdant lawns which you see around. We have a herbal garden, a biomedical waste team. And recently, under the auspices of Dr. Poonam Narang, we could start the wet and green composter. You'll be glad to know, ma'am and sir, that our team scored 85% last time in the Kayakalp round. And in addition, our team has this Delhi Journal of Ophthalmology, which is coming out from GNEC. This low vision rehabilitation with special emphasis on children has started from April 2024 with a strong support from alumni and the government. Just to last, it's very rare that we get a patient feedback. This is a very positive feedback. ये है दिल्ली का गुरु नानक आई सेंटर। यहाँ आते हैं बहुत रोगी जिनकी बिगड़ी है नजर, यहाँ होता इलाज और हो जाती है ठीक नजर। यहाँ रोजाना हजारों की भीड़ लगती है, फिर भी आ जाता है नंबर। यहाँ इलाज कराना पड़ता है जरा धीरज धक्कर, बेशक लगाने पड़ते हैं आई सेंटर के कई चक्कर। ये आई सेंटर चलता है जैसे हो गुरु नानक का फ्री लंगर। निजी आई सेंटरों इलाज करने वाले में जेब खाली देते हैं कर, बड़े काबिल है यहाँ के आई डॉक्टर, रोगियों का इलाज करते हैं और देते हैं स्माइल और आदर। गुरु नानक के सद्भाव का पड़ा हुआ लगता है असर। हम भी कराने गए थे इलाज गुरु नानक आई सेंटर से, हम भी लौटे हैं इलाज से पूरे सेटिस्फाइड होकर। He is Mr. H. Singh, who is an ex-IITian who came for treatment. Vision is our mission and caring our credo. We are the dreamers who aimed for the stars and reached it too. We are the workers who stirred all hearts with skill in our hands, with care in our mind. We ceaselessly light the torch for those who are blind. Cradling light in our fingertips, murmuring a song on our lips, we strive across the seas for the shores of excellence, guided by our gurus and the divine Nanak, we shall reach it too. Thank you all. Gratitude to GNEC faculty, our residents, for support in the book and foundation day. Gratitude to GNEC glaucoma team and Dean Mamsi for being the light for our lives. Thank you so much.
Thank you so much, ma'am, for displaying the bright future, bright present that GNEC has, and undoubtedly the brighter future that is yet to come, and for that beautiful message at the end. I now invite Professor Poonam Narang, Dean Maulana Azad Medical College, to give the guest of honor address.
Good morning and namaskar. I'm so pleased to be part of this activity and celebration that Guru Nanak Eye Center is undertaking today. You have the presence of so many dignitaries, so many seniors who have come to bless you all. I would be amiss if I don't mention the blessings of two prior deans who have come from this institution and have been my, sir, That was before my time, I believe. And Dr. Ritu, Dr. Sushil Kumar, and Dr. Gupta. And they are my leading lights also, my go-to mentors when I have an issue that I cannot deal with. So not only educational acumen, your academic achievements, your skills that you impart, apart from the clinical excellence that you have achieved over so many years, it's befitting that you are celebrating your journey from where your foundation was laid and the magnificent castle that you built on this. Tamaso ma Jyotirgamay should be literally and figuratively applicable to Guru Nanak Eye Center. You not only give us the light of knowledge and skill and make capable doctors and ophthalmologists, you leading the country into blindness control eradication program. You are literally also giving light to people in so many super specialties and subspecialties of ophthalmology that you have brought under this umbrella of this institution. I'm personally aware of the hard work and the passion of your current leader as well as the previous leaders that you have. I know her passion for poetry, her passion for extracurricular art forms. So I'm very, very convinced that ophthalmology, she doesn't only teach you the science of ophthalmology, she is very skillful in the art of ophthalmology as well. And congratulations and best wishes to the entire team and family of Guru Nanak Eye Center. Thank you so much for having me here. Thank you.
Thank you so much, ma'am, for these words of appreciation and motivation. It drives us to push our limits and do better each day. I now invite Lieutenant General Daljit Singh, AVSM, BSM, PHS, to deliver the chief guest inaugural address. Sir.
Professor Poonam Narang, Professor Kirti Singh, senior alumni sitting here. I had an opportunity to interact with some of them when I was here, sitting there with them. The faculty, delegates, and my armed forces colleagues sitting there, Brigadier Mishra and Colonel Lok. Firstly, I must thank Professor Kirti and Brigadier Mishra for giving me an opportunity to be part of the celebrations of the Foundation Day of this great center. Vision is of two kinds, external vision and inner vision or internal vision. First, we'll talk of external vision and then we'll talk of internal vision. That should be okay. Because you are the ones who maintain the external vision, prevent it going down in various fashions, and do all that you can do to ensure that the world is seen by the people whom God has given the sense organs to see the world, perceive the world, and accordingly go along in the world. Dr. Kirti has so beautifully brought out all the things which happen in this great center. The center which started in 1986, 37th foundation, 86, 37th foundation day today. Starting, Dr. Kirti also narrated to me how the land was acquired, how the land has the holy presence of Shahid Baghel Singh, and that how, from Guru Nanak's life, an instance that how a Sacha Sauda was actually happened here, and with a small sum of a small sum of 10 lakh rupees, how the thing started, and it has grown into a beautiful eye center today, the biggest in Delhi NCR, and one of the best in the countries, where you have the subspecialties all the subspecialty which you just saw start. I mean, it's like literally taking the layers of the eye one by one. You start with the cornea and how things are done for the cornea, for the glaucoma, for the retina, for the lens, how you do the cataract surgery, and how in short period, in a short period, already some 10,000 cataract surgeries have been performed in this year. How you take care of the retina and the oculoplasties and squint surgery and pediatric ophthalmology having a special special role as such. Being a pediatrician, I have seen small babies when I was training for neonatology at PGI Chandigarh. We used to have the preterms. At that time ROP had just started. Dr. Mangat Dogra was doing the ROP screening there, and small babies 28 weeks, 26 weeks, oxygen exposure things were still unregulated. How despite the babies would just go blind. Now we call it rush ROP and all those terms we use now, but you would see within the babies would just go blind and retinal detachment, and we could do nothing about it. That sort of things we would send to Dr. Ramurthy Eye Hospital at Chennai, and all that thing. And slowly we saw that how if we could start acting in time. In front of me, I saw how we started acting in time, started giving laser to ablate the avascular retina, and how things started improving. And today ROP screening is a done thing. I mean, it's something which has to happen in any case. In children, the amblyopia, lazy eye, if you don't use the eye, child has amblyopia. To prevent that, we act at the right time, right screening. All these things are so important. So all that is happening in this great center with the footfall of close to 4 lakh, which the figures were given, and in patients going beyond 25,000. That kind of work is happening here. The faculty is involved. The residents are there. The best residents in the country are coming here. 17 residents, I was told, that are pursuing the post-graduation every year here, and their faculty, the senior residents, you're really doing a great job in terms of what the human beings, the doctors as such, can provide in terms of mitigating the suffering and ensuring that the right, as we literally call, providing vision, the light to the people of all levels, starting from children to the old age, starting from the problems in the small babies to the old age. At all ages, you're doing a great job. I must compliment all of you are sitting here, because all of you in some fashion belong to the specialty. I will only use the word vision. I will not use ophthalmology. I will not use eye specialty, because vision is what is important. Vision is what keeps us alive, what gives us a sense of beauty that we can see around. And that's why it's so important that the role that all of you, right from these seniors who are sitting here and all along people are getting trained now, that all of you are playing in various fashions. So that was the external vision. Now the inner vision. Who gives the inner vision? I saw this, let others see what you see. The saint incarnate after whose name this institution has been named. Guru came out. Spiritual vision. There is a transformation which happened in every being. And what was the transformation which occurred in him? The transformation was he's found that everybody is equal. There's no Hindu, no Muslim. That was the vision that he had. And what he did was, when he had seen it himself, he spent his life going all over the world to give this vision. But he had seen that all are equal. Today, all over the world, the Sikhs, what is the prayer that they give in the morning? They say, Nanak naam chardi kala, tere bhane sarbadda bhala. What does it mean? That, oh God, praying to Nanak himself, that things should be in ascendance, things should be moving upwards, and by your will, everybody should get benefit. Sarve santu niramaya. Everybody should be healthy. Everybody should be happy. That is the prayer. And once we have done with all the tasks of providing the outer vision, when we come to this stage, we should be looking inwards. Think of Guru Nanak. Think of the vision that he had provided. And inspired by that, the noble task that all of you are performing, may you continue to perform that task and do good to humanity as you are doing. I thank once more Dr. Kirti Singh and everybody here. Jai Hind.
Thank you so much, sir, for such appreciative words and such positive feedback. We try to set the bar high and try to achieve that and be better versions of ourselves than each passing day. We now proceed to the GNEC Foundation Day oration, Genesis of GNEC. To talk about this, I welcome none other than Professor A.K. Gupta. Professor A.K. Gupta is the revered founder principal of GNEC, who was instrumental in establishing it as an administrative and financially independent institution. He's also been pivotal in numerous academic activities. He started the ophthalmology postgraduate course in Goa Medical College and served as the Dean of Medical Faculty in the University of Delhi. He has authored numerous academic books and has more than 100 publications in journals of international and national repute. Having aced his residency exam and been bestowed the gold medal and the postgraduate student in ophthalmology, to serving as the Dean of Maulana Azad Medical College in 1992, his life has been vibrant and dynamic. I request you, sir, to share those colors with us that painted the history of GNEC. I request Dr. Subhash sir and Dr. Punita ma'am to felicitate sir. Sir, please come on.
Hello. Am I audible? Chief guest this morning, Lieutenant General Daljit Singh, Dr. Poonam Garg, Dean MAMC, Dr. Kirti Singh, Director GNEC, distinguished members of Guru Nanak Eye Center faculty, past directors, past faculty of Guru Nanak Eye Center, distinguished guests, members of press and media, ladies and gentlemen. Thank you, Dr. Kirti Singh, for inviting me for this oration today. I am at this moment the happiest person. You have fulfilled my dream of Foundation Day into reality. Development of Guru Nanak Eye Center passed through many turbulations. GNEC started as a blessing of Guru Nanak Dev Ji. Gurdwara Prabandhak Committee approached Dr. Gurbakh Singh. He became the medium with a grant of rupees 10 lakhs in 1968. He told about this proposal to Professor S.R.K. Malik, then HOD. Money has to be used to upgrade the department, and the department had to be named after Guru Nanak. Professor Malik was a dynamic personality with futuristic vision. He did not think of just purchasing few equipments with this money to modernize the development. He discussed the matter with high-ups in Delhi administration. It was decided to develop a full-fledged eye center. He got a separate piece of land of 3 acres allotted from DDA on Ranjit Singh Marg, where we are today. Bhumi Pujan was performed in 1973 with the blessings of Shri A.N. Jha, the then Lieutenant Governor of Delhi. Outpatient block phase 1 was constructed, where ophthalmic OPD specialty clinics were run. Wards and OTs were still in LNJP hospital. In 1975, due to some unfortunate circumstances, Professor Malik had to resign and leave. Subsequent HODs, unfortunately, did not have the vision for the growth of the Guru Nanak Eye Center. So much so that many of the posts of Guru Nanak Eye Center were declared surplus and seconded to other departments in MAMC. Senior faculty members practicing super specialties felt frustrated, and many of them resigned and left the department. The department was run as if it was a part of a district hospital. The retina section was sealed through the orders of district court due to internal disputes. In 1980, I was posted as HOD Guru Nanak Eye Center on transfer from Goa. On my courtesy visit to Secretary Medical Delhi Administration, Mr. Chauhan, at that time, I was told that most of the time of the administration was wasted in settling the issues of GNEC. And the administration hoped that things will improve with my joining. I assured them of doing my best. I found that the happenings of GNEC rather disheartening. Triangular piece of land of GNEC was encroached by Jhuggis. Children from Jhuggis would come to the central lawn to ease themselves. It was used as a dumping ground for garbage and malwa. Clinical and academic activities were at their lowest ebb. The department was a lonely place by lunchtime. I had to take the then faculty, Drs. Natarajan, Sen, Sota, Das, Mehta, into confidence. I assured them full facilities and induction of new equipments. I also gave them full freedom to do their clinical and academic activities. Dr. Ghosh and Dr. A.K. Grover joined subsequently. Everyone worked very hard. GNSC started getting recognition at the state and national level. One day, Mr. Jagmohan, the then Lieutenant Governor of Delhi, visited for inspection of phase 2 building. I took this opportunity to draw his attention to the encroachments of Guru Nanak Eye Center land. Just 3 days after the meeting, when I came to GNEC in the morning, I saw a huge police force at GNEC. By the evening, all the encroachments were removed and the vacant piece of land was handed over to us. I had never seen such a swift and dynamic person like Jagmohan acting so fast and clearing this difficult problem for us. In 1985, phase 2 building of GNEC was handed over to us. Unfortunately, it had only wards, no OT, no kitchen for patients. We had to remodel one of the wards into operation theater and also got a temporary kitchen block constructed. I got 120 new posts created, and this was done when there was a ban on creation of new posts by the center. Phase 2 started functioning. We conducted a live surgery workshop on extracapsular cataract surgery and IOL implantation with the help of reputed ophthalmic surgeons from Japan who had come to Delhi for the Asia Pacific Conference. Faculty of Guru Nanak Eye Center was the first in Delhi to perform latest techniques of PCE and IOL implantation. Teaching and academic activities of this center had become so popular that the postgraduate students from other institutions like Lady Hardinge Medical College, Safdarjung Hospital, and Army Hospital used to come and attend the PG classes at Guru Nanak Eye Center. In March 1986, Shrimati Mohsina Kidwai, the then Cabinet Health Minister, Government of India, came to formally inaugurate phase 2 of Guru Nanak Eye Center and also declare Guru Nanak Eye Center administratively and financially independent. And this was the day Guru Nanak Eye Center was actually born. Subsequently, more faculty members, Dr. Usha Yadav, Ritu Arora, Usha Kaul, Kamlesh, Sushil, joined the center and support facilities were strengthened further. In 1992, I took over as Dean of MMC. I got the plans and drawings of phase 3 completed. I also got the administrative approval for phase 3 so that there is no hurdle in the future growth of the Guru Nanak Eye Center. Ladies and gentlemen, today what you see as a great institution, it is the result of years of struggle and hard work. It has produced reputed and great ophthalmic surgeons spread all over the country and the globe. Alumni of this institution have won great honors for themselves in various professional bodies. We are fortunate to have even Padma Bhushan and OBEs awardees amongst our alumni. I'm really a proud person today and thank each and everyone who have brought this great institution to this level. Special word of praise, Dr. Kirti. She has been making notable contributions to improve DNEC at different levels. My blessings to you. Today, I take this opportunity to make an announcement. I'm making a donation of rupees 50,000, which will go toward the Best Alumni Award of Guru Nanak Eye Center to be awarded every year. Thank you very much.
Thank you so much, sir, for taking us on the paths we had only heard of and enforcing our belief in the potential of this magnanimous center. And thank you so much for this generous donation and the award that you've instituted. Now, proceeding on to the mega event of the day, the GNEC book launch. A lot of sleepless nights have gone into the making of this book, and I now invite Dr. Ayush and Dr. Sanat onto the dais to hand over the books to our dignitaries. I welcome our dignitaries on the center stage, Professor Poonam Narang, Lieutenant General Daljit Singh, Professor Kirti Singh. I also take the opportunity to welcome our Alumni Foundation President and Secretary, Dr. J.S. Chilana and Dr. Ritu Arora on the dais for the book launch.
Dr. Sanat, Dr. Ayush, the encyclopedia brains of Dr. A.K. Gupta, Dr. Gurbaksh Singh, Dr. R.V. Jain, Dr. Sota, Dr. Das, so many names, Dr. Kalsi, Dr. Natarajan's third picture has been sent. So I'm still, this book is still being in the process of being done. This is the first proof because we were a little late in getting the sanctioning. So requesting all of you to send in pictures of your times in GNEC. And thanks to Dr. Ritu and Dr. Chilana for having the directory of GNEC alumni. That's for our students. They have a mentor-mentee relationship in future. This will be lots for you to stand upon and call on your alumni anytime, and I'm sure they'll come running. So, sir, if you could just, ma'am, launch the book. Exactly what you had said. And the alumni still is being lunch.
I would now like to request all the audience and the dignitaries to join us for the sumptuous and hot piping lunch in the GNEC lawns. The CME will follow after lunch at 2 p.m. Thank you so much. Priya? Sanat को बुलाना. Dr. Sanat? बाहर था वो बाहर. Vishnu? Can you please request the people in the lunch area to join us back for the session? कितने पावर का मंगाना? I'll be around. हाँ. So welcome back after a sumptuous lunch. I hope all of you enjoyed the food. Now that the taste buds are stimulated, let's stimulate our brains with an update on oculoplasty trends. But before that, we would like to felicitate our guest surgeons this morning who couldn't join us here in the auditorium because they were in the OT. I would request Dr. Ruchi and Dr. Paromita to felicitate Dr. Santosh Hunawar for an outstanding contribution to GNEC. I now request Dr. Parul and Dr. Ketki to felicitate Dr. Sushmita Kaushik ma'am for demonstrating such a beautiful surgery in the morning. Please, ma'am. I would also like Dr. Sushil Kumar to felicitate Dr. Ruchi Goyal for her talk, upcoming talk. Okay. So Dr. Ruchi Goyal has done enormous work in the field of oculoplasty. She's an academician that all the residents look up to and a clinician and researcher par excellence. She collaborates with various modalities like dental centers in her oculoplasty and orbital work. We welcome ma'am to widen our knowledge on the trends in oculoplasty.
So good afternoon, everyone. In the next 15 minutes, actually, I'm not going to show the actual trends worldwide, but what we have achieved in the last couple of years and our significant contributions to the medical literature. So I'll be sharing some of the studies which we have done. So I've organized my talk into the 3 subheads. These are the main. We are doing all kinds of state-of-art surgeries in GNAC. And to begin with the orbit, routinely the patients of thyroid eye disease, basically when we are doing a follow-up, we are measuring the proptosis, the IOPs, and those kind of things. So we decided to see that what really is happening because of the orbital space conflict. There is a decrease in the blood supply of the orbital structures. So we decided to study the ocular perfusion. And this is one of the papers which we have recently published in Survey of Ophthalmology. And we all know that the ophthalmic artery and the central retinal arteries, these are the main branches which supply the orbit. And if you see we measured the peak systolic velocities and end diastolic velocities using the color Doppler. And this was being done in the radio diagnosis department in MAMC. And this is the central retinal artery. You can see on the other side, you can see the Doppler flow in the image there. So what we did was we did decompression in these patients, and this is a lateral and inferior wall decompression along with the fat decompression. And we measured the color Doppler velocities before and after the decompression. And you can see this is the fat decompression being done. And after decompression, what we found was that the perfusion increased, and I'll just show you the parameters. Sorry. I'm not wearing my spectacles. It's in the car, so that's a problem. Okay. So you can see the perfusion on this side, it is showing that is the peak systolic velocity which had fallen, which had decreased tremendously. And after doing a decompression, you can see the velocities, the peak systolic velocities at the top. After that, D means the end diastolic velocity. This is more or less okay in the normal, nearer the normal range, but PSV had increased tremendously. So what really happens in a thyroid eye disease was that initially when there is inflammation, the velocities increase, and as the time goes by, the velocities decrease first to the normal level. And once the patient approaches dysthyroid optic neuropathy, there is a chance that the velocities may decrease even further. So this is the time when you need to intervene and detect early. Another, the mucor came, and actually our lives were really upset. But then in the process, we realized the importance of teamwork, and we collaborated. It was not just ophthalmology, but so many departments. Thanks to Dr. Ritu ma'am, she created a mucor task force, and we really, all of us worked hard, and we came up with multiple studies, which I'm going to share in the next few minutes. And normally what happens is that we see that there is we see a patient of orbital apex syndrome because of mucormycosis, and we expect there would be some central retinal artery occlusions also. There were a couple of patients where I was asked exenteration kare ya na kare. Now I wasn't sure, the fundus appeared normal, and I did not know what to do. Then it occurred to me, since we were already working on color Doppler, we started doing color Doppler of these patients. And if you see, these are again ophthalmic artery, you see no flow. The central retinal artery, you see no flow. This is the right eye where the disease, there is an orbital apex syndrome. The disease has reached the orbital apices, but you see the fundus is showing only myopic changes. There is no sign of any central retinal artery occlusion. So, but then this was a documentation that the perfusion was totally conked off. Another patient where this is a patient of ocular ischemic syndrome. Again, I could not see the fundus. We did the color Doppler. This is the eye involved. There was no flow. But to our amazement, what we saw was the ophthalmic artery was thrombosed, but this is the central retinal artery. You can see it's absolutely normal. So what we concluded was that actually in all these patients, the ophthalmic artery was getting thrombosed, and the flow in the central retinal artery got occluded after the ophthalmic artery flow decreased to a certain level. So again, we published it in OPRS. Then, of course, since it was a teamwork, lots of new findings came up, and we realized that actually mucor was not as dismal as it was portrayed in the literature, with 50% deaths and mortality rates. So this was again the anterior ethmoidal vessels and nerves along which the mucor was tracking up, which we saw in multiple patients, which was not reported earlier. Then these were, of course, multiple studies which were published. And then what we found was there was a study in JAMA where they had 36% deaths, whereas in our hospital, where we have treated more than 400 or 500 mucor patients, there were only 5.4% deaths. So what we tried to analyze what really happened. Why was our mortality rate so low? So the teamwork, the prompt institution of systemic antifungals, and reversal of immunosuppression, we had a very good diabetic control happening in our patients, and the surgical debridement, when indicated, was done very fast. So our OTs started running, all 7 days. Simultaneously, we used to do deal with the ophthalmic part and the ENT part. We were operating, and we had very good results. And there were patients who had presented with hemiplegia, and now I'm doing cataract surgery from them. So you can see that things were not as bad as initially we were reading. So this was another paper, and these were the different. Okay, then this is another interesting patient. This is a patient of malignancy with orbital exenteration. We collaborated with the dental department, and we put in these implants into the orbit, and these were allowed to integrate for about 3 months, and then it was coupled with magnetic prosthesis, as you saw in the previous picture. So this was another interesting collaboration which we have done. This is just to show the implants in situ. Then in acute dacrocystitis, classically, again, we are told that you should not operate. You should not do external DCR. The chances are the patient will develop orbital cellulitis. So we acquired laser DCR, and I started doing, I thought that you need to really drain this stagnation. Otherwise, you keep giving amoxicillin and clavulanic acids, and these patients keep coming back with the formation of fistulas. So I started creating a small opening with laser in the acute stage itself. And you can see by 3 days, the patient started recovering so well. And either you could enlarge that opening in the same sitting, or you could go back after 10 days and do the enlargement later. So we published this in Eye recently, and this surgery, I think it is one of the very useful procedures which one can do. Now, the flop side of using a laser DCR was that if you don't use it carefully, you can create these kind of fistulas. So this was really alarming. And after that, I realized that instead of using a continuous mode of laser, you need to use it in pulse mode. And it has to be very, very, very carefully used, because a little mistake and you can create these kind of complications. Then again, we did these patients, the laser endoscopic DCR, we could easily do them in patients with deviated nasal septums in mild and moderate, and in severe, of course, it was difficult to do unless you could get a septoplasty done. So this also we showed. Then this is another which Dr. Nawar is sitting. I got an award for this patient. I'll just show you the video of this is the conjunctival DCR for proximal blocks. It's usually very difficult to treat, and these tubes they keep coming out. And so what I thought was, if you fix the cuff of the tube like you do it in a mirror work, this tube would stay back. So this is again a laser DCR being done. The laser osteotomy is created, that unlike the routine DCR where you create a larger osteotomies, here you create just about 4 to 6 millimeter osteotomy, and this is the endoscopic view where you can see the opening has been created. And just watch this tube, which is the bypass tube or the Jones tube. This is a glass straight tube without any holes. This you just push it in, see the correct position in the nose using the endoscope. And this is a 6O proline. The first eye is taken around the neck of the tube, and then you create a mesh as you do it in a mirror work. Any of the girls who enjoy embroidery would have definitely done this sometime back. And you create a mesh and then you anchor it to the adjacent conjunctiva and episclera. So this really helped, and we had very good results. And this is just to show the animation, and I'll just forward it. This is, anybody interested can just see it on the IGO website. So, and this was another study for proximal blocks where we compared the retrograde canalicular retrograde DCR with conjunctival DCR. And this is, you can see, this is the anterior segment OCT image of the pseudopunctum which we have created. I'll just share a video of this. So here, instead of in proximal blocks, sometimes, it is difficult to do other procedures, and they tend to, even if you do a cannulation, they tend to fail later on. So what we did was, using the patent portion of the canaliculus, we created a pseudopunctum. And this is the internal ostium, internal normal canalicular opening, which you can see, and you pass a probe retrogradely and create a opening in the patent part of the canaliculus. And we had good results in these patients, but patients who had a block which was more than 5 millimeter from the punctum, the chances of failure were high. So this is another study published in Canadian Journal of Ophthalmology. And this is just to show how these, the mirror tuck technique, these are the actual openings which we saw after 1 year of the surgery. And the disadvantage again of the laser conjunctival DCR was that since the sac remained in situ for, and unlike a external DCR, there were the remnants of sac started collecting the mug and got infected. And this patient developed a sum syndrome, which was usually not seen in a conjunctival DCR. So coming to the lid now. So the classical treatment of punctal and involutional ectropion is, of course, we are all doing tarsal strip procedures, and wedge resections are more or less gone out now. But there would be patients who are very morbid, and it is sometimes difficult to do a prolonged surgery where Prolene suture was used, and this was a 5O Prolene suture which we used to anchor from the medial canthal ligament and the adjacent area to the lateral canthal ligament. And we had very good results in both moderate and severe ectropion. The only problem was that the suture had to be buried properly. Otherwise, since Prolene has a chance of extrusion, so this is the problem which could occur. Then we compared the lateral tarsal strip, the classical procedure, with the Prolene suture, and we got comparable results. Of course, lateral tarsal strip is the gold standard, but you can use this, the Prolene sling, in some patients where you need to do a quick surgery. Sometimes very sick patients are there. Okay, so just the last one. Sometimes, when you're doing a sling procedure, it appears very easy for doing in a severe ptosis when you're doing the silicone sling. But there would be patients like blepharophimosis where there is a lot of shortening of the lid, and sometimes when you're trying to pass the silicone, upwards, that is the straight needle upwards, it tends to get stuck, and you really fiddle with it, and you cause a lot of trauma. So it just occurred to me that why not use a 18 gauge intracath, and you just pass it downwards, and you dock the straight needle onto the silicone into it, and then pull it up and make things much more easier. So this is again a very interesting, easy innovation which I found, and we use it sometimes when we are having problems. So thank you so much. I'm really grateful to, of course, Dr. Sushil sir, all the residents, not only the current batch, but all the residents who have been there working with me for so many years, and so many departments I need to thank, for which all these, because of which these publications have been possible. Thank you so much.
I request Professor Sushil Kumar sir to please felicitate Dr. Ruchi. Thank you, ma'am, for such an informative talk and widening our horizons. I welcome GNEC alumni GNEC alumni who has always been in constant support of GNEC and contributing towards major activities that happen here. We welcome President Dr. J.S. Chilana and Secretary Dr. Ritu Arora. I would like to call upon Dr. A.K. Gupta, Dr. J.C. Das, Dr. R.B. Jain, and Dr. Gurbakh Singh to felicitate Dr. Ritu Arora and Dr. J.S. Chilana and Dr. Naushi Shroff, sir. Dr. Chilana and Dr. Ritu Arora, ma'am, please. GNEC alumni, sir. Dr. Sanchita, Dr. Saksham. Now let us go back down to the memory lane and take a journey from what GNEC was in the past to its present endeavors. For the cornea services, I invite Professor Ritu Arora and Dr. Parul Jain on the dais for the discussions, and Dr. Gaurav Luthra to talk about the then aspect, followed by Dr. Avni for the now part.
A very good afternoon to everyone, and it's really a great feeling to be back to Guru Nanak Eye Center and reliving some of those days which we, I fondly cherish, and lots of memories have been coming back, and I'm really grateful to Dr. Kirti and the faculty of GNEC for inviting me to be with you all today. And in fact, I'm grateful for also being pushed to come over today because I was trying to wriggle out a little bit, but it's all been worthwhile. And very impressed with so many the orations and everything. So I'll quickly try to talk. I was reminiscing a little bit about the corneas, that we dealt with that time, and I did it my MS ophthalmology, and then I did a senior residency. I was posted. I was lucky to be the last PG for Professor A.K. Gupta sir when he went over to become the dean, and with Dr. Ghosh, Dr. Ritu, and Dr. Anju, and of course everybody else, Dr. Das and Dr. Sushil and Dr. All the other teachers who were there, Dr. Sota sir. And I look back at the eye bank clinic, as we used to call it, the EBC. I don't know if it's still called the same, but this unit used to be part of Unit 1. And I remember the eye calls and Boss's Gypsy, which used to take us at night with Mr. Kantaram, who used to be there. And he used to be helping us. And amongst others, there were two other people, I'm forgetting their names. But those were the amazing days. And we used to be so enthusiastic for going for those night calls. A little sometimes, kind of trying to wriggle out, but most often it was fun to go. And this brought me for my first trip to Paranthe Wali Gali at 2 a.m. And, I was there in the month of June sweating, and I was, there was a eye call which I had to take. I had to bend down and kind of retrieve it. And I can't kind of forget that. So that was my first trip to Paranthe Wali Gali anyway. So, we were quite excited about getting some suturing for the PKs. And I remember Dr. Ritu and Dr. Anju doing beautiful suturing and us trying to emulate that. And my first therapeutic PK, when I got it from Dr. Ritu ma'am, and I was again went back thrilled that I finally got to do one. I don't remember whether it was during PG or senior residency. And I was thinking back, and I realized that I don't know how many of you will relate to this, but I think every patient, I think 50% of our patients used to get this instead of a lubricant. Today, how we write a lubricant, we used to write this thing, and it was made in GNEC, if I'm not wrong. It was actually made in the pharmacy and dispensed to patients. And then the first lubricant drops came up, and suddenly we were all so excited that finally we have a lubricant available to us. And today we all take it for so much for granted. Ma'am, was this the first lubricant that came out, or it was not the first one? But which ones? They were amongst the first ones, right? TS Plus was the first one. I thought this one came even before that. I'm not sure. And then a lot of Mezol prescriptions. And, I was looking back at what might have changed so much drastically in cornea. So keratoconus management, it used to be a rare diagnosis when we were there, and we would look at scissoring on retinoscopy. I don't think we had access to topography at that time. I do remember in the exams being shown a Placido's disc and us trying to use it sometimes. But we used to look more at the gross signs, as on the right side with, Vogt's-Try and Munson's sign and Risotti's sign. It was grilled into us. And today we don't even think about all these things because we picked them up so early with OCTs and everything and epithelium thickness mapping. Eye rubbing was not even a concept at that time. I don't think so. We used to get to see quite a few eye drops. And then the treatments, we frankly never did any treatments for keratoconus except end up going for a keratoplasty in the end. So what a huge transformation today with all these things that are available to us. And I don't think lamellar surgery was there at all at that time. We only used to do full thickness. Today we would do intact CXL, topo-guided PRK CXL, so much that we can do today. Diagnostics have, completely changed. We used to do slit lamp examinations, most basic, Shermer's, maybe a fluorescence stain, and Placido's disc and aesthesiometry. I remember ma'am teaching us. And trying to wriggle with specular reflection. I'll just finish in half a minute. But today we have access to epithelium mapping, pentacam, speculars. I don't remember we had a specular. I'm not sure we had one at that time. And anterion kind of images, which are amazing. Our surgical exposure was amazing. I'll finish in 2 slides, last 2 slides. we got so much of perforation repair, which really helped us. I mean, almost every emergency we were given something to repair. Suturing all the cataracts at a good pace for sir and for Dr. Ghosh and everybody else, trying to finish their cataracts. Lots of pterygias, traps, DCRs. Nobody wanted to go to the DCR OT. Lots of buckling under Dr. Ghosh. Yeah. Because it was that last OT on the left side, I don't remember, but a lot of scleral fixations I learned. I learned a lot of pediatric cataract, epilenticular cataracts, and lots of other things. It all helped me in great stead. We got a lot of entropians, and of course, nobody want to go to the evisceration OT. And refractive surgery is something which I'll finish with. We were all taught that refractive surgery is probably not a great thing to do. It's unethical or whatever. I mean, we were always used to look down upon people who were doing refractive surgery at that time in the private sector. And we heard of the first examiners coming up, Dr. Daljit Singh doing -20 PRKs at that time. And I never wanted to do refractive surgery when I left GNEC, because I used to think that this is not, something that people who are, in academics want to do. And it took a few years for me to change that. And some of the anecdotes, midnight welding calls, I'll never forget those. In fact, my children are doing their post-graduation. I asked them ki raat ko 2 baje wo aati nahi hai welding ke baad wali calls. They say, no, we don't get them. They all go to GNEC. So, and the morning rounds, which we were really scared of, we were preparing it like late night and early in the morning, and the chai samosa breaks. So to conclude, I think all we are doing today is one way or another from what we learned in GNEC. And for me, at least, it's like that, and from all our teachers. And I can never be grateful enough for those invaluable years of learning that we had here. And I'm really wishing, after seeing everything and how GNEC is reaching greater heights, that it reaches the pinnacle of ophthalmology in the coming years. And, we should all be really proud and work towards bringing it there. So with that, I'll stop. Thank you so much.
Dr. Avni is the current senior resident, so.
A very good morning to one and all present here. Hope you are having a wonderful time. Speaking about the now and cornea, where do I begin? The list is so long. It's not moving. There's so much to do. We'll discuss our talk in 3 subheadings: corneal transplants, refractive surgeries, and keratoconus and CXL. This is our eye bank right now. And it's great to see how the number of eye retrievals have increased in the past 10 years. And a record of 600 eyes retrieved in the year 2022 with 144 PKs done, and an exponential increase in the number of DALPs and DSECs, approximately 81 done in the last year. The number of DSECs have gone up so exponentially, mainly due to the HCRP, which we consider the lifeline of eye banking, which has helped us obtain optically really good tissues for DSEC and a utilization rate of about 80%. Not to mention the special partnership, the public-private partnership we have with Shroff Charitable Eye Hospital, that helps us get pre-cut DSEC tissues as and when we require. Coming to the refractive surgeries, in the past 10 years, we've done approximately 5,000 eyes of LASIK, and the redo rates have been surprisingly low to 0.001%, and not a single case of keratoconus that has come to us. We attribute this to the detailed investigation and workup we do of the patients and the meticulous follow-up. All this, obviously, we have stored in our physical and computer forms. In keratoconus and CXL, like Sir said, it was a rare diagnosis earlier. Our cornea OPDs and clinics are filled with patients of keratoconus. And the number of C3R surgeries done in the year of 2022 was 78, using the conventional C3R, pulse accelerated, and the hypoosmolar and contact lens C3R. Now, we've also done a lot of work in this field, and it has been recognized. A case report in the BMJ of unusual association of keratoconus with situs inversus, a case report in contact lens regarding sterile keratitis in a child after CXL, a comparative study in cornea regarding the topographic changes post-CXL in advanced keratoconus, a paper in international ophthalmology regarding contact lens fitting post-CXL, a paper in journal and refractive surgery regarding results of CXL in pediatric patients, a poster in U Cornea in 2014 presented in London, a IGO case report of keratoconus misdiagnosed as meridional amblyopia, and a IGO review paper regarding the
complications of CXL. A few papers in the field of keratoplasty in the American Journal of Ophthalmology regarding DALC for advanced keratoconus in pediatric eyes, and in Eye and Contact Lens and European Journal of Ophthalmology regarding corneal parameters in D6 and DALCs. Beautiful work done in the field of ocular surface reconstruction. Paper published in BMJ regarding the immunohistochemistry of ocular surface post slit and claw for chemical burns, showing amazing illustrations of pre-operative and post-operative surgeries done post slit and claw, showing complete reversion, a few cases of incomplete reversion, and a few cases of residual limbal stem cell deficiency. A paper in IGO which is widely cited, comparing slit and claw for severe ocular burns. A beautiful report in IGO with amazing results in a young patient with severe chemical burn who was treated in the first sitting with AMT and later on went on with the PK with autologous limbal transplant, followed by a cataract surgery with the end result of a very happy patient and a 618 vision. Lastly, a few papers in the refractive department in contact lens and eye analyzing the refractive outcomes of wavefront LASIK and wavefront PRK in eyes with higher order abrasions. A RCT in Journal of Refractive Surgery comparing wavefront and aspheric LASIK in myopia. The list is obviously never ending. In the end, what defines success is patient and surgeon satisfaction. This is a picture from the eye donation fortnight in 2021, where we did a record breaking of 12 corneal transplants in a single day. And special thanks to our eye bank staff, OT staff, nursing staff, and especially our patients for trusting us. Many more accolades to come our way, as this is just the beginning. Thank you.
I think they've said it all. They've said it all. And
it's wonderful to see the cornea journey. I now request the retina services on the dais. Professor Meenakshi Thakkar and Professor Punita K. Sodhi, ma'am. And I would like to request Dr. Sandhya Makhija to talk about the then services, followed by Dr. Shruti Bhattacharya, who's a senior resident in the retina team, to talk about the now after that.
Good evening, everyone. And I'm so happy and honored to be here in front of you in my alma mater. And I especially thank Professor Kirti ma'am and Professor Subhash Daria for giving me this opportunity to be here. I can't start my talk before my pranam to my mentors. So I was given this topic, retina services, then. So just to, it's not going ahead. Sorry. Okay. Okay. So let me take you some time back in some years probably back in mind. So I was here till 2002. So my talk will be like based on that era. So these were the retina clinics we used to have. Same busy retina clinics full of patients. Some would be happy, some would be unhappy. Same scenario as per now. But the difference is a lot. So when we talk about diagnostics, we started with direct ophthalmoscopy. So when we were learning, we were so enthusiastic that we would get hold probably of anyone actually to practice our ophthalmoscopy skills. Indirect also we started, we were very keen and enthusiastic and jumping on to learn to indirect ophthalmoscopy, and we will ask our seniors and residents and teachers, everyone to teach us and figure out kya seedha hai, kya ulta hai, charting. It used to be so confusing that, which is 12 o'clock, which is 6 o'clock, break kahan hai, and we were so happy seeing a break. Oh, this is a break, we found a break. Don't know, it was actually a break or something else. But those were the times. 90D and 78 examination, they were just starting. We started with our 90D and 78D few years later, and we used to really save on to our pocket money to buy 90D or 78D in the next forthcoming conferences where we would get a good bargain and good deal. And just a small little thing, in these 90D, I want to go back. Okay, can you see this 90D pink in color, such a cute pink color? We never used to have these colored 90Ds. We used to have simple, black, boring 90Ds. Okay, then FFA, it was the most sought after investigation. FFA clinics were full and it was not easy to get early dates. And because we were using these reels wala cameras, and the reports used to take a week to come. We used to just click pictures, never knowing it's come correct or no, it could be just a blank picture also. Then we would send these reels to Mahata the photographers at Connaught Place, and we used to get them developed, and they would come back, and then we would see, oh no, ye to theek aaya hi nahi, all those things. ICG also had just started. Digital fundus cameras just started at about 2002 to 2005. And then, of course, the sky was the limit. Can you imagine a retina clinic without an OCT these days? But we used to do. OCT actually totally changed the face of retina diagnostics and management. So we worked actually without OCTs, if you can imagine those times. OCT was first introduced in 1991, but true commercial OCTs were available much later. That time also the machines were expensive, they were big in size, they were so slow, like as slow as 400 scans per second, which we can't even imagine now. They had poor resolutions and many errors due to eye motions and everything. Retinal photocoagulation, we have seen even those big argon lasers, which were like big and they needed water console. Even in our GNEC retina laser clinic, we used to have initial argon lasers we have seen at our times. Then came double frequency YAG and smaller, better equipments, and lots of things. We used to do photocoagulation, laser barrage, and some little PRPs, or they used to take so much of time, and they were slow, and patients were given lot dates, weeks later. So, and then we also were doing cryopexy. Cryopexy treatment was quite in vogue these days. Prophylactic cryotherapy. We used to do anterior retinal cryotherapy, like 360 degrees or partial cryotherapies for vitreous hemorrhage for advanced PDRs. As in now, like people just going for a vitrectomy for any advanced PDRs. Wet ARMD treatments have really undergone a big change. We used to do focal photocoagulations and see a lot of scarrings after photocoagulation. We have done transpupillary thermotherapy, even for subfoveal or juxtafoveal membranes. Even these kind of big membranes, we have undertaken them for a TTT using a red laser. Photodynamic therapy had, it was in big vogue those days, very fascinating. We used to really fascinated to see like, oh, PDT, this patient ka kiya hai, iska ye. So, and a lot of papers, a lot of conferences we used to hear about PDT, and it's very fascinating. These were the side effects of PDT treatments. Sometimes feeder vessel treatment of a CNVM, that came for a very short time, and that was in vogue, and people tried, and with okay, good results, but of course, it just went off. Intravitreal treatments were just limited to IVTA, posterior subtenance, intravitreal antibiotics, or maybe sometimes dexamethasones. Prophylactic cryo procedures were done, but we did have like big boom like intravitreal anti-VEGFs or implants. Surgical retina was limited to primary buckling, thorough time spending, retina charting, pre-operatives. Residents would spend whole night, and next day we have to show chart to our consultant. So it was like a nightmare. And full conjunctiva peritomy being done, heavy indirect on head, and spending hours and hours finding hole and cryo and buckling and all those things. It was a struggle. Let me not go into these debates and details. I mean, these are just, always debatable, that do we still need buckle in vitrectomy era? But probably, yes, we do still need buckle, and one has to have a knowledge about buckling surgery. Probably for retina residents, I will say yes. Advantages, okay, let me just go further. Okay, vitreous surgeries, we were primarily starting with 20 gauge surgeries. So 20 gauge we were still learning. Even our professors, consultants were still learning, putting the machine on and putting the tubing connections, and they had low cut rates and poor controls, not very good dynamics. So it was like a full day task. After finishing the whole routine case, then we used to start having a VR case, a vitrectomy wala case lagega, machine lagegi, set hoga, all these things. We had lack of skill, confidence. Posting a vitrectomy case was a task. Complicated cases like TRDs or RDs or PVRs, macular holes, they were basically left untreated, you know. So in the end, whatever, we were all like happy residents, and after all the day of hard work, we were like always happy and so proud to be at GNAC. So these were like few of my pictures from my then moments. Like probably we must be like weird, and I think we are weird still today. So, and I thank you GNAC for making me worthy of standing here today for what I am today. Thank you everyone, all my seniors, my colleagues, my juniors, my friends, and my mentors. Thank you.
That was so nice, Dr. Sandhya, remembering all the old times. And we also have some happy memories of you being here. So now I invite Dr. Shruti Bhattacharya for the now of the retina part. She is one of the senior residents in the vitreoretina unit.
Good afternoon, everyone. I'm Shruti Bhattacharya. I'm one of the SRs in the retina unit, and it's a great honor to be here today in front of all of you. I'll be talking about some of the innovations that we have adopted in the recent past. So we have a twice weekly retina clinic, and we have a twice weekly retina OT. So in terms of investigations, we've moved on from time domain to SD-OCT to the new HD-OCT with extended depth imaging that we have. This is a photo of the old time domain OCT that we used to have. And this is a photo of our own OCT of a macular hole. You can see the different layers, the extended depth. The next thing that we have is a OCT angiography. This is an image from one of the studies that we have published. There's a macular hole in a patient with the Eales disease. As you can see, apart from the macular hole, in the deep complex as well, we can see an enlarged foveal avascular zone. This is an angiography analysis of a patient with diabetes. This is the OCT angiography of the optic nerve head showing a neovascularization. We also have a new wide field digital imaging system that's primarily used for infants. It's called the 3-Netra Neo HD-FA. Can be used for fluorescent angiography as well, primarily for babies with ROP. So this is a photo. This is how we take in the computer. And this is an image from one of our babies with ROP. In terms of imaging, we have fundus photo, autofluorescence, and angiography. There's an image from one of our published studies, patient with Stargardt disease, and an autofluorescence of the same patient. Lasers in retina clinic, we're doing pan-retinal, sectoral laser, scatter laser, and macular lasers along with LIO. We have single spot as well as pattern scanning mode as well. We've moved on from 20 gauge sutured vitrectomies to 23 and 25 gauge sutureless vitrectomies, which has reduced the time and the surgical post-op recovery period. We've also moved on to non-contact viewing systems. We're using the one here, pictured here, beside. In terms of surgeries, we're routinely using anti-VEGFs. We use Razumab, which is a biosimilar ranibizumab. We are also performing anti-VEGF assisted surgeries, along with PFCL assisted VR surgeries for complicated retinal detachments. Along with macular surgeries, this is a photo from one of our published studies showing a stained BVG tag. Thank you so much. Now invite our consultant, Meenakshi ma'am, for a discussion.
Yeah, ma'am will summarize now and then and now.
Thank you so much for enumerating all the then and nows of retina services, Meenakshi ma'am.
So it was so nice to hear from Dr. Sandhya what we used to do, and it brought up a lot of memories from the past. I thought I'll summarize the then and now because I am the only person who was then also and now also. So I've got 2-3 slides. So when this topic was told to me then and now, it set me thinking, and I went into my archives and looked for some very old videos. You know, they're not very good quality, but I'll just show you 2 short clips of the surgeries that we used to do then, and how, you know, we used to have a pumping heart that, oh, what is going to happen to the patient. And really at the end of it all, some were successful, some were not too successful, and we never knew who is going to be successful. So this is the first video. Can you decrease the volume? So maybe you can just see a small on the left side, very small hole, peephole like. This was actually a case of grade 4 dislocated nucleus in the vitreous cavity. And one of my first cases, and this was referred by one of our consultants only, and they told me that please do a good job because he is elderly and one-eyed patient. So my heart, you know, you can imagine how it was pumping. So at that time, what we used to do, no PFCL, nothing. We would take a V lens and we would, you know, ream it inside the thickest portion of the lens. And it helped that the nucleus was like a brunescent, because you could really ream it in like a screw and then levitate it. You can see, you know, after freeing the nucleus here, maybe you can, maybe you can't, but you ream it in and then you bring it up, and with the other hand you open the section, and by that time your heart is stopped pumping and you are like, oh my God, is it happened? So this was what it used to be. So over here, you know, if you can see this, the next step, I could not take a picture of actually me reaming it because it fell 2-3 times, believe it or not, before I could get it on. But finally I managed to get it on, and people today, the surgeons of today would think, oh, how could this happen? You know, even in very soft nuclei, they need a PFCL. And I tell them, don't use hospitals money for these stupid cases. You know, PFCL is so expensive, but they don't understand. So finally, you know, successfully it has come out. This was another old video, and this was, you know, in those times for endophthalmitis, we used to do a 2-port vitrectomy. Nobody had heard of 3-port for endophthalmitis cases, because everybody thought that you have to basically clear up the toxins and the pus and then inject intravitreal. That was all there is to it. So this was one of those cases where we actually went very near to the macula. You can see this is a macular hypopyon, like a garland of small beaded pus points. And it was very satisfying because this was one of our first cases and the patient did very well, and we could actually clean up the whole of the retina of any residual pus, and it was a great experience. So if I was to talk about then and now, and so many things have changed, but if I were to talk of just the top 4 innovations, of course, now we have the Octa, and these are the beautiful pictures that we have from our own patients, and you can maybe see that you know, the whole fundus is beautifully, all the vessels are delineated without the need for injection of a dye. And moreover, more important is that it is not only, you know, sometimes you see a normal FA and the FAZ is not enlarged, everything is fine, but there is an unexplained visual loss and you don't know why it has happened. In this, you can actually see all the plexuses, the deep as well as superficial, and you know really what is going on. So, you know, this is one of our patients who had dengue fever, and post dengue fever, his vision would not recover. And we were very surprised. We did FA, we wanted to document that case. Finally, what we found was on the Octa picture, we found the superficial and the deep plexuses were enlarged. And not only that, there was a very strange finding here. So that finding was that this is the choriocapillaris layer. And we had not even, you know, looked at it clearly. But one of my very bright residents, she pointed it out that these have flow voids. And we looked up in the literature and found those flow voids are an indication of acute macular neuroretinopathy, which was a strange kind of a word for me because I'm a, as I say, a old timer. So this was another study, and this was, we did a study of patients of Eales disease, and we did Octa for all of them. And we found that, and it was a big series, that what we used to think of Eales disease as a peripheral vasculitis, nearly more than 50% of the patients had a central involvement also, which is a, you know, totally different perspective given to Eales disease. And of course, the innovations that helped were smaller and smaller gauges of vitrectomy Now I have said that no more, nothing smaller. I can't handle more than this. So I'm sticking to my 23 gauge and sometimes 25. So what is the greatest benefit is that initially, for 20 gauge vitrectomies, we used to have many post-op retinal detachments, which were port related. And whenever you gave it to a junior to do the surgery, you were always thinking that, okay, next day it will clear up, but what will happen after 1 month? The patient will return with a retinal detachment. It was a very high incidence. But now you don't have that because there is a bung through which the trocar and cannula system through which the instruments go in and go out, and that track is prefixed. So you are not causing so much damage to the base, ora base. And I think the newcomers have not seen so many post-op retinal detachments after vitrectomy. Then, of course, the PFCL has helped us greatly. And the case I showed, I would have never imagined without PFCL in today's era. And, you can do so much with PFCL. You can unfold the GRT. You can release the pucker. So many things have become easier with PFCL. And this was one of the first cases where I did a anti-VEGF assisted PPV. Because, up till then, this was a case of Eales disease. And you can see that he had a this very TRD and a deadly looking neovascular membrane which on fluorescein leaked. But we could achieve this kind of result because otherwise, if we had done without anti-VEGF, this would have kept bleeding while we were peeling, and we would not have been able to give him a successful outcome. And of course, anti-VEGFs we can never talk enough about, so I'm not talking at all. Now, the last slide is, and one of the greatest innovations for me personally, I think the greatest innovation is indirect ophthalmoscope, which is like wireless. Because in the OPD, I just use it as a direct ophthalmoscope, wearing that hat off and on, off and on. Otherwise, it would just cause a severe headache by the end the OPD was over. So that is, in my personal opinion, the best innovation. Now, not all new is good and not all old is bad. What I feel is that because of the so many new innovations, new technology in the instrumentation, as well as the new investigative tools, people have lost the skill of being good clinicians. And I think over here in the first row, I can say about all the people sitting here in the first row on my left side, that those were the actual mentors who taught us and who focused more on acquiring a clinical skill. Because if you don't have a clinical skill, if you've not diagnosed it properly, no matter how many injections you keep pumping into the patient's eye, he's not going to gain anything. So thanks to them. And I feel that you have to have a balance. You have to become a good clinician first and then go on to the the glamour of new things. Thank you.
Thank you, Dr. Meenakshi, for summarizing then and now.
Thank you so much for the retina services discussion. Moving on to the strabismus services, I'd like to call upon Dr. Subhash Dadia and Dr. Paromita Datta on the dais, please. For the discussion, we welcome Dr. Savleen Kaur for the then part, followed by Dr. Himshikha, who's a senior resident in the strabismus services, discussing the now part.
A very good afternoon, everyone. And thank you so much, Dr. Kirti and Dr. Subhash, for having me here. When I'm talking about the strabismus surgery, then I'm actually talking about the time period, not so back, but 2008 to 2011 when I was here. I was, again, very inspired by the last two talks. I was thinking, how do I, reminisce the GNAC at my point of time? But then again, I had the same problem. I did not have any photographs. My Facebook account was opened in 2011. So I had no photographs before that. We did not have smartphones. So I called a few people, and I have very good friends sitting in the audience who gave me some photographs from some special occasions. And sometimes we used to have those handheld cameras, because those Sony CyberShot cameras that we carried around for our thesis. Because in strabismus, I don't think much has changed in the surgery per se, but the planning, yes. So this is the person who actually, the first person that I saw strabismus surgery being done was Dr. Kamlesh. And he took me to Atlanta, and I've shared these pictures before because I was just 3 months into my residency when he said that you know, come along to American Academy. And he was the first person that I saw doing a strabismus surgery. I realized I did not have a single photograph with Dr. Subhash. He was in the sister unit, and he has been giving me opportunities throughout my life when I was a resident, when I was a senior resident at PGI, and he still keeps giving me opportunities which I have never got the chance to thank him for. And now I make it a point at every conference I meet him, I click a picture because I don't have any pictures with him as well. This is one photograph I really like because one person sitting right there, Dr. Anju, she was the one who inspired me to do pediatric ophthalmology and not just strabismus, to look at the child as a whole. And that is what I like doing in pediatric ophthalmology till date, the best thing. One of my friends, Dr. Sonal, we were a Tigdi, Dr. Bhavna, me and Dr. Sonal, and she was the one who thrusted Rosenbaum in my hands because I was never studying strabismus, and she was the one who actually made me study strabismus. So thank you for that. And this is a picture when we used to have a tradition that we, you know, the first years when they joined, we used to go out. You recognize this person sitting here? That's Dr. Parul. She was the first year and she just joined, and we are right here. We are the second year batch. And you can recognize Dr. Ghosh, Dr. Meenakshi, Dr. Anju is smiling. Dr. Kirti was very, very approachable at that time as well. You know, this is one of the junior residents, and Dr. Ritu is shouting instructions, you know, sit ear-wise. So this is first, second, and third. You sit ear-wise, and you see Dr. Usha and Dr. JL Goel. Yeah. And Dr. Meenakshi. So this was the first photograph that I had on my Facebook account. That was 2011. So these are the memories that I think I have of GNEC, just to show you. But strabismus surgery, I don't have any videos. I don't have any thing to show in strabismus. There used to be one clinic running in the afternoon, and the strabismus surgery part hasn't actually changed over the years because the 4 principles remain the same. You either loosen a muscle, you tighten it, you reduce the length of the arc movement arm of the muscle, and then you change the vector. So I'm just going to show you 2 basic things that have been constant throughout a career in strabismus. That is, you recession, you shorten the distance of the muscle from the region, you disinsert it and put it at a separate place, and it induces a laxity in the surgery. So the surgery itself, I'm just showing a fornix incision because this is what I have been, you know, I was lucky enough to see 2 surgeons operate here and then 2 another surgeons at PJ. So I have kind of had the opportunity to combine those 2 approaches. So I'm using a fornix incision through a small hole in the intermuscular septa. I'm hooking the muscle because it's a fornix. I have an assistant who's helping me. The overlying conjunctiva and the tenons is retracted from the muscle. Sorry, I've just started. Sorry. So once you have the muscle hooked on, you just tie it. You separate the intermuscular septa and the tenons overlying and give a snip. And this is basically the same for every strabismus surgery, the isolation part. I usually use a blunt tipped cotton applicator to denude the muscle sheath, and I do not cut it. So now I have isolated the muscle, and after this, you decide what you want to do. So you use a double armed vicryl suture and you pass it in the bulk of the muscle and 2 tying knots in the end. So in resection, what you do is the opposite of what you have already done. You first cut the muscle, decide what you want to do, cut that part, and then you reinsert the muscle at the original insertion. So in this section, again the initial parts are the same. Again, I'm giving a snip in the fornix, trying to extend it with the help of a tenotomy. Again, overlying tenons is separated and the conjunctiva is retracted. Once I have hooked and once I have tied the sutures, I have tied the muscle back at the insertion site. Now, muscle plication is one procedure which has always been the same. So it was an old procedure and it has come back now. So I think it has been there with us forever, just that we have started doing it again now. It is just a muscle, is plicated onto the sclera. So in this, you do not cut the muscle, you do not ligate any vessels, you're not, compromising the anterior segment circulation. You're just isolating the muscle, you're passing sutures, and then you're folding the muscle on itself. So it is primarily a strengthening procedure or a tightening procedure, as people like to call it, because you have passed sutures and now you will resuture the muscle back to the sclera. you use a blunt tipped hook or maybe an iris retractor to fold the muscle over onto itself. So once you have folded that, I mean, this is a vessel sparing procedure because the muscle is now folded onto itself. I would just want to show this picture to the residents that we used to do on loops. Okay, some of our faculty, you might have seen some people do it. Dr. Pandey used to operate with loops, and we have now moved on to the Ingenuity. But I spent some time in UCLA, and still people use loops to do strabismus surgery. It's not an old thing. It's these loops are really, really customized. They are very costly, and they are built according to your IPD. And I think that way strabismus surgery has stayed the same because you see people still operating under loops for so many decades now. I would like to acknowledge my mentors at PJ, and thank you, Dr. Subhash and Dr. Kirti, for giving me this opportunity.
I invite Dr. Himshika to speak strabismus surgery now.
A very good afternoon to everyone. I'm Dr. Himshika Agarwal, working as a senior resident in Guru Nanak Eye Center. Ma'am, how do we change? Conceived in 1971, GNIC has been providing comprehensive quality eye care to not just the residents of Delhi, but also patients from other states. Adding on to what my esteemed senior has already presented, GNIC has grown by leaps and bounds over the past few years. Be it research, medical, or surgical innovations, its growth has been multifaceted. Today, I will be discussing what all progress we have witnessed in strabismus services in GNIC in the past few years. Under the able guidance of Dr. Subhash Tadia, more than 6,000 patients were satisfactorily examined in our squint clinic in the year 2022. A newly acquired OCT machine has made it possible to use anterior segment OCT to identify anatomical location of recti, especially in cases of strabismus resurgery. It is also being used routinely for post-traumatic strabismus, thyroid disease associated with muscle hypertrophy, and congenital muscle anomalies. Minimally invasive squint surgery is being routinely performed in our center. There has been a steady trend towards minimally invasive surgeries across all surgical fields because it reduces trauma, post-op patient discomfort, hospital stay, working disability, and economic impact of the surgery. In this procedure, after applying limbal stay sutures, two para-insertional radial cuts are made 1 millimeter smaller than the amount of desired recession, and the tunnel is dissected under the tenons through the radial cuts. The muscle is hooked, sutured, and cut at the insertion. Recession, in this case, a hangback recession is performed through the minimally invasive opening, and para-insertional cuts are sutured with 80 vicryls. We are doing MISS for the recti as well as for the inferior oblique muscle. The advantages of MISS include that it minimizes the visibility of the surgery. It reduces the frequency and severity of corneal complications. Contact lens wearers may resume wearing lenses earlier. There's improved patient comfort, reduced foreign body sensation, less scarring to the perimuscular tissue, which makes it easier for resurgeries, and it preserves most perilimbal episcleral vessels, decreasing the risk of anterior segment ischemia. We are routinely doing hangback and anchored hangback recessions in our center, especially in cases where a large recession is required, high myopes, and other patients with scleral thinning in whom risk of inadvertent globe perforation is high. Anchored hangback recession has the added advantage of preventing post-op muscle creeping and slippage and better maintains the width of the muscle. There is a surgical video of anchored hangback recession. In this, a conjunctival incision, limbal conjunctival incision is made and the muscle is exposed. The muscle is hooked and blunt dissection is done. The muscle is secured with 60 vicryl sutures. After securing the muscle is cut. And here we were, the patient was planned for a 9 millimeter recession. A 5 millimeters mark from the muscle insertion was taken and a scleral bite at this 5 millimeters was taken. And then the suture was passed through the muscle stump. Similarly, at the other end of the suture was passed through the 5 millimeters mark. and again at the muscle stump. The suture ends were tied and the conjunctiva was closed. We are commonly performing muscle transposition surgeries like naps and modified naps for MED, superior rectus transposition for DRS, and lateral rectus transposition for third nerve palsy. This is a pre-op and post-op care photos of medial transposition of lateral rectus and a pre-op post-op photos of NAPS procedure for monoocular elevation deficit. We have done many research on the treatment of amblyopia. An innovative study done on the treatment of amblyopia in our center, where we studied the role of television video games in the treatment of amblyopia in children aged 4 to 7 years, had been widely cited worldwide. Another landmark study on the role of LASIK in treatment of amblyopia in adults has been widely appreciated. Thank you. I hope to see you all in another 10 years again, traversing genic growth as it continues to reach new heights. Thank you.
Thank you, Dr. Saulin and Dr. Himsika. Any questions anybody want to ask? Okay, thank you.
Thank you so much. I now request the glaucoma services team, Professor Kirti Singh and Dr. Ketki, to be on the dais. Dr. Charu Khurana would be talking about the then aspect, followed by Dr. Priya Saraf, who's a senior resident in the glaucoma team, talking about the now.
Good afternoon. I'd like to thank Dr. Kirti Singh and Dr. Subhash Dadia for allowing me to be a part of the Founder Day celebrations. And I'm very glad, and I don't know why this is not moving. Yeah. So I'm very glad to be here to share my experience of how glaucoma was back then, about 20 years ago. But surprisingly, it's very different from, my previous speakers. We were great up there. And I think we had a very, very good, fantastic time. Things haven't changed much. But before I begin, I want to tell you two things. One, I think a place is made not by the building and the equipment and the infrastructure, important as they are. I think it is made by the people. And I think we were very, very lucky to have some of the best people here, our mentors. And the second important thing is you'll realize their value when you're outside, when you've left this place. So we had top-notch faculty of international fame. We had key opinion leaders, Dr. Das, Dr. Kirti Singh, and we're lucky to have Dr. Kirti Singh with us till now, providing a continuum of very, very fine mentoring, very fine guidance and support through the years. And like I said, you'll realize the value so much more. You'll see abhi to hai, but when you're outside and realize, oh my God, you got trained with the best people in the field. And that's when you'll know how lucky you were. Amongst the equipments, we had everything. The shots tonometer, we began our internship doing, I think, 100 tonometries every day. And DV waking up at 11 at night and 3 a.m. and 5 a.m. because all the consultants wanted the early morning reading. And the Mataji, Ammaji, beti, kyun utha rahi ho? And I'm like, even I don't know why I'm awake at that point of time. But the DVs were a real pain, where. We also had applanation tonometers. I hope you're doing DVs by applanation now. I don't know how it is. Are you still doing shots for your DVs? Okay, but it's a wonderful instrument. Please keep it safe. We had the toner pens. Incidentally, we also had the ORA back there. We had it for a few months, the Richards Ocular Response Analyzer, much, much before Corvus made it commercially available about a few years back. We had all the gonioscopes. We had Humphrey. We also had frequency doubling perimetry for pre-perimetric glaucoma screening. So I think our glaucoma clinic was very flush with the latest of things. We had the CCT, of course, we had the OCT, the GDX and the UBM, all of which were thesis topics, and all of us got a lot of opportunities to work with the latest of things. I'm sure you've upgraded even more, but glaucoma clinic even then was absolutely wonderful. And that trained us to be very good doctors now. Amongst the medicines, the clinics were known as, the uropathy clinics were the Moss-Mezol clinics, and the glaucoma clinics were based, really based on timolol and pilocarpine. But I still feel now with even the Rho kinase inhibitors and everything else, I think timolol and pilocarpine are wonderful drugs very undervalued, very underused in the face of marketing of so many newer agents. But they are wonderful, wonderful medicines. And, we learned their interactions, we learned their contraindications so well that I think glaucoma kind of crept into our bloodstream and we were able to handle everything. Amongst the lasers, we did about 15 to 20 ACPIs every day. I think the glaucoma laser clinic sister was here in the morning. Cyclocryos we did initially, then the DLCP came, and ma'am, Dr. Kirti, really trained us beautifully in this wonderful laser. And, we brought pain relief and pressure control to so many people who would otherwise just have lived with their painful blind eyes for years and years. Surgeries, we were doing everything from trabeculectomy with and without mitomycin C to amniotic membrane to ma'am's another thesis topic, collagen biodegradable implants, phaco traps and 6 traps. Ma'am taught me reusable sutures. And these wonderful, fine things have helped me in so many situations. We were doing trab and trab. We were doing prep traps for PK patients, thanks to Dr. Ritu. And this was a term people were unfamiliar with outside. Ye kyu karna? I said, Hare. So this was, these are your grounding rules that will make your practice or your ophthalmic journey so much more stronger and powerful. And of course, we did all the adult and pediatric valves. The glaucoma clinic, the backbone of glaucoma, the new and old clinics, we saw about 80 to 100 patients in the old clinic. We saw about 50 patients in the new clinic, filled a glaucoma file, and it was like a factory line setting, everybody was doing an 80. One person was just doing 50 80s, one person was just doing 50 gonioscopies, one person was just doing fundus examinations and then taking the file to the consultant who would either ask for the OCT or the DVDC, diurnal control, another term not many people had heard of outside of GNEC. And then we were giving the best of medical and surgical treatments to all our patients. So if you see how much you do, you're really geared up to be really supermen and superwomen in glaucoma, at least, if you have trained from GNEC. And it's all thanks to, the wonderful mentors that we had here. But beyond the lectures, beyond the equipment, beyond the, facilities we had, I think there are a lot of things you learn by observing your teachers. And these are things I especially learned because I spent a lot of time with Dr. Kirti. Listening to the patient, what really is bothering them and asking them their problems. Sometimes it's just a headache. And the headache is not coming because the pressure's gone up to 24 from 20. And I'm not saying you don't have to treat that. But often the headache is coming from an undiagnosed cervical spondylosis or an early morning gastritis. And I would wonder, why is ma'am treating this patient's anemia? She'll be saying, "Aap bahut pale hai, aapna iron start kariye." But I can vouch for it that it's this calcium and this B12 and this iron, which has given me a much greater patient following now and has made my patients come back to me from, miles and miles when there are lots of doctors in between. But these are the skills that have helped me become not only a better doctor, but I think a better human being. And for this, I have only ma'am and sir to be grateful for. Also, reassuring the patient, I think giving them hope and not telling a 0.8 physiological cupping ki aapki to 80% nazar gayi. There are lots of us people who do that. I think giving each and every patient hope, be it in the form of a good refraction, which will help them to read better, or even an LVA for a patient who really has poor vision, will help you to treat your patients in a better and so much of a more holistic manner. And these are skill sets I think only GNEC provides. And I can vouch for this because I worked with lots of people from lots of hospitals. I think this basic grounding that GNEC gave me makes me eternally grateful to GNEC because I learned one thing, that the people who make the biggest difference in your life are not the ones with the most credentials, the most money, or the most awards. They are simply the ones who care the most. And GNEC really helps you to care for your patients. Thank you.
Good afternoon, everyone. I'm Dr. Priya Saraf, working as Senior Resident in Glaucoma Unit currently. I will be talking about glaucoma services in present day in GNEC. This is our present day glaucoma clinic, which runs in room number 202 in the OPD block. It is a dedicated workspace area right now, where 4 to 5 patients can be simultaneously examined over 4 different slit lamps, which have Goldman applanation tonometry mount on them. Our residents take a detailed history of the patient and fill them up in a glaucoma clinic file. Apart from doing single and double mirror gonioscopy, we now do 4-mirror Sussman gonio lenses gonioscopy also in our patient. We have recently acquired eye care tonometer also in our clinic. Apart from the old glaucoma clinic file, which we had from a very long time, we have recently added this glaucoma clinic card, where we fill the detail of the patient along with its personal history and family history and all the parameters which have been taken in the glaucoma clinic with the advice of the patient and the further plan of action. With this, we give this card to the patient, and he is to bring this card in every follow-up in the old clinic, and it is like a snapshot of the patient on the day he presented in the glaucoma clinic. It has helped us. It has helped us really a lot in the old follow-up. This is the data of the glaucoma clinic, which we have seen in last 1 year. We have seen around 700 new patients in the new clinic and around 4,500 patients in the old clinic. Talking about the laboratory services at GNEC, we now have 5 visual field machines which are placed in a single visual field room. We have 3 new JIS HBA 840 and 2 old JIS 740i. This has decreased the number of basically decreased the waiting time among the patients. So the patients don't have to take a long date for visual field. And we also make sure that patients are examined the same visual field machine. We have basically numbered every visual field machine from 1 to 5, and we report the patients on the visual field machine and follow up them in the same machine. We also have the recent Revo OCT machine, which apart from giving high defined posterior segment photographs, also gives a high quality bleb photographs for studying the morphology of our trabeculectomy patients. We have recently acquired Cassia 2 in our center, and it has helped us to understand the iris and lens parameters like lens fold, lens thickness of the ACG versus OAG patients and to plan them accordingly. Talking about the medical management, apart from the previous drugs like beta blocker, alpha agonist, which we already had in our center, we recently have acquired first-line PG analog bimatoprost in our center, which is available to the patients free of cost. It has helped us to manage the patients medically with greater efficiency, and it has also increased the compliance issues with our patient due to its single-day dosing. We have now DLCP machine placed in our glaucoma clinic only, so the patients are managed then and there according to their pressures. Talking about the surgery, apart from doing adult trabeculectomies and the combined surgery, which is now done in every unit in GNEC, we do a lot number of examination under anesthesia and pediatric trabeculotomies and trabeculectomies in our unit. We have recently acquired expertise in bent angle needed goniectomy, which was shown in the live surgery. This bank has helped us to manage our patients with mild to moderate glaucoma on 1 and 2 AGMs and then bring them off the AGM in their subsequent follow-ups. We have recently acquired Ahmed glaucoma valve free of cost for the patients, and we are managing our patients with failed trab and uncomplicated glaucoma cases with AGVs. This is the data of the last 6-month glaucoma surgery, which was done in GNEC. There were around 30 cases of pediatric glaucoma cases and around 250 to 300 adult glaucoma surgeries, which were done in GNEC in last 6 months. Talking about our research work, a novel surgical technique of reducing surgical induced astigmatism with patient discomfort post-trabeculectomy, that is the conjunctival frill incision, has been recently published in IGU. We are one of the few centers which use amniotic membrane in glaucoma surgeries, both in pediatric and in adult glaucoma surgeries. We are among the earlier centers who have popularized the use of MMC needling for the managing of bleb failure. And in fact, our recent thesis is on this topic, that is the efficacy of MMC augmented needle revision in failing and failed trabeculectomy blebs. We have been seeing a lot of ACG patients in our center. So we have done a lot of work on ACG patients, like clinical outcome of phacoemulsification in visually significant cataract in ACGs, lens and iris parameters in ACGs post-iridotomy in ASOCT. Our work on comparative evaluation of trabeculectomy and primary open angle glaucoma and ACG using inflammatory marker was awarded the best paper in AIOS. And the assessment of ocular hemodynamics in asymmetric OAG was awarded as best poster in AIOS. This is a part of glaucoma teaching. You can see Kirti ma'am teaching the residents by placing the visual field in a chronological order so that we can read the reliability, reproducibility, and progression of the field along with the history of the patient. Our recent work on the referral practices in the tertiary center helped us to know that there is a lot of gap among the person working, practicing in the periphery center about gonioscopy and perimetry. So we came up with this program of GAP, that is glaucoma and perimetry, to bridge the gap in glaucoma diagnosis and management by teaching not only ophthalmologists, but optometrists and residents about gonioscopy and perimetry every year in World Glaucoma Week. We recently had our second GAP program on 4th March. Glaucoma unit has also taken active part in awareness program by organizing various Nukkad Natak along with the nursing staff on about what is glaucoma, how to take medications, how to be adherent to their medications, and when to follow up. We have collaborated with different departments like pediatrics and PSM with the MBBS student to create awareness about the abuse of steroids and how it causes glaucoma and cataract. All thanks to the dedicated glaucoma team under the mentorship of Dr. Kirti and their esteemed Assistant Professor Dr. Anu and Dr. Ketki with senior and junior residents. Thank you.
I think we don't have any discussion. It has already been said, and we are lucky in glaucoma team and in GNAC to have the best of residents and the best of teachers. Thank you so much. And Dr. Ketki and Dr. Anu have been really the best of collaborators and the team somebody could ask for. Thank you so much. So let's have now one of the most awaited sessions.
Thank you all the services for showcasing that GNAC was no less back then in the days and has only looked forward and proven its mettle with time. Now gathered with us today afternoon are the stalwarts on whose shoulders GNAC has risen tall. And to name a few, we have Dr. R.B. Jain with us, Dr. Naushir Shroff, Dr. A.K. Grover, Dr. J.S. Chilana, Dr. Minakshi Dhar, and a few of them have sent a few recorded videos. So I would like to invite them one by one, talking about their experiences in GNAC and life beyond GNAC. I would now request Dr. R.B. Jain sir to come up on dais and share his views.
And he has shared his memories, his pictures. A really big thank you, sir, for making GNEC what it is and making the book of GNEC. Thank you.
Has it been published?
Yes, sir, you missed the book release. It has been published.
ये forward कैसे करना बेटा? नहीं अभी तो first slide ही रहना. Okay. Actually, I am only going to talk about how we worked more than 50 years ago in GNEC, because I am a 1972 batch pass out. Forward नहीं हो रहा भैया. ये कराना. Okay. It is fascinating to look back at the radical changes during my lifestyle, during my life. Things have transformed so much that it is unbelievable today to think how we worked before. For example, we had to work with naked eye. Slit lamps were hardly available. There was an old model of slit lamp in the OPD, which was kept in a small room, and every PG and senior resident had to take the patient there to see. There was also a slit lamp in male eye ward. Refraction, there was no streak retinoscope, so light was reflected. That was a bulb from which the light came, and this is a retinoscope mirror through which we reflected light into the patient's eye to see, to do refraction. And the trial glasses were of full aperture, not the small size glasses. Cataract surgery, intracapsular surgery was done with Graffes knife. Sometimes keratome was used, this one. Normally it was done with a Graffes knife, and the lens was removed by either tumbling or with the Ruga's forceps. Aristophage is a small rubber thing which you put on the lens, and pull it out. Sometimes the vitreous followed. 1970, late 1970s, cryo came. So they were very thick probes, and you had to pour the nitrous oxide into that probe, and there was no defreezing mechanism. Sutures, very interesting that there were, initially we started, when I started PG, there were no sutures applied. The patient had to lie, both eyes bandage, we made the patient lie for 3 days. And after that, the bandage was changed every day. After 72 hours, the eyes just settled. And it was a 9 to 3 o'clock section. Later on, we started with 1 suture and then 3 sutures and 5 sutures. 10-0 suture was not available, obviously, which we use. And there was a 10 or 12 millimeter needle with an eye. And we used to put a 7-0 silk, black silk in that and put the stitch with that. Later, we got 8-0, we were very happy. The interesting thing is sometimes we took a 3-0 black silk and split it into threads and took out one which was strong. We saw it like this and used it to do corneal suture. Dr. Gurbakh Singh is laughing because he was there. We even did keratoplasty with Dr. Gurbakh Singh with this split suture. Obviously, the glaucoma, coming to glaucoma, short tonometer was the only tonometer available, which was used basically. Unfortunately, I'm saying unfortunately, many people are still using short tonometer, which does not give accurate pressure. I started using applanation in 1974 when I went to England. The short tonometer had already been discarded by that time. Is it? Thank you. Central glaucoma investigation, central fields were done on a Janum screen like this. Patient used to sit 2 meters away and they were shown targets like these targets were shown moving things. So surgeons' skill and knowledge was very essential to diagnose these field changes. We had to know what field changes we are looking for. The peripheral visual fields were done with a Lister's arc parameter, in which a rotating arm moved all around and there was a bulb here. The visual fields, the fields were recorded. The central field and peripheral fields were manually recorded after doing. Slit lamps were not available, and thus question of gonioscope does not arise. So we did not know angle closure or open angle. But it did not matter because the only drug available was pilocarpine. No other drugs were available in those days. Pilocarpine is in use since 1870s, more than 150 years now. Acetazolamide tablets were available, and in acute cases, we use IV mannitol or glycerol. Timolol came in 1980. Actually, Dr. Bansal was here. He was involved in initial research on timolol in America. He just left. Retinal examination done with direct ophthalmoscope. Indirect ophthalmoscope came during my stay there. There was an old Killer's model available, and we had to take it in the evening. I had to get it issued and see the dilate patients, see them. In my MS exam, the examiner asked me, I am told that you can see in the side mirror. I can see, yes, sir. And during examination, I showed him in the side mirror a patient of retinal detachment with a retinal hole. He was so thrilled. He said, excellent. Can you actually show me the detachment? I have written, unfortunately, many people I know still do not know how to do a good indirect ophthalmoscopy. RD detachment was very primitive. We just used to apply Aruga string with diathermy. Fluorescein angiography came in 1961 in the world, and it came in MAMC in 69. I started working on it in 1970 and published a thesis on it in 1971, which was the first thesis in India. The camera was very primitive. We had to manually put excitation and barrier filters in front of the camera and in front of the light source. Sometimes it so happened we used to forget putting a barrier filter and the film came blank. The Flash recharge in 1/3 of second. So we had to wait for 1 second to take the next thing. 400 ASA films were used, which were very difficult to obtain. Color photography was very difficult, very costly. This is me doing angiography in 1970. Fluorescein dye solution was not available. We had to make the dye with fluorescein crystals, 20% solution. So we made it in a jar and took the Jalocaine 30 ml vials, washed it repeatedly with distilled water and then injected in it and autoclaved. That is how we used the fluorescein. An interesting story. I was going to import fluorescein crystals from Germany, and our pharmacist, he just heard it and he came to me, took me to his storeroom and gave me a 1 kilogram fluorescein crystal pack, which an Englishman had left it at the time of independence. This is the first fluorescein we used to do fluorescein angiography. That was probably the first one in India as well. Xenon arc photocalculators were available, very difficult to treat. Miscellaneous, I have written. Trachoma was very prevalent. Every third patient in the outpatients had trachoma. Sulfacetamide, sodium eye drops were available, 10, 20, and 30% for trachoma. Trachoma complications, entropion, ectropion were very, very common. Miscellaneous things, antibiotic eye drops were very limited. Chloramphenicol eye drops, which is actually bacteriostatic, were mostly used. We didn't have things like ciprofloxacin or things. Lubricating eye drops, somebody was talking. There were no lubricating eye drops in those days. No anti-allergic eye drops. Actually, sodium chromoglycate eye drops were introduced in India in 1986. Antiviral drops, IDU 0.1% were available. Antifungal eye drops were not available. Dr. Gurwat Singh would know that. And we used to make antifungal with amphotericin B intravenous injection. In short, I will say change is the essence of life and one has to keep pace with advancements. But for junior doctors, it is meticulous examination of the eye is essential as no machine can replace the clinical acumen. Remember that. 50 years, personalities have changed and so has lifestyle changed. Petrol in 1973 was 93 paisa per liter. I used to drive a scooter and junior resident got 200 rupees pay per month. Thank you very much.
Thank you so much, sir, for taking us back in time and highlighting the things that we've only just heard about or read about, but not come across. And some of the examiners that do ask these things and the residents have to cut a sorry figure not knowing them. But it truly makes us feel blessed that we are living a life of privilege, having facility and access to all these things that we do now. I now invite Padma Bhushan awardee, Dr. Naushir Shroff, to share a few words. So take as much time as you want. This institute is all yours.
How many PGs are there? Raise your hands. Okay, good. This is something to do very different from what you have heard just now. Firstly, I'm extremely grateful to Dr. Kirti for inviting me to this Founder's Day celebration. She has made great efforts to bring GNAC upward and has added many more facilities in GNAC. And she has created a lot of things, including the optometrist program, etc. Also, I'm extremely grateful to both Dr. Chilana and Dr. Ritu for making a lot of effort to bring this GNAC alumni directory and other activities. They are constantly at it, trying to get people for these functions that we have. Thank you very much. Now I'm going to be very different from what everybody spoke. Firstly, I was at a time when people don't know when Dr. Patnaik who is now no more with us, Dr. Malik, who is also no with us, not with us. And also I hear that Dr. I'm very sorry, Dr. Prem Singh is also not with us. So that was a time that we had our training. And these people were stalwarts in their fields of ophthalmology, and they were my teachers those days. After that, Dr. Sota, Dr. R.B. Jain, Dr. Gurbakh Singh were the present day teachers who taught me a great deal today, brought me a great deal and made me a good ophthalmologist. Dr. Sota was instrumental in helping me at every stage when I was doing my post-graduation. In fact, Dr. Kalsius, I was hoping she'd be here, but she taught me how to do cataract surgery. She used to hold my hand and say, and it, really assists me in suturing the corneal wound in cataract surgery. So these were the teachers who helped me to make me what I am today. Dr. Prem Singh and Dr. Patnaik were very tough taskmasters, very tough. And I could not reach up to the expectations. And I used to really cry off these days. I really cried. I used to come home and say, my God, these people are real terrors. Dr. Patnaik taught us indirect ophthalmoscopy. In those days, there was only direct ophthalmoscopy, but he was insistent that you learn indirect ophthalmoscopy. And then we were his postgraduates, and he used to say, bring that patient in that ward with 2 holes in the temporal quadrant of the right eye. Now, how do you know? He used to only remember the fundus diagram. He never remembered the name of the patient. So now at night, we used to go into the ward. Poor patient को उठाते थे, बाबा please आँख दिखा दे, नहीं तो सुबह डांट पड़ेगी. So those were the days when they used to, Dr. Patnaik also used to do fundus photography. Those days there were no, there were no non-mydriatic cameras, and you have to dilate the pupil fully to get a good view. Now we used to bathe the patient with mydriatics till their blood pressure shot up, and so did ours. And then if the patient was not fully dilated, he would throw both of us out of the room, the patient and us. So he used to throw us out of it, go and get him dilated. So one day a postgraduate told him, sir, क्या करें, क्या iris को खींच दें क्या? And then Professor Malik's class also, that one day he used to be right on time for his classes, right on time. Dr. R.B. Jain and I were discussing. So one postgraduate came late. So he said, Dr. Malik said, क्या कर रहे थे? Why are you late? He says, sir, मैं सुत्ता पिया सी, मैंने सुपना आया कि आज Sunday है. So those were the days we went through. And I tell you, Dr. Panik didn't know whether to be serious or to laugh. So he was trying to be very serious, but under say he was feeling like laughing. Anyway, as I said, I'm going to be very different. Now, Dr. Patnaik also used to tell the patient, तेरा retina settle हो गया है. Sir, Babu, sir, doctor साहब दिखता तो कुछ नहीं. Now, those days, there were no intravitreal injections and there was nothing for the macula. So what do? He said, get out. Their retina settled है. So बेचारा वो कहता है, सर दिखता तो कुछ नहीं है, retina settled है, मुझे क्या फर्क पड़ा? Anyway, those are very interesting days. Now about Dr. Prem Singh. Dr. Prem Singh was also a very tough taskmaster. I used to be in his unit. So he used to throw my case sheet from the second floor and be downstairs, and I have to go and pick it up if there was even a single finding missing. And he was also trying to do indirect ophthalmoscopy those days to learn. He was learning from Dr. Patnaik. But he used to grill me so much that finally I told him, sir, मैं आपकी unit में नहीं काम कर सकता. So he used to ask my parents over to his house. It was in, what is Mirdal? नहीं, यहाँ पे Dr. Prem Singh यहाँ रहते थे जब, हाँ, Mirdal. And my father was also an ophthalmologist. So he told him, I'm going to grill him properly. because I would want to make him a good ophthalmologist. I said, my God, to become an ophthalmologist, I didn't know I have to be grilled such a lot that I almost cried. Now, later, Dr. Patnaik was so encouraging to me that, in fact, when I became a DOS executive, came in the DOS executive and he was unanimously elected the president of the DOS, he was very encouraging. And Dr. Prem Singh became such a good friend that whenever I went to United States, I stayed with him. So this is what, when they grilled me in my post-graduation, but they were so nice to me after I had passed and after I started practice. So remember, postgraduates, one thing, and now Dr. Professor Gupta is sitting. Now I can't forget him. So, so he became the dean and the HOD first of the Guru Nanak Eye Center, and then dean of Malandar Medical College. And he's now in our teaching program at the Shroff Eye Center. He is the academic in charge of the Shroff Eye Center academic DNB academic program. Now the postgraduate, he has a habit of staring at the postgraduate, and the postgraduate just freezes. And what he'll do is he'll say and only that is enough to run with make the postgraduate understand that he is in for trouble. So in a nutshell, let me end by saying that there is no postgraduates, there is no substitute for hard work. You have to be grilled and grilled and grilled to be able to be successful. Postgraduates in those days, आजकल तो लोग rights मांगते अपनी, ये वो डिप्रेशन हो जाता है, गूगल कहता है कि ज्यादा स्कोर करो तो डिप्रेशन हो जाता है. हमें कोई डिप्रेशन नहीं हुआ, as you can see. हमें कोई डिप्रेशन नहीं हुआ. हम do you look depressed? So one thing you have to remember all your life, that be true to your patient. Be true to your patient and do your best for your patient. I have had cases of endophthalmitis in one eye when I had operated. He came to me for the second eye because I had worked very hard on the first eye, that he even came to me for the second eye. The other thing is uphold all the ethical and moral values that are taught in our profession. And Dr. Jain, Professor Gupta, Dr. Das, Dr. Gurbakh Singh have taught us all this. Thank you very much.
Thank you so much, sir, for sharing not so few words and making the audience such lively, wonderful experiences. And I think, yes.
डॉक्टर A.K. गुप्ता सर का जो हूँ है, मेरे फाइनल ईयर का सेंटर ऑफ एग्जाम हो रहा था, एंड ही से हूँ, so I froze. Absolutely, my mind went blank. And he says, "कुछ तो बोल, number दूं," and I am just sitting like this. And ultimately he says, "कुछ बोल." I froze more. So he gave me 0.
Just call the next person. Dr. Virdi is actually no more. And our book, sir, has all the anecdotes of yours, but I didn't say he was second floor se picked it. I just wrote on euphemistic, you picked it. But so Dr. Virdi was nice enough when I approached him. I was not an American Academy member and I had an IC to say, and he said, Aja, मैं sponsor करूँगा. And he became not the sponsor financially, but he put his name in the American Academy. कभी भी आना हो American Academy में, मेरे को बस एक message कर दे. So if you can just wait for 1 minute to remember, he was such a fine person, Dr. Prem Singh Virdi. I couldn't imagine Dr. R. Vijan when you told me, sir, मेरे को रोना आ गया था उस दिन, and he was a super handsome guy, super photographer, super warm person. If you could just say 1 minute, rest in peace, sir. You were wonderful. You should remain wonderful. God needed you. He brought you to him. Take care of him. Thank you.
I had the privilege to stay in the same house. He used to stay in Mata Sundari Lane. So when he came back to India, he came to our house and said, I wanted to be in this house, met us, had a dinner with us. It was so lovely to meet him.
की बात हो रही है तो I don't think, I'm not sure I should tell. He used to live in Green Park before Mirdar Lane. So I went to his house in Green Park and he was sitting like this. मैंने कहा सर क्या हो गया? कहना यार 2000 की सैलरी मिलती है, बीवी 2500 का सोफा खरीद लाई, सारा महीना कैसे चलेगा? So that jolly man. He actually, his birthday is
I only wish Nosher was my teacher when I was here. So I could have told all those kind of kissas जो उसने Dr. Gupta के बताए हैं ना.
So requesting Padam Shri.
Mike. एक कॉन्टैक्ट लेंस क्लिनिक होता था जिसमें एंट्री बड़ी मुश्किल होती थी. माय गॉड, उन्होंने ऐसा बना रखा था कॉन्टैक्ट लेंस क्लिनिक के जिसको अंदर कोई घुस नहीं सकता था. वैसे ऐसे आई एग्री दोस डेज हार्ड कॉन्टैक्ट लेंसेज थे, एब्रेशन हो जाते थे, कॉर्नियल एडिमा हो जाता था, बहुत चीजें हो जाती थी. बट उन्होंने ऐसा हुआ बना रखा था कॉन्टैक्ट लेंस क्लिनिक का. फिर बाद में जब हमने पास किया और कॉन्टैक्ट लेंस काम किया, मैंने कहा इतना तो मुश्किल नहीं था जितना डॉक्टर साहब बताते थे.
We have Padam Shri awardee Dr. A.K. Grover, sir. Of course, he needs no introduction, so he's not letting me speak. So, sir, the stage is all yours.
So, since Nosher के बताने के लिए के बारे में बताने के लिए किस्से नहीं है, so I'll start with my kissas. So the boy from Barabanki, that's me. Small town boy. Schooled in Barabanki. So that was the first memories I have since I was there from 3 to 8 years of age, to Banaras, to Amritsar, to Muradabad, to Amritsar again. A small period of admission in Langat Singh College in Muzaffarpur, but I didn't study there. And then Chandigarh, and then onwards. So I don't know if everybody in the first row identifies with all these things. This radio with a huge antenna like that, where you had to tune microscopically to get BBC or get Radio Ceylon. And our favorite hero, of course, he came a little later, but all these things I'm sure you all relate to. Ye stove and ye gaadi. इस गाड़ी के बारे में सबको पता है, एम्बेसडर. इसमें सब कुछ बजता है हॉर्न के अलावा. And these typewriters and steam engines. So I'm a product of that age of 50s and 60s. And of course, adulthood in MAMC, including some tough days in the beginning. Anatomy बिल्कुल drawing नहीं आती थी, इसलिए anatomy नहीं आती थी. रोज पढ़ने की आदत नहीं थी, इसलिए anatomy नहीं आती थी. What a first professional was very tough, survived. And then nuts and bolts and tips and tricks at GNEC, and look at the bell bottom and the hair. And then on to GNEC, and we had the good fortune of being under the mentorship of Professor Gupta, who was benevolent, who let us work to our heart's content, do whatever we wanted with full freedom. And that was the great opportunity to be here at a time when the institution was just building up. There was only an OPD for Guru Nanak Eye Center. There were no wards. So that's when we started the indoor facility. Sir, what year was it, sir? 86, 87? पढ़ी नहीं, पढ़ने की आदत शुरू से नहीं थी. 80, 86. So that was when there was a foreigner who came. Sir, नाम याद है जिसकी वर्कशॉप करानी थी, तो कहा कि नई वर्कशॉप LNJP में नहीं होगी, वो गुरु नानक आई सेंटर की OT में होगी. So all material had to be procured, all OT had to be set, and the microscope एक बड़े दिन से पड़ा था जो नहीं इंस्टॉल हो पा रहा था जाइस का, उसके लिए फ्लोर खोद के बनाना पड़ा क्योंकि वो सीलिंग माउंटेड था, जगह नहीं थी, तो गड्ढा बनाया गया और फिर वो OT तैयार की गई. So that was the beginning of wards and OT of Guru Nanak Eye Center, and see the skies to which it has gone now. So all credit to Professor Gupta and making me an instrument to be a part of starting the OTs. And then he gave me that there was no oculoplastic service in Guru Nanak Eye Center. I had done a senior residency जिसमें कि बहुत सारे subject थे, glaucoma भी था, so I can still do trabeculectomy and trabeculectomy, and there was trauma clinic and pediatric ophthalmology and oculoplasty. So since there was no oculoplasty service, I became an oculoplastic service in charge, big man. So started oculoplastics with 1 or 2 patients coming every week. It grew to about almost 800 odd patients per year. By the time 92, President was pleased to accept my resignation, 92. So at that time, oculoplastics, the range of surgical procedures was limited. There were no fellowship programs in the country. There was no Oculoplastic Association of India. A handful, you could finger count the number of oculoplastic surgeons. And when you had to invite a faculty, you had to send an email and wait forever. And you had to wait to get a phone or to make a trunk call, and parents could only call you by making you wait at a time in your phone booth. So it was a struggle to get swage sutures, if any at all, as Dr. Arbi was pointing out. I must say it is on their shoulders that we moved further, just as we brought in something and others got on to further procedures from them. Similarly, what Nasher, Arbi, and Dr. Sota and Dr. Gupta did, we had that base to start from. So we always have to remember that we get those shoulders to go further up. So there were no intubation sets. What we did was Dr. Gupta ने थोड़ी freedom दी हुई थी as medical store in charge, तो कोई और जो import करता था उससे bundles सा मंगवा लिया silicone tubes का, और वो hypodermic needles होती थी तब वो आपको दिखाते हैं, उससे उसको support देके उन tubes को intubation के लिए use किया. No orbital implants, there were no Jones tubes, no CT, no MRI, no PET scan, no B scan either, no imaging whatsoever. So we used to do venography. I don't know how to say intraconal hai ya extraconal hai. So lacrimal intubation के लिए we got those tubes, bundle होता था, उसमें hypodermic needle के अंदर जो एक stainless steel stillet होती थी उसको support की तरह use करके intubation शुरू किया. Conjunctival DCR ट्यूब्स तो होती नहीं थी, तो ये पॉलीथीन काट लेते थे ये ट्यूब्स में से और उसको हीट पे बुनसन बर्नर की ऑक्सीडाइजिंग फ्लेम में करके ये बना के कंजंक्टिवा DCR करते थे. ऋतु का थीसिस जो था, कोई और कोई सर्जरी नहीं करता था बेचारी के लिए RP सेंटर में, तो आई हैड टू डू द फर्स्ट कंजंक्टिवा DCR केस इन RP सेंटर विद दीज काइंड ऑफ ट्यूब्स. She completed her thesis. पास भी हो गई. So then fascia lata के लिए कोई, of course there were no right fascia lata needles, तो ये artery forceps से खींचते थे, काट लेते थे थाई से लंबी सी incision देके. Then of course the innovations came. एक वो खराब सा वो पड़ा हुआ था fascia lata harvester जो काटता नहीं था, तो बहुत बार कोशिश की, कटता ही नहीं था. तो then we started otherwise. फ्रैक्चर्स के लिए भी गॉट अ ब्लॉक फ्रॉम समवेयर, अगेन इंपोर्ट करा के उसको ब्लेड से काट के उंगली कट जाती थी, इतना हार्ड होता था. रेजिडेंट्स बहुत सारे मुझे याद करते हैं कटी हुई उंगलियों के साथ. उस टाइम HIV नहीं होता था. Then innovations in fascia lata, Marcus gun, so on and so forth, blepharophimosis, transnasal wiring, we did all that without rights needles and so on and so forth. Then the microsurgery had to begin. So we had a Bharat Electronics Limited, BEL, जो माइक्रोस्कोप कोई नहीं जानता था, उस वक्त भी नहीं जानता था कि वो माइक्रोस्कोप बनाते हैं, वो खुद भी नहीं जानते थे, पर उनका 15-20 साल पुराना कोई माइक्रोस्कोप पड़ा था जो LNJP में स्टार्ट किया, याद है सर? बेल का माइक्रोस्कोप कंडेम करा के सो उससे कुछ दिखता नहीं था, पर वी थॉट वी आर अंडर द माइक्रोस्कोप, सो उससे ECC स्टार्ट किया इन 84-85 जब LNJP में, and then we started when then the microscopes came. The Ascon का पहले 40,000 का माइक्रोस्कोप आया with Nikon industrial head, and then Appasamy came a little later for 50,000 rupees. So that was the beginning of microsurgery, and then we could do these things. Steno suture was introduced. I came back from Momose in Japan and could start doing 10-0 suturing for the first time. And Guru Nanak Eye Center was the pioneer in Delhi in IOL implant surgery, PC IOL implant surgery, amongst all the government institutions. So initially we got for the workshop, Shah was the only manufacturer. We got the IOLs from them, and 90% of them got a sterile hypopy. I don't know what method of sterilization they were using. And they were PMMA lenses, of course. There was no question of foldable lenses with holes and with J loops initially. And it was a big relief when a company called IMD started making those lenses, and then we could not fear a sterile reaction. And then the C loops came, then the modified C loops came. This angulation used to be large earlier, so on and so forth. So, and we had also the freedom to do PKs because PK karne wale tab koi nahi tha, so we started doing PKs and so on and so forth. And then the academics had to be done without computers, laptops. There were no PowerPoint presentations to make. You had to just keep your slides. अगर एक slide से कोई और slide दूसरे set में चली गई तो दोबारा कभी नहीं मिलती थी. It was so tough. And photos के लिए जैसे बताया था कि महाटा को दे के क्रोम स्लाइड लेके 60 रुपए की हमारी सैलरी 2,500-3,000 होती थी, उसमें 60 रुपए की स्लाइड, फिर डेवलपमेंट के लिए वो कितने लेता था? नहीं, स्लाइड 110 की होती थी, शायद 60 की डेवलपमेंट महाटा लेता था. बस टफ लाइफ. तो वो करा के, और कैमरा डॉक्टर गुप्ता से एक मैंने ले लिया था. सो एक वो मोटा सा कैमरा था, उससे फोटोग्राफी शुरू की. एंड देन of course there was no YouTube, no videos to see, so you just had to read and start doing it. So read it second time, read it fourth time, fifth time. So DCR में चालाट से 10-15 बार तक हर बार पढ़ के जाता था, and every time I could find something extra. So no photographic documentation, and VHS cassettes पे जाके editing करते थे. कनॉट प्लेस में एक भला आदमी था, वो उसके साथ ओवरनाइट बैठते थे तो वो एडिट कर देता था. And then communications, we started Oculoplastic Association. We invited Colin, we invited Mustade, and वो aerogram लिखो और इंतजार करो कि कब आएगी चिट्ठी, कि वो इसको मिल गई है कि नहीं मिली, and so on and so forth. And then we of course did all that in that era. And of course the greatest joy was learning and teaching and being with the students. We had some workshops. This was a WHO assisted workshop. This was another one by NSPV. So all those programs, Dr. Gupta led the way for academic programs with these CMEs, workshops, and so on and so forth. This is Dr. Siva Reddy, right? And then who all knows Dr. Siva Reddy? He was a pioneer, another Padma Bhushan in ophthalmology from Hyderabad. Yeah, he was the head of Sarojini Devi, which is the largest. Siva Reddy, that's right. Sorry, Siva Reddy. He was the kind of mega figure in ophthalmology. And then, of course, who's this? Anybody? Wrong. Ridley, father of IOL. So IOL implant meeting. बाकी और लोग थे साथ में, उनको मैंने काट दिया ताकि हम दोनों की फोटो लगे. And who all know the founder, Dr. Malegi? This was probably LG, sir. कौन याद है? Probably yes. And Professor Akira Momose, who taught a lot of us. Professor D.B. Chandra, who became the founder president of Oculoplastic Association while I was the founder secretary. And who all know this person? G. Venkatasamy, the founder of Arvind and Dr. J.K. Pasricha was a great man from Karnal who became president of AIS and of course our own Natsota. And then I had to grow up, parenthood, and my first scooter to old 35,000 ki second-hand Fiat car, for which I used to pay 700 rupees for next 50 months to Sarkar for the loan. And of course, the great joy of being here was serving the underserved. And the great joy of being with the faculty and with the residents. It was such a joy. Our house was just nearby, so a lot of PGs would come there, write their thesis in our homes, or eat with us, or be with us, and traveling together. And ye hai kaun? Dr. Mehta refuses. I sent this photo to him. He says, this is not me. So I've been trying to convince him for the last 5 years that this is him. So I'll tell him that Dr. R.B. Jain said the same thing. Dr. Sota, of course. And this is my elder son, Apur. वो मानते हैं पर डॉक्टर मेहता नहीं मानते. And then we did a crazy thing together, and this is the last slide. So let's look at this crazy dance. इसमें डॉक्टर दास को पहचानने का क्रेडिट मिलेगा सबको. डॉक्टर दास का डांस. This is a cataract extraction in our own stupid way. Sound. दोबारा repeat करो. Sound के बिना तो नहीं दिखाना साउंड के बिना यार. तुमने कहा था साउंड है. ये मैं हूं. From a VHS cassette, courtesy Shahana Mazumdar, we could convert it into a video. So 2-minute video. Restart. Louder. Nancy auditorium, yes. और ऑडियो बढ़ाना है. Crazy sounds also. दूसरा माइक दे दो. और दूसरा वाला माइक. वॉश कर रहे हैं ना निर्मा. डॉक्टर घोष. Not me. I deny. Dr. Das, he denies. Happiness at delivery of the lens. So this is what Das used to do, Dr. J.C. Das. So thank you, GNEC, for giving me all that I have today. Thank you very much. Thanks.
What a wonderful and lively talk and performance. I think now we'll have to see if our residents can beat that performance or not in the culturals, but I doubt it. This was really unique and really innovative. But jokes apart, I think working with such limited resources and yet being able to do so much only shows how perseverance and dedication can pay back. I now request Dr. J.S. Chilana, sir, to share a few words.
Hello, dear friends. Let me start with thanking Dr. Kirti first for inviting me to talk my few remembrances in the GNEC Alumni Days. Thank you, Dr. Kirti, for organizing such a wonderful program. And thanks, Dr. Noshish Rao, sir. Very kind words for us, for GNEC alumni. Me and Ritu and Dr. Mohita are working our best to take the GNEC to newer heights. Thanks for recognizing us. So my talks will be a bit different. I don't have any academics and no PDF, nothing. I just talking 3-4 ex-tempo memories which I have got. I joined MMC Malanjar Medical College in 1978. After MBBS, I did my house job in 1984, and that was in ophthalmology. And I got my house job in Dr. L.T. Sota batch. Dr. L.T. Sota unit at that time didn't have any other consultant, no senior resident. So there were just 4 persons in the unit. Dr. L.T. Sota, sir, second year PG, Dr. Vijay Gupta, first year PG, Dr. Kamal Sani, and house surgeon, Dr. J.S. Chilana. That was the all unit. So you can remember those days in which the GNEC alumni we started and how we rose to this level, which we are seeing today. And during those days, only OPD was running from here, the present premises, and ward number 10 was there in LNJP, and OT was also in LNJP. So we used to walk down all the way from PG hostel and house surgeon hostel to GNEC alumni on 2 days of OPD. After I got my MS in 1985, all services were shifted to this place under the guidance of Dr. Professor A.K. Gupta, sir. I very well remember Dr. L.T. Sota was given the duty of getting the thing shifted from LNJP to GNEC. So this slit lamps, Snellen chart, trial box, all were loaded in a truck. And it was my duty and Kamal Sani duty to supervise that truck reaches GNEC and things are delivered here. I very well remember that I was in the truck and we got those things shifted from LNJP. In those days, now we had to come all 6 days walking from PG hostel to here. It is around 2 kilometers. If you all know it, PG hostel is quite far off. At that time, when I came today, I just found it difficult to park my car. But I very well remember when I was PG, there were just 2 cars in GNEC alumni. One was white Fiat by Professor A.K. Gupta, sir, and second was a red Maruti by Dr. L.D. Sota. And Dr. Gupta used to stay in type 6 quarters in the MMC complex. So whenever he was coming to the GNEC premises, he would see us walking, he would open the door and make us sit along with us. You can imagine our plight. Dr. Gupta is driving and we are sitting, and we were always fearing that he should not ask any question. But those were the days we really enjoyed it. That sir is taking us from the hostel to the hospital. Then beside this, beside that 2 a.m. call when you get up and there is a knock on the door and you know it is photophthalmia. That Gaurav has already said. But I'll be talking something different from GNEC alumni days. At that time, there were no TV, no movies were not easily available. So as a resident, we used to go Regal Cinema to watch the movies. There we used to use our GNEC card to show that we are doctors. We get time by very difficulty, so you have to give us the ticket. At that time, it was not easy to get the ticket in a hall, and we used to go to the manager's room, show our GNEC card that we are resident over there, and he used to give us the seats. But at one time it happened, I very well remember, all the seats were filled up, and we said, no, we want to see this movie. So he put 2 chairs separate in the auditorium, and we were watching movie, sitting in the chair along with all those. And obviously we didn't pay for that. Those were the days. That's all I want to say. Thank you very much.
Thank you so much, sir, for sharing those memories. I now invite Dr. Meenakshi Dhar for her time at GNEC.
A very good day, good afternoon to one and all. It's a pleasure to be here. And thank you, Kirti, for including me in the list of people who'd come and say a few words here. It's actually very heartening for me to see my teachers here, Professor Gupta, Professor Das, Professor Dr. Grover, and of course, Dr. L.D. Sota, who was my mentor all through my learning in GNEC. I have a lot of, for most of you who may not know who I am a true, I did my MBBS from MAMC, then went on to do my PG in GNEC, then went on to do my senior residency in GNEC. And then of course, I also learned a lot from Dr. Nausher Shroff at Shroff Eye Center and came back to do my, my school job here. So I had a long list of a number of years that I spent here, and I managed to, and I had the opportunity of learning different types of surgeries. One of the greatest things that learning here was, one was systematic approach to a patient. Another was the type of variety of surgeries we learned from Dr. Grover, Dr. Ritu, like whether it was apart from retina, there was no surgery that when I left this place, I could not feel confident in handling at any point of time. We were at the era when we shifted from, we have seen people performing intraocular ICC, then going on to ECC, then going on to phaco. So we have traversed this whole journey. Now for a few, I had a lot of charming moments here. One of the most memorable has been with Dr. Gupta, and everybody remembers as but I have, when I was a student of MBBS, I used to do radio programs. And one of them took me to Dr. Gupta, and I wanted him to speak on lasers. And I took his interview on that. And so when I went on for my final exam, when I come in and I sit there and he says, "Iska to main kya viva lunga, isne to mera hi viva le liya tha." And like with Dr. Sota, one was very, like the kind of image he has, one was very fearful of him and initially, and but he was not my guide for thesis, but he's a person who actually I've sat in his house and written my thesis. He was always there to support me. So I remember once, like I had assisted him for years together, and so right in the beginning, I was my hand must have been shaking to hand him a thing because we were so scared of him. he said कि तेरे हाथ क्यों कांप रहे हैं? I said, sir, आपसे डर लगता है. But he was one person who would not only mentor me in having in my surgical and academic skills, but he was somebody who always used to keep telling me, beta, अपनी शादी और अपने बच्चे समय पे करना. Don't I now I go to parties and I see all my colleagues, they have such older children and things like that. So I'm very fortunate for the time that I spent here. After that, I went on to be starting a department at Amrita Hospital in Cochin in way back in 98, 99. And that's one time when I'm really thankful for the guidance that Dr. Grover and Dr. Ritu Arora gave me, because when I was working here, I never thought I would ever have the opportunity of starting a department, let alone in a big institute. So, and those were the days when we did not have news at hand. I wish I could be a student in this era, when everything with a few tips, clicks you get and all information you have. So in those times, I would ring up both of them and ask them, what should I buy? And thankfully, with the guidance that I got, the department that I have set up there was indeed a good one. And now I'm here in Amrita Hospital at Faridabad, and again going on to establish an ophthalmology department there. And it's thanks to all the, like Dr. Nosher said, remember your ethics and approach a patient for always the benefit of a patient is what I would like to say. We had lots of fun times, like Dr. Chilana and Dr. Grover, Dr. Gaurav said about that, those night calls and going to God knows for God-forsaken places in Sitaram Bazaar to collect eyes and things like that. And I have nurtured friendships for the last, say now 30 years, thanks to having been here, and it's been a wonderful journey. And I wish all of you who are geneticians, and we are here to help you anytime that we can. And thanks Ritu and Dr. Chillana for doing such a lovely job in GNEC. Thank you.
Thank you, ma'am. Dr. Vivek Pal couldn't join us at the last moment due to family emergency. And Dr. Rajan Narayan has sent in a video. I'd like the AV team to play that.
But I have very fond memories of Guru Nanak Eye Center. In fact, what I am today is absolutely because of how I was shaped at GNEC during my PG days. I remember I joined Dr. D.K. Mehta's unit way back in 1998 as a first year PG. As a single PG in the head unit, I learned so much. I got so much opportunity. I was the only first year and also the only second year PG of that unit. I got so many opportunities. I used to do FAs in the retina clinic. I don't know of any other center or medical college as of now allowing PGs to do FA. And I also did a lot of scleral buckles, keratoplasties I used to do during my PG days. And I remember my faculty, Dr. Usha Rana and Dr. Ritu Arora, who were my co-guides in my thesis, used to really take care of me. In fact, I also did trap with releasable suture in my PG, which I don't know if they're doing now, but it's not a common thing, I would say. I also wrote quite a few papers during my PG. Some of them have close to 100 citations now. One unique thing which happened in my case was my thesis was accepted as an oral presentation in AAO, the American Academy of Ophthalmology. I still cherish that letter. It says, "Dear Dr. Mehta, your paper entitled, my thesis title has been accepted as oral paper in AAO." Way back in 2001. I would say again that my faculty showered their affection on me. I mean, more than teaching for the sake of teaching. I think they had tremendous affection for me, and that's how I also gained a lot from them. They went out of their way to teach me. Dr. Mehta, Dr. Ritu, Dr. Sarena. And also all the faculty in my third year of rotation were also very kind to me. Just to name some of them, I'm indebted to so many, but Dr. Ghosh, Kamlesh, Pandey, Usha Yadav, Anju Rastagin, Dr. Sushil, and so many others. Also, my thesis patients were very attached to me. In fact, I don't know for what reason, during my second year PG, the Health Minister of Delhi used to refer patients to me directly. And this is one of the letters which I have. Dr. A.K. Walia was the Health Minister. It says, June 2009, I think 22nd June 2009, he has written a letter referring a patient to me. I used to say, I'm only a second year PG. Why are you referring patient? He used to call me also in those days. I didn't have a cell phone, but someone would find me in the ward. Someone would come and say, Minister Sahab, baat karenge. It was a little bit embarrassing, but I had learned a little bit of these political connections also at that time. But other than these, I think the best time that I would say, as a memory is that we used to enjoy pizza and drinks in every OT. My colleague who was 1 year junior team, Anush Gogi, was so fond of pizzas. He's currently in Aligarh. He used to order pizza, and all the faculty also used to eat. We were very jovial, very cordial, and we used to have, in the OPD Pepsi, and I remember specifically Haldiram's, that nutcracker masala wala, peanuts and the khata mitha. And every OPD, it was my responsibility for 2 years actually to get this coordinated. I remember Pion Dharamveer used to be there. He was very, very meticulous in making sure that he gets it on time. I also learned some people skills because some people would not pay at that time their contribution. So I learned how to some, I would say, negotiation skills also with some people, with some seniors also. But I would say that that bonding which we have, we don't realize it's not just about pizza or Pepsi, but when we get together during the hectic time, it's not easy to manage so many patients, tough patients, people pushing each other to get into the OPD and a heavy list of OT. When you get together, it's such an important thing. I hope that tradition is continuing. And it is not happening now. At this time, I have heavy OPDs, but we are not getting together, my colleagues and all. We just do our work. But I would say that having that time and making sure that you get together during the tough days is a very, very important thing. And I would say GNEC provides a lot of opportunities which are not available to most residents in India. For that, I would sincerely thank and convey my gratitude to the founders and early foundation layers of GNEC, whom I have never met probably. The current residents, when you are doing the residency, you may not realize the importance of GNEC and its faculty and staff in shaping their future. It is similar to our younger days, when we are with our parents and relatives and near and dear ones in the house, you don't realize their importance. Only when we move away from them that we realize their value. And this is the same thing that we all will feel once we finish our PG, come out, become alumnus, and after a few years we realize what GNC was, what their faculty did to us. And again, I would like to convey my sincere gratitude to everyone there. If there is a hypothetical situation that if hypothetically I have to do a residency again, I will certainly choose GNC again to do my residency, even though I have seen many other residency programs in India, in Shankar Netral and LV Prasad Institute or Arvind. I have worked in the US also. I've seen many programs in the US. But hypothetically, I would say, I would certainly choose GNC if I were to do again. And our life goes on, it's only a hypothetical situation that I'm talking about. But today is a day to remember and celebrate the foundation of a great institution called GNC. And I wish all the faculty, residents, and staff of GNC the very best in their future. Thank you very much. Bye-bye. See you later.
We thank Sir for sending in the video, even though he couldn't be here with us today. So thank you all the speakers. I now request all the speakers to please come ahead so that we could felicitate them. Dr. R.B. Jain, Dr. Naushir Shroff, Dr. A.K. Grover, Dr. Meenakshi Dhar. I request Dr. Kirti Singh to felicitate the speakers. Can we have these lights? I think she just stepped out. Dr. Sanat and Dr. Vinayak, please. And Dr. Ayush. Dr. Subhash to Dr. A.K. Grover, sir. Dr. Ruchi ma'am to Dr. R.B. Jain, sir. Dr. Meenakshi ma'am to Dr. Meenakshi Dhar.
Actually, interestingly, both of us were together in school and we met today. And we were in 2B, 3B, 4B, school, 5B, and maybe
Dr. Kirti ma'am to Dr. Parul ma'am and Dr. Paramita can join us, please. Dr. Ketki. Dr. Parul to Dr. We've heard so much about Dr. Das, literally on everyday rounds in the glaucoma unit. Dr. Parul to Dr. A.K. Gupta, sir. Dr. Ketki to Dr. Naushir Shroff, sir. Sir deserves that for being the founder and much more. Dr. Parumita to Dr. Bhalla, sir. Thank you so much, all of you. Thank you so much. I know we are running 45 minutes late, but I'm sure you'll not regret it. I'm going to hand over the podium to Dr. Avani Haryani, who's a very dynamic senior resident, along with her team of talented residents, to take us through a visual and auditory feast. Dr. Avani, all yours.
A very good evening to everyone. So we've come to the end of the day and everyone's feeling nostalgic. Let's end our day on a high note today and we'll welcome our performers for the cultural event.
I'm so sorry. Dr. Kirti Singh to Dr. Gurbaksh Singh, please.
Hello, check, check, hello. ये number 4. Hello, hello, hello. 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 Check कर, check,
So can we start?
check.
So Dr. Ayush, if people remember him from the alumni day, I'm sure would be very excited for his performance. And for those who missed him on that day, today is your lucky day. With his typical bow tie and a red rose in his pocket, I welcome Dr. Ayush.
Hello, hello. 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 शराब पे मैं जरा सी शराब फेंकूंगा किसी हसी की तरफ ये गुलाब फेंकूंगा पर्दा है पर्दा है पर्दा है पर्दा है पर्दा है पर्दा पर्दा है पर्दा पर्दे के पीछे पर्दा नशी है पर्दा नशी को बे पर्दा ना कर दूं कि पर्दा पर्दा नशी को बे पर्दा ना कर दूं तो अकबर मेरा नाम नहीं है पर्दा हे पर्दे के पीछे पर्दा नशी है पर्दा नशी को बे पर्दा न कर दूं तो अकबर मेरा नाम नहीं है पर्दा है पर्दा पर्दा है पर्दा खुदा का शुक्र है चेहरा नजर तो आया है हया का रंग निगाहों पे फिर भी छाया है किसी की जान जाती है किसी को शर्म हाँ शर्म आती है किसी की जान किसी को शर्म आती है कोई आंसू बहाता है तो कोई मुस्कुराता है सताकर इस तरह अक्सर मजा लेते हैं ये दिल भर हाँ यही दस्तूर है इनका सितम मशहूर है इनका खफा हो के चेहरा छुपा ले मगर याद रख उसमें वाले जो है आग तेरी जवानी मेरा प्यार है सर्द पानी मैं तेरे गुस्से को ठंडा न कर दूं हाँ मैं तेरे गुस्से को ठंडा न कर दूं हाँ पर्दा नशी को बे पर्दा न कर दूं तो आर्या मेरा नाम नहीं है पर्दा है पर्दा पर्दा है पर्दा पर्दे के पीछे पर्दा नशी है नशी को बे पर्दा न कर दूं तो अकबर मेरा नाम नहीं है पर्दा पर्दा है पर्दा है पर्दा पर्दा है पर्दा थैंक यू
Well, what a start, Ayush. I would like to welcome Dr. Apurva and Dr. Hiten now. Them being from the retina unit, I still get maximum cornea opinions from them. A round of applause for their debut on GNEC stage.
Hardy, everywhere she make him go crazy. पर kill करना उसकी hobby. के भूल भुलैया बातें हैं भूल भुलैया के भूल भुलैया बातें हैं भूल भुलैया तेरे सपनों की गलियों में you keep driving me so crazy मैं तू रहती है बेटा भी कहती है I keep praying all day तुमने मोहब्बत करनी है हमने मोहब्बत की है इस दिल के अलावा किसी से भी ना हमने इजाजत ली है ये भी इश्क का किसी किसी को आता है जान लुटा के दुश्मन की हमने हिफाजत की है बात करते हैं हजारों है तजुर्बा हमें यारों बात करते हैं हजारों है तजुर्बा हमें यारों ऐसी है बांध लूं मुझ पे वो झूमे जो पठान मेरी जान महफिल ही लुट जाए देते जो जुबान मेरी जान उस पे मर मिट जाए जो पठान मेरी जान महफिल ही लुट जाए जो जुबान मेरी जान उस पे मर मिट जाए
Well, this was so different from the washing powder Nirma performance that we just saw. Now, I'm sure everyone here remembers Dr. Sanat and his Badan Pe Sitare performance. Him and Dr. Ayush keep the pre-op and the patients in pre-op very jovial by playing old Bollywood songs on their Bluetooth speakers. I would like to welcome Dr. Sanat. Oh, easier.
Hello. एक minute, let me revise my lyrics. Start. ये गाना एक्चुअली उन लोगों के लिए है जिनके लिए गुरु नानक आई सेंटर उनके जीवन का हिस्सा रहा है। एक मिनट के लिए रुक जाइएगा, पॉज कीजिएगा प्लीज। ये मॉनिटर पे नहीं आ रहा है, मॉनिटर पे जो बोला था। हाँ हाँ, फिर से। हेलो। तो जैसा मैं कह रहा था, ये गाना थोड़ा सा जॉली, थोड़ा ज्यादा सेंटिमेंटल है। उन लोगों के लिए है जिन्होंने जीनेक में अपना जीवन बिताया है और उनके जीवन का हिस्सा है ये। उम्मीद है कि आपको अच्छा लगेगा ये। जीना यहाँ मरना यहाँ, इसके सिवा जाना कहाँ। जीना यहाँ मरना यहाँ, इसके सिवा जाना कहाँ। जी चाहे जब हमको आवाज दो, हम हैं वहीं हम थे जहाँ, अपने यहीं दोनों जहाँ, इसके सिवा जाना कहाँ। आगे की जो लाइन है वो उन लोगों के लिए है जिन्होंने जीने को इतना कुछ दिया है। आपने हमें इतना कुछ सिखाया है, इतने यादगार पल बिताए हैं। और जीने एक बिल्डिंग नहीं है, एक हॉस्पिटल नहीं है, एक जीव है, जीवित है, और ये चलता रहेगा। ये मेरा गीत जीवन संगीत कल भी कोई दोहराएगा, ये आपका गीत जीवन संगीत कल भी कोई दोहराएगा, जग को हंसाने बहुरूपिया रूप बदल फिर आएगा। स्वर्ग यहीं नरक यहाँ, इसके सिवा जाना कहाँ। जी चाहे जब हमको आवाज दो, हम हैं वहीं हम थे जहाँ, अपने यहीं दोनों जहाँ, इसके सिवा जाना कहाँ। आगे की जो कुछ लाइनें हैं वो हम सबके लिए हैं। हम आज यहाँ हैं इस वक्त, कल शायद नहीं होंगे, कल हो, आई होप कि होंगे। कल खेल में हम हो न हो, गर्दिश में तारे रहेंगे सदा। कल खेल में हम हो न हो, गर्दिश में तारे रहेंगे सदा। भूलोगे तुम भूलेंगे वो, पर हम तुम्हारे रहेंगे सदा। रहेंगे यहीं अपने निशान, इसके सिवा जाना कहाँ। जी चाहे जब हमको आवाज दो, हम हैं वहीं हम थे जहाँ, अपने यहीं दोनों जहाँ, इसके सिवा जाना कहाँ। जीना यहाँ मरना यहाँ, इसके सिवा जाना कहाँ। थैंक यू so much for being here. Thank you.
Well, Dr. Sanat did definitely made me a little bit teary-eyed. I would like to call upon stage Dr. Gahan and Dr. Ashi. I assisted Dr. Gahan in his second ECC yesterday, and I must say he's gonna go ahead and become a really good surgeon. Ever excited to call patients for PKs? I invite Dr. Gahan and Dr. Ashi on stage. Please give them a big round of applause.
नमस्ते डॉक्टर साहब। नमस्ते डॉक्टर साहब।
नमस्ते।
याद हो डॉक्टर साहब, परसों आई थी मैं।
हाँ याद है, बताओ दिक्कत क्या है?
डॉक्टर साहब जो आपने हरा गोली दी थी उससे बिल्कुल आराम नहीं मिला डॉक्टर साहब।
अच्छा, अपने ओपीडी के पर्चे दिखाओ।
पूरा सर दर्द आ रहा है डॉक्टर साहब, मेरे घुटनों पे दर्द है डॉक्टर साहब, मुझे क्या करना है समझ नहीं आ रहा डॉक्टर साहब। देखिए डॉक्टर साहब प्लीज डॉक्टर साहब।
अच्छा, पुराने ओपीडी के पर्चे दिखाओ।
मैं तो पढ़ी लिखी नहीं डॉक्टर साहब, पर इसमें सारे हैं डॉक्टर साहब। क्या होगी डॉक्टर साहब? डॉक्टर साहब डॉक्टर साहब,
ये तो तुम्हारा आधार कार्ड है, ये पेंशन का पर्चा, ये घर का एड्रेस।
डॉक्टर साहब सब कुछ
ये तो डेथ सर्टिफिकेट है किसी का। अरे अम्मा आँख का पर्चा दिखाओ।
मेरे पति मर गए डॉक्टर साहब, ये लीजिए डॉक्टर साहब, इसमें होगा डॉक्टर साहब।
अरे ये तो अर्बन के पर्चे है, ये तो दिल का पर्चा है, ये तो घुटनों का पर्चा है, ये दिमाग का पर्चा है,
डॉक्टर साहब
ये फेफड़ों का पर्चा है। अरे मुझे आँख का पर्चा दिखाओ अम्मा।
डॉक्टर साहब मैं पढ़ी लिखी नहीं डॉक्टर साहब।
अच्छा अच्छा ठीक है ठीक है। दिक्कत क्या है तुम्हें? दिक्कत क्या है?
आँख में बहुत दर्द होता है डॉक्टर साहब, पूरा धुंधला दिखता है डॉक्टर साहब, क्योंकि मुझे कुछ नहीं।
अच्छा कब से? कितना कम दिख रहा है तुम्हें?
मैं हो गया डॉक्टर साहब, बहुत समय करना के पहले आया था डॉक्टर साहब में।
अभी तो तुमने बोला परसों से कम दिख रहा है।
डॉक्टर साहब परसों करना के पहले आया था डॉक्टर साहब में।
अच्छा ठीक है, कितना कम दिख रहा है?
डॉक्टर साहब बहुत कम दिख रहे हैं डॉक्टर साहब। परसों रात को मेरे पति के अलावा मैंने पति सोच के मेरे पड़ोस के साथ चला गया डॉक्टर साहब। बहुत कम दिख रहे हैं डॉक्टर साहब मुझे। देख लीजिए
अरे
डॉक्टर साहब।
अम्मा चलो बैठो,
डॉक्टर,
तुम्हारी
प्लीज।
कुछ जांचें करते हैं। बैठो
डॉक्टर साहब
बैठो
ठीक
बैठो
है
अम्मा।
डॉक्टर साहब, ठीक।
अच्छा ये बताओ ये किधर को खुल रहा है?
पूरा फ्रेश दिख रहा है डॉक्टर साहब, बहुत दिख रहा है डॉक्टर साहब, पूरा फ्रेश है
अम्मा
डॉक्टर साहब।
बेबी, तुम्हारा नाम बेबी है ना?
हम में बेबी
ये तीन धारियां किधर को खुल रही हैं?
वही डॉक्टर साहब, वही फ्रेश दिख रहा है डॉक्टर साहब। मैं पढ़ी लिखी नहीं डॉक्टर साहब, आप ऐसे क्यों मजाक उड़ा रहे हैं डॉक्टर साहब?
ऊपर नीचे दाएं बाएं किधर को खुल रहा है? जल्दी बताओ।
वही डॉक्टर साहब, वही
मेरे पे इतना टाइम नहीं है।
दिख रहा है डॉक्टर साहब, सब फ्रेश दिख रहा है डॉक्टर
अच्छा
साहब।
तुम्हारी दूसरी जांच करती हूँ, बैठो।
ठीक है डॉक्टर साहब।
अपना यहाँ ठुड्डी माथा लगाओ।
रख रहा हूँ डॉक्टर साहब, रख रहा हूँ डॉक्टर साहब। डॉक्टर
राहुल
भैया
राहुल कितने
सबको देखने से भैया।
राहुल बाहर कितने ही पर्चे बचे?
मैम अभी तो 90 हैं, 21 नंबर की ओपीडी तो खत्म भी होगी मैम, जल्दी करो।
डॉक्टर साहब मुझे भी देख लीजिए डॉक्टर
अम्मा
साहब।
तुम मेरा बहुत टाइम लगा रही हो।
डॉक्टर साहब
अच्छा अम्मा अब तुम्हारी आंखों की प्रेशर की जांच होगी।
ठीक है
लेटो।
डॉक्टर साहब, ठीक है डॉक्टर साहब। लेटना है डॉक्टर साहब?
लेटो।
डॉक्टर साहब डर लग रहा है डॉक्टर साहब। डॉक्टर साहब
हम कुछ नहीं कर रहे हैं, लेटो।
डॉक्टर साहब ठीक है डॉक्टर साहब।
चश्मा उतारो।
ठीक है डॉक्टर साहब, चश्मे के बिना नहीं दिखता डॉक्टर साहब, चश्मे के साथ बिल्कुल फ्रेश दिखता है डॉक्टर साहब। ऐसे ड्रॉप्स लिख दीजिए कि चश्मे के बिना दिखता है डॉक्टर साहब।
अच्छा ठीक है
डॉक्टर साहब
अंगूठा उठाओ अपना।
पैर का? ठीक है डॉक्टर साहब, ये लीजिए डॉक्टर साहब। डॉक्टर साहब
राहुल इनके पैर पकड़ो
भैया
जाकर।
देख लीजिए डॉक्टर साहब।
राहुल इनके पैर पकड़ो।
हाँ ठीक है डॉक्टर साहब, उठा
आपकी जांच करवाने आई हो पैर की।
आँख की डॉक्टर साहब देखें।
अंगूठा सीधा देखना एकदम अंगूठे
देख
को।
रहे हो डॉक्टर साहब, देख रहे हो डॉक्टर साहब। डॉक्टर साहब
अंगूठे को देखो अम्मा।
ठीक है डॉक्टर साहब,
वरना हम
देख रहे हो।
जांच नहीं करेंगे।
देख रहे हो डॉक्टर साहब। डॉक्टर साहब क्या लग रहा है डॉक्टर साहब?
अरे अभी तो बस दवा डाली, अभी तो जांच की भी नहीं है।
डॉक्टर साहब मुझे दवाई लिख दीजिए डॉक्टर साहब, ये मत दीजिए डॉक्टर साहब, ये सब बंद कीजिए डॉक्टर
अच्छा अम्मा मैंने तुम्हारा देख लिया है मोतिया।
डॉक्टर साहब हंस क्यों रहे हैं डॉक्टर साहब? मैं पढ़ी लिखी नहीं डॉक्टर साहब, मजाक नहीं उड़ा रहा डॉक्टर साहब, देख लीजिए डॉक्टर साहब।
मैंने तुम्हारा मोतिया देख लिया है। तो
डॉक्टर
कुछ
साहब दर्द
दवाई
भी होता है
लिख-
डॉक्टर साहब, इतना दर्द होता है कि आँख निकाल के अलमारी में लग के लॉक कर दो डॉक्टर साहब।
अरे ऐसे नहीं करना होता, अगर चाबी घूम गई तो।
डॉक्टर ऐसे जोक्स मत अड़ाए डॉक्टर साहब, सीरियस हो रहे डॉक्टर साहब, प्लीज डॉक्टर साहब।
अच्छा अम्मा सुनो, अब मैं तुम्हें कुछ दवाइयाँ लिख रही हूँ। 10
है,
दिन
डॉक्टर
बाद ये ड्रॉप डाल के मेरे पास आना है, ठीक है?
ठीक है डॉक्टर साहब, मैं पड़ोसी में एक बच्चा है उसको भी पानी आता है, ड्रॉप डाल दो डॉक्टर साहब उनको।
हाँ हाँ जाके पूरे मोहल्ले में डाल दो, ठीक है?
क्या बोल रहे डॉक्टर, एक ड्रॉप दे के पूरे मोहल्ले बोल रहे हैं, ज्यादा दे दीजिए डॉक्टर साहब, डाल दूंगा डॉक्टर साहब।
अच्छा सुनो राहुल कितने पर्चे बचे हैं?
70 और बचे हैं
डॉक्टर
मैम,
साहब।
डायलेटेड मत देखो ना आज प्लीज।
ठीक है राहुल चलो सुनो।
डॉक्टर साहब
अब हम तुम्हें अगली बार 10 दिन बाद देखेंगे, ठीक है अम्मा?
सर मोतियाबिंद का ऑपरेशन कब होगा डॉक्टर साहब?
10 दिन बाद हम कुछ जांचें करेंगे, उसके बाद मोतिया का ऑपरेशन कर देंगे।
उसके बाद हमको कितने दिन तक सर पे नहीं नहाना डॉक्टर साहब?
तुम नहा सकते हो, ऐसा कोई दिक्कत नहीं है।
ठीक है डॉक्टर साहब, फिर से कब आना है डॉक्टर साहब?
अब हम 10 दिन बाद बोला ना, तुम्हें देखेंगे।
ठीक है डॉक्टर साहब, आपको जल्दी शादी हो कि जल्दी बच्चे होने डॉक्टर साहब, उनको भी डॉक्टर बना दीजिए डॉक्टर साहब।
अरे मैं तो शादीशुदा हूँ।
फिर से कर लीजिए डॉक्टर साहब, ज्यादा डॉक्टर चाहिए डॉक्टर साहब।
अम्मा राहुल इनको बाहर लेके
डॉक्टर
जाओ।
साहब थैंक यू,
इनको बाहर लेके जाओ।
डॉक्टर साहब थैंक यू डॉक्टर साहब। ठीक है अम्मा, ठीक है अम्मा, ठीक है।
This small skit was dedicated to all the ammas out there who make this place a little more live, a little more warm, and a lot more humorous. To all the ammas out there.
Three cheers for all the ammas out there. No wonder Gahan's OPD doesn't get over on time. Well, Dr. Nandita doesn't require any introduction. I'll let her grace and dance speak for herself. Well, Nandita, you are a treat to watch. Welcoming back for our last performance, Dr. Ayush and Dr. Sanat, their dashing duo. I request everyone to be on the edge of the seat and be ready for some participation and fun.
Hello, hello, check, check. Hello, hello, hello.
Sound symmetrical. Hello.
Hello, hello.
Hello, hello, check.
Hello, hello, hello.
हे, क्या तुमने कभी किसी से प्यार किया?
किया।
क्या कभी किसी को दिल दिया?
दिया।
मैंने भी दिया।
ला 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 ला
ला ला ला ला ला ला ला ला।
मेरी उम्र के नौजवानों, दिल ना लगाना ओ दीवानों।
मेरी उम्र के नौजवानों, दिल ना लगाना ओ दीवानों।
मैंने प्यार करके चैन खोया, नींद खोई।
पर झूठ तो कहते नहीं है, कहते नहीं है लोग कोई।
है प्यार से बढ़कर नहीं है, बढ़कर नहीं है रोक कोई।
चलता नहीं है दिल दे के यारों इस दिल पे जोर कोई।
चलता नहीं है दिल दे के यारों इस दिल पे जोर कोई।
इस रोग का नहीं है इलाज दुनिया में और कोई। तो गाओ ओ शांति ओ शांति शांति ओ ओम शांति ओम शांति शांति ओ।
मैंने किसी को दिल दे के कर ली रातें खराब देखो।
मैंने किसी को दिल दे के कर ली रातें खराब देखो।
आया नहीं उधर उधर से,
आया नहीं अभी तक उधर से कोई जवाब देखो। वो ना कहेंगे तो खुदकुशी भी कर जाऊंगा मैं यारों।
वो ना कहेंगे तो खुदकुशी भी कर जाऊंगा मैं यारों।
वो हाँ कहेंगे तो भी खुशी से मर जाऊंगा मैं यारों। तो गाओ ओम शांति ओम शांति शांति ओम शांति ओम शांति शांति ओम। Jump, jump, jump. Come on, people. Get up on your feet. Come on, how are you sitting here? Come on, people. Come on. Come on. Come on.
जो चुप गया है पहली नजर का पहला सलाम ले गए।
जो छुप गया है पहली नजर का पहला सलाम लेकर।
हर एक सांस लेता हूँ अब मैं उसका ही नाम लेकर, उसका ही नाम लेकर।
मेरे हजारों दीवाने अब मैं खुद बन गया दीवाना।
मेरे हजारों दीवाने अब मैं खुद बन गया दीवाना।
ये वक्त तुम पे आ जाए प्यार में तो ये गीत गाना।
सिंग
ओ शांति ओ शांति शांति ओ ओम शांति ओ शांति शांति ओ। मेरी उम्र के नौजवानों दिल न लगाना ओ दीवानों। मैंने प्यार करके चैन खोया नींद खोई।
अरे झूठ तो कहते नहीं है, कहते नहीं है लोग कोई।
हे प्यार से बढ़कर नहीं है, बढ़कर नहीं है रोक कोई।
चलता नहीं है दिल दे के यारो इस दिल पे जोर कोई।
इस रोग का नहीं है इलाज दुनिया में और कोई।
तो गाओ ओ
turned up. So please do the cake ceremony. And Dr. Gurbaksh Singh, sir, if you could just help. Thank you, sir, so much. Dr. Subhash. I can't touch that.
So vote of thank में क्या है मैम? Thank you everyone. है? सबका नाम लेके बोलूं? चलो जी, as directed by director. So, dear all, at the outset, I would like to thank first of all our surgeons who performed surgery. I would like to thank Dr. Santosh Honawar. Thank you very much, sir, for accepting our invitation and doing excellent surgery. Then I would like to thank Dr. Smita Kosik. She has been our resident and she has done wonderful glaucoma surgery. I would like to thank all the OT staff, sisters, nursing orderlies, technicians, and the audiovisual team. Then I would like to thank each and every speaker. I would like to thank Dr. Gupta sir, and many of you will not be knowing that I am here because of Dr. A.K. Gupta sir. There were some notorious elements who does not wanted to me here, but it was Dr. A.K. Gupta sir. Then I would like to thank all the speakers, Dr. Avni, Dr. Gaurav, Dr. Himshikha, Dr. Savleen, Dr. Shruti, Dr. Priya, and Dr. Charu. Then PWD staff, all the staff members, the staff members of the director office, then auditorium staff, Ankur, Nafe, then Joginder, and all the persons who were involved in registration, then purchase branch, and I will be failing in my duty if I don't thank all our residents who have performed wonderfully, and each one of you who is here. And I would like to thank Dr. Bhalla sir, who is there despite of so many works, and all the faculty. And thank you, everybody.
In conclusion, I would like to thank the government of NCR Delhi. Delhi government has sponsored this program, and it was a great initiative by them. So Sucha Sauda of Guru Nanak Dev Ji, which came in so handy for the center. Thank you to our entire faculty who has been the backbone of GNEC always. Our residents, wonderful, wonderful residents, you make everybody proud. Our administrative staff, our ancillary staff, Pankaj, Nafe, OP, everybody team, kitchen team, and the people who have been up till 2 a.m. Ankur, and especially the team behind the GNEC book. Special thanks to Dr. Anu and Sanat and Ayush for being there, constantly editing it, sitting with me at night. And sir, all of you present, if you could send me some more pictures. This book is still incomplete because I lack some pictures. So please promise me that you would send me pictures, not by WhatsApp, but by email. Thank you so much. And we have this cake cutting ceremony, as I said. And the horticulture division for making everything so beautiful.
I think we have all different flavors. You can choose what you like to see and what you like to eat.
क्या लग रहा है?
जो सभी पूरा हो ना नहीं मैम अभी तो लेना
All together. So this the iconic moment, right? ओले चल कोई नहीं इसको बाद में कर लेना सर ओके 1 2 3 ऑलराइट आ गया है उनके पास सर 1 2 3 गो पहले सर blow the candles happy birthday आजा हेल्प कर दे
Thank you, each one of you, for being here today and gracing this auspicious day for us with your presence. I'm Dr. Anu June, Assistant Professor in Glaucoma Services. It was an honor to be your host today, and you've been a lovely audience. Thank you.
Right.